Okay. I hope you are all doing good. Is my voice clear? Am I visible? Okay, I can see that I'm visible. Is my voice clear? If you can clearly hear my voice, I would really appreciate if you give me some thumbs up. And everybody who has come, if they give me thumbs up, then I'll have an idea how many of you are there, and then we can start with our discussion of anesthesia. Wow, wonderful. So a lot of you have turned up for a Diwali weekend class, and this shows the level of commitment that you guys have, which is wonderful. And these are the, the days like these that would give you the strength and the courage to do really good in your exams. Because it's the days like these that will make you feel okay. I'm giving my 100% to this exam, and so I will get a good rank and it will help me achieve something in the future. So before we start the discussion of anesthesia, let me all welcome you to this wonderful morning. The festive season has started, and this is the most difficult time for all of you to study. Some of you must be away from home in hostels or in other cities where you must be working and studying at the same time. Some of you might be at home but would have not really enjoyed the whole process of festivities, not taken part in the cleaning and the lamp lighting and stuff like that. And it would often make you wonder that where my life is going and why am I doing this thing? Like, is there a need to do this thing? Like, is it really necessary? Am I right? This question does crop up in mind once in a while, where you feel that, okay, is this really necessary? Should I be doing this thing? What will I do? Like, all my friends are enjoying, and everything around me is so festive and everybody is smiling, laughing. But you have to understand that this is just a very short term sacrifice that you are making. And this sacrifice that you are making in very, very short term, if you see a few years of Diwali, is going to fulfill your life with the kind of happiness that would be unimaginable. And why I say is unimaginable is because if you pursue what you love in the coming years of your life, and it should not matter that what branch are you talking about, or what field you are talking about, or which college you are talking about, or which institute you are talking about. What I'm meaning is that if you find the real true passion in your life, that means the thing that you love the most or you adore the most is the thing that you do as a profession. There is nothing better than that. And once you start doing the thing that you are very passionate about, your life just becomes a very extended and a long vacation. Because usually, we work, we don't like our work, and whenever we want to relax, then we take a break and go on a vacation. But imagine if vacation is the work that you do, how cool that life would be. Like, your work and your vacation do not have two different meanings. And that is why you are sitting here today on the Diwali weekend, 2 days after Diwali, and you are concentrating with 100% of your effort to understand and learn something, and then move forward from here to achieve your ultimate goal in life, that is finding your true passion. It could be anything. Somebody would want to become a surgeon, somebody would want to become a physician, somebody would become an anesthetist, some pathologist, some microbiologist. Doesn't matter which field you are going to take. What matters is that you ultimately find that one chi, that is what we call them, chi, the one thing that will make you get up from your bed every morning. So whenever you are doing these long hours of classes and you are studying so much and you are sitting in your room quietly or in your library and there is nobody around, and it happens usually, people who are night dwellers, they experience this thing somewhere between 1 to 3 in the morning when 90% of library is empty, and they look left, nobody is there, they look right, nobody is there, up front there is nobody, there's probably 2 people in the whole of library. And you are concentrating on the book, you're trying to read a concept and remember it, and you realize that this is not worth, like, why the hell am I doing? All my friends are sleeping, some of them have now married, and some of them have gone to US and UK and they are doing party and stuff like that, and that makes you feel very small in life. But remember, they do not have a purpose like you do. When you talk to your engineering friend or an MBA friend, they have their work life, which is 5 days a week, and then they have their weekend, which is the truth. So they live only over weekends. But a doctor lives every single minute of their life. They enjoy every single minute of their life because their work is their everything. I'll give you an example. I'm a freelance anesthetist and a teacher, and it's a brutal job. Freelance anesthetist is not an easy job. You are always on work and you are never on work, because I don't have any particular timings, because I don't particularly give a time to the hospital. Okay, I'll come from 9 to 1 or 9 to 2 in your hospital. Wherever there's a case, they call me. And of course, that means that you do not have, whenever you want to try and do something, the moment you get ready and you're leaving for, say, a family dinner or meeting your friend, there'll be a call. Okay, sir, there's an LSCS emergency. We need you. You have to leave everything and go. Sometimes you leave your family for dinner and then you go. But the joy that you get when there's an emergency LSCS, you have taken the patient, you induce anesthesia, the baby comes out, the baby is saved, the joy, that itself is so overwhelming that at the end of the day, you feel that, okay, it's all worth it. What happened? Out of the 1000 meals that I'm going to have with my family over the years, if I skip 1 hour of one meal, doesn't matter. What is important is I'm fulfilling the purpose, my purpose in this life, and that is what makes me happy. So the idea of telling you this thing at the start is that I know that these classes are long. I know that you are all very, very apprehensive, in a state of heightened anxiety all the time, especially last week when your examination board has released the tentative date of exam, and now you know that there is a possibility that within 6 months we might have another exam. That obviously makes you feel very, very anxious from within. What will happen? You start thinking of the future and you think that if I fail, then my future is ruined and stuff like that. Nothing of that sort should come to your mind. If you keep your goal very simple, and the simplest goal is to be better than yesterday. Simple. To be better than yesterday. Yesterday, you did, say, 4 hours of studies. Today, you will do 4 hours, 10 minutes of studies. That's it. It's as small as 10 minutes, as small as 10 minutes more. Tomorrow, you will do 4 hours, 15 minutes. Day after tomorrow, 4 hours, 17 minutes. But the idea is to just become better than yesterday. If yesterday I did 50 MCQs, today I'll do 51 MCQs. If yesterday I tried to deal with 10 concepts, today I'll try to deal with 11 concepts. So the idea is that we do not think in terms of how long we are going to run and how broad the life perspective has to be. All you have to think is what you are going to do the next moment, the next hour, the next day. That's it. Because trust me, you cannot control anything beyond that. You can't even control tomorrow, but then at least you can control what you're going to do tomorrow. You're not going to control anything beyond that. So this sense of power that you feel that you have over your future, just because you think that your thinking would make a difference, is just futile. Rather than making your mind so in a state of entropy where everything is just haphazardly moving, contain it. Concentrate all your energy on just the next step. It's like how you see a kid who has just started to walk. Like I see my kid, she's 1 year old. And now that she has started to walk, I see that it doesn't really matter to her what is going around her in the room. How many people are there, what they are doing. Her whole idea is to concentrate on putting the next step so that she doesn't fall. And then she falls. She doesn't really bother. She gets up. Again tries, again falls, again tries, again falls. And then after 15, 20 times, you keep on seeing them that they keep on trying, falling, trying, falling, trying, falling. There'll be one step that they would succeed. And they become so happy, they clap and they laugh. And because they clap and they laugh, they again fall. Again they try, get up and try and do the same thing. So this is something that you can learn from our kids, like, from the kids that are around you, that they're simple. They are simple. If you keep your life simple, then everything else will fall in place, right? So we are going to discuss a lot of what I say soft skills that are required for you to prepare for this exam. You have lot of motivation already there. We have exemplary teachers. They are all my teachers as well. They will give you a lot of motivation, lot of pep talks, and you would obviously feel very motivated when you talk to them. You listen to their podcast, and then you see their posts and everything. But ultimately, I feel the motivation has to come from within. If you are motivated internally to do better, then all of this will help you move forward. And if you are not motivated within, all these are just empty words. So idea is to get motivated yourself and to try and do things in a better way every single day. So it's small step, but every day you try to be near to your goal, right? So with this, we'll start our discussion of anesthesia, which will span over 2 days, today and tomorrow. It's going to be a very chilled out session. You would not feel that you are reading something very, very difficult. It's one of the easiest subjects that you will deal with in terms of your preparation out of 19 subjects. Now, just to give you an overview into what exactly anesthesia would ask from you. So anesthesia usually in a 200 question paper, it will give you 4 to 6 questions. And if you have read anesthesia 2 times, then you will score 90 to 100% in this. That is the level of efficiency that anesthesia gives you, which is something which is wonderful. Okay. Okay, so yeah, so the video sometimes freezes because of the network issues that keep on happening. If it is troubling you too much, you will let me know, and then I can probably switch it on to, rather than picture in picture, where you can see me in front of the background of the screen, we would probably put it sideways, then it fluctuates less. Let me know if it is a concern for you. Okay. So this is what we are targeting, and what happens is that usually when we say that okay, 200 question paper and 4 to 6 questions, we tend to think, yeah, this is not such an important subject, like it's only 4 questions. But you have to understand that it's all about input output ratio, and this is efficiency, how much you have put in and how much comes out of it. So for any subject, let's say you consider medicine as the most important subject. How much effort do you put in medicine? So if you consider all the systems together, 2 days, then you read medicine in classes for 8 to 10 days, which eventually takes you to complete at least 20 days. And the number of questions that come out of it is 35 questions. And no matter you are the best physician in the world, you know everything in medicine, still you'll be able to solve 25 of them correct, 10 would be wrong or new question, something that you have not heard of or not read. Okay. But if you consider something like anesthesia, forensic, psyche, radio, derma, ortho, the ones that we call short subjects, although they are not short in any sense, but you give 2 to 3 days in class and you get on average 4 to 9 questions with 90% efficiency, that if you have read the topic, then you will be marking 4 out of 4 or 9 out of 9. So if you see combinedly, you would put say 20 to 25 days in these subjects. And combinedly, if you see 1, 2, 3, 4, 5, 6, and if you take an average of 6 questions, then you will get 36 questions from these. And if you have done them well, then you will be able to mark 34 of them correct. Now tell me, are these subjects really short, and do these subjects require your less attention? No. If you combine all these subjects, then they are giving you a higher ratio of correct answers. So I don't say that you should not read medicine. Of course, you should read medicine. Without medicine, it is difficult to clear an exam like NEET. But what you have to understand is that these are the questions which are going to give you very good ranks, because these questions will improve your efficiency in the exam. Ultimately, your goal is that out of 200 questions, you need to mark 140 to 150 correct. That is your target. So these 60 questions which you will be marking wrong or not marking at all will come from subjects which are difficult, subjects like medicine, surgery, pediatrics, PSM. But the subjects which are easy, like anesthesia, forensics, psyche, radioderma, these subjects will not make you do mistakes. And so your number of wrong questions will not come from these subjects, and it will add to the number of right questions. And that is your ultimate goal. Your ultimate goal is to score 140 to 150 marks, right? So keeping this thing in mind, let's start the discussion of anesthesia, which will span over 2 days. And you can see I'm Dr. Anshul Divakar and not Ralph, as you can see in the picture. And we are going to discuss the nuances of anesthesia. We are going to discuss the nuances of anesthesia over the course of next 2 days, right? So you know already a kind of anesthesia that you are very, very well versed with, which is, yes, lectures. Something that you go through every single day. What you feel through a lecture is exactly how somebody would feel through anesthesia. That is, the eyes start closing, your response to things becomes slow and sluggish, and eventually you don't remember anything and the time just passes, right? So what you feel during a lecture is exactly what somebody would feel during anesthesia. So this is one form of anesthesia that you are very well aware of. The other two forms is something that I'm going to discuss, which is general and local anesthesia. General is the anesthesia of the brain, which is CNS. And local anesthesia is at the site of injection. At the site of injection. These are two basic forms of anesthesia, general and local. We'll start the discussion with general anesthesia, and major portion of our discussion is with general anesthesia. We will divide our lecture into 4 categories. First, we'll discuss general anesthesia, followed by anesthesia delivery systems, then a note on regional anesthesia, and finally on CPR, which is now a part of the anesthetist domain. All right. What is general anesthesia? So general anesthesia is a set of steps. This is the part from where you start writing. Okay. General anesthesia is just a set of steps. And when it is done, then you induce the patient and keep him in a state of completely unaware of what is happening with him. This is called as anesthesia. It starts with pre-operative assessment and preparation, followed by monitoring, followed by induction of anesthesia, which is the start of anesthesia, followed by a step called as bag and mask ventilation, BMV, followed by intubation, for which you require muscle relaxants, followed by maintenance phase of anesthesia, which is done through inhaled anesthetic agents, followed by reversal of the muscle relaxants and the step of neuromuscular monitoring, and finally extubation and post-operative care. So I would like you all to write these steps, because our whole discussion will be based on these steps. And just like how we perform anesthesia in the OT, we are going to discuss every step one by one. So what it does is it creates a flow of the things that are being done in the theater on the patient in the exact same way we are going to discuss it in our notes. So when you start reading your notes from page 1 till the page 110, that is the number of pages that you are going to write, then it's like going through the whole journey of general anesthesia, right? How many of you have seen induction of general anesthesia in the theater? I'll come in a minute, just a second. How many of you have seen induction of general anesthesia? I'm presuming not many, because anesthesia is not something that is taught very well in the MBBS. Also, most of the time in internship, you skip the anesthesia posting to make a vacation for 10-15 days, go home or go to Goa or something like that. So just to give you an overview, I have recorded this video. This is general anesthesia, right? The whole process, and this will give you a fairly good idea as to what we do, the steps, right? So let's start with pre-operative preparation. You can see in this phase, I am preparing the OT. I'm keeping all the airway equipments, tubes. I'm attaching the monitors to the patient, right? So I'm going to do all of these things in pre-operative preparation, followed by IC. This is the step called as pre-oxygenation, whereby I'm giving 100% oxygen to a spontaneously breathing patient. You can see the bag of the machine is moving, the bag on the anesthesia machine, and the patient is awake, breathing on her own. And then I start pre-medication. I start pre-medication. I start pre-medication. Yes, Shubhangi, NM means neuromuscular. See, the patient is still awake. She's breathing spontaneously. I'm constantly talking to the patient, and now I start induction, right? So I am inducing the patient. The patient is slowly going into the state of sleep, that is unconsciousness. You can see in the background the monitor. Right? As the whole drug goes in, you can see now the patient is no more conscious. The patient is not responding to verbal commands. And now I'll check for bag and mask ventilation. I will check for bag and mask ventilation. As soon as I can confirm the bag and mask ventilation, I'll give the muscle relaxant in the form of scoline. Muscle relaxant in the form of scoline. And you can see fasciculations, which is a very distinctive feature of scoline. And then I'll do a direct laryngoscopy and intubation, that is to secure the endotracheal tube. So this is direct laryngoscopy with endotracheal intubation. And then I will check the position of the tube after. Yeah, so I've started the ventilator. Now I'm giving the carrier gases along with inhaled anesthetic agents, and now I'll fix the endotracheal tube and then check the position of the endotracheal tube. Check the position of endotracheal tube. Yeah, little bit is getting stuck, but I think you are getting the gist of it, right? So this is how I induce general anesthesia, and with these steps in mind, we can now start the discussion of general anesthesia. And the first step is pre-operative assessment and preparation. Pre-operative assessment and preparation. So let's start with the first step. which is pre-operative assessment and preparation, and we divide this step into three parts: assessment, preparation, pre-medication. Assessment, preparation, pre-medication. Assessment, preparation, and pre-medication. So what do? We start with airway assessment and we do risk assessment before surgery. In preparation, we prepare the patient's pre-operative drug therapy. And then pre-medication, that is all the drugs given before the start of induction. All the drugs given before the start of induction. All the drugs given before the start of induction. So let's start with the first topic, that is airway assessment. And can anybody tell me, why do you feel the need? So airway assessment, because airway handling is a very, very important part of the anesthesia induction. As you saw, we need to secure the airway. And if we fail to do this step, then the patient would be apneic and without airway. And so there would be risk of hypoxic brain damage. That is why it is an important step before surgery. Risk of hypoxic brain damage. Yes, Sabita, difficult intubation is always a risk. But most important thing is that, yes, if it is difficult, then ultimately the problem that happens is hypoxic brain damage, which is a direct iatrogenic complication of anesthesia, direct iatrogenic complication of anesthesia, and you want to avoid that complication, and that is why you would want to avoid a difficult airway, right? Now there are two things in airway assessment. The first step is predictors of difficult bag and mask ventilation. Predictors of difficult bag and mask ventilation. You saw in the video and in the steps as well that first before we actually go on to do a direct laryngoscopy, we first do a bag and mask ventilation. So you need to know all the predictors of difficult bag and mask ventilation. All the predictors of difficult bag and mask ventilation. Right? This is how a bag and a mask ventilation looks like. You hold the mask, face mask, snugly on the face of the patient, and you use the bag of the anesthesia machine or an ambu bag to do positive pressure ventilation. The factors that predict difficult bag and mask ventilation can be remembered by a mnemonic called as obese, which is an obese individual with BMI more than 30, one who is bearded, edentulous, that is no teeth, history of snoring. Do you know which disease has snoring as a very important component? Which disease has snoring as a very important component? Yes, history of obstructive sleep apnea. History of obstructive sleep apnea and elderly. That is when age is more than 55 years. These are predictors of difficult bag and mask ventilation. These are predictors of difficult bag and mask ventilation. Predictors of difficult bag and mask ventilation. Predictors of difficult bag and mask ventilation. Yes, very good. When you find one or more than one of these in an individual, then you can have a prediction that, okay, bag and mask ventilation is going to be difficult. Edentulous means no teeth. Individual with no teeth. Individual with no teeth. Individuals with no teeth, right? So the first step is predictors of difficult bag and mask ventilation. What would be the next step? The next step would be airway assessment, that is predictors of difficult intubation. Predictors of difficult intubation that can be remembered by this mnemonic called as lemon. 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 This is a mnemonic as well as a set of steps that you need to do in a patient to assess the airway. It starts with looking externally at the patient. Looking externally, looking for obvious signs. Why teeth? Why beard is a risk factor? You can see here. This is how you hold the mask on the face. Now tell me, if there is beard all around, would the sealing of mask would be proper? Would mask sealing be proper? Have you seen a Punjabi guy, Babaji Punjabi, one who doesn't cut his beard? Huge long beard. Now imagine that you have to do a bag and mask ventilation. Would it be easy? The mask would not just form a seal because there's so much of hair. Also, you won't be able to hold the mask properly because even the jaw has, everything has hair. So hair becomes a big risk factor for difficult bag and mask ventilation. Alright, so let's come back. What we are going to do is, as a rule, we are going to wait till the end of the topic to ask doubts. Doubts at the end of topic. I will tell you now, you can ask doubts, and you can only ask doubts then. It would not affect the flow of the class. And at break, that is when I take a break, then I'll again wait for 2 minutes for you to ask doubts. Okay. So these are the 2 times when we'll keep the doubts. And this will not affect the flow of the class because I'll go to a topic, because you know that there's a lag of 1.5 minutes between what you see and what I am there, right? So whenever you ask me a doubt, I've already moved ahead 1.5 minutes. So you would feel, okay, I asked the doubt, but still sir is still teaching the topic, but actually I see it later on only. Okay. So we'll keep a very designated time for doubts where I'll wait for 2 minutes, then you can ask all your doubts and then we'll discuss it and then move ahead. Okay. So let's start with airway assessment. And the second airway assessment is predictors of difficult intubation or difficult airway that can be remembered by mnemonic, lemon, which is looking externally at the patient, looking externally at the patient. When you look externally at the patient, then you see certain obvious signs of difficult airway, that is facial trauma, large incisors, beard, mustache, large tongue, high arched palate. When the palate is very arched, then the angle is steep and so the tube doesn't get negotiated. So what happens is, because the palate is very high arched, so your blade of the laryngoscope goes deep in it, and while you are trying to pass the tube, the angulation is so steep that the tube doesn't get negotiated in the vocal cords. Okay. Shubhangi, if it is hanging now, then you might have to check your internet. Because now from my end it would not hang, because this arrangement is a stable arrangement. In this there is no hang. That picture in picture, sometimes it does create problem. So that is why I stopped it within 10 minutes, because I realized on my own video that it is hanging a lot. But now it would be probably some network issue at your end. So you can wait for some time, it will get okay again. Okay. Next E is evaluating the rule of 332. Next is E, that is evaluating the rule of 332. Evaluating the rule of 332. We'll discuss that. Next is M, Malampatti, and a Malampatti score of more than or equal to 3 more than or equal to 3 is considered to be a difficult airway. A Mallampati score of more than or equal to 3 is considered to be a difficult airway. Then look for signs of obstruction. That is obstruction to putting the endotracheal tube. So everything that has to do with the laryngeal part where the tube has to eventually go. Epiglottitis, peritonsillar abscess trauma. Epiglottitis, peritonsillar abscess trauma. And finally N, which is neck mobility, and a limited neck mobility is considered to be a difficult airway. A limited neck mobility is considered to be a difficult airway. A limited neck mobility is considered to be a difficult airway. Limited neck mobility is considered to be a difficult airway. All right. Now let's start discussing with the individual points. Let's discuss evaluating 332 rule. Evaluating 332. So these are certain distances that you have to evaluate. They are called 332. The first distance is mouth opening or interincisor gap. Mouth opening or interincisor gap. Now why do you think mouth opening would act as a predictor of difficult airway? Why do you think mouth opening would act as a predictor of difficult airway? Is there a reason why mouth opening should be considered as a predictor of difficult airway? Yes, because it is required for laryngoscopy, direct laryngoscopy. So if you have a restricted mouth opening, then the laryngoscopy automatically becomes difficult. So mouth opening, an adequate mouth opening is considered to be more than 3 finger breadths. FB, more than 3 finger breadths. You call it abnormal or restricted mouth opening when you have less than 2 finger breadths. Less than 2 finger breadths. Less than 2 finger breadths. Similarly, hyomental distance. Hyomental distance. That is the distance between chin, that is mentum, and hyoid bone. Normally has to be more than 3 finger breadths. And thyrohyoid distance, distance between hyoid and thyroid, normally has to be more than 2 finger breadths. That is why it is called as rule of 332. That is why it is called as rule of 332. 332. Apart from this, we have 2 more distances. But before that, let's try and understand what is the significance of these 3 distances. Mouth opening is required to access airway and obtain glottic view. We understand that. For direct laryngoscopy, you need mouth opening. If mouth opening is restricted, say a patient of submucous fibrosis that you very often see in ENT OPD. So let's say something like this. Half a finger or 1 finger mouth opening. Would you be able to insert the laryngoscope? And if you are not able to insert the laryngoscope, then would you be able to do a proper laryngoscopy? No. So it automatically becomes a difficult airway. This is hyomental distance. It will tell you how large is the tongue. How large is the tongue. So larger the tongue, smaller is the hyomental distance, more difficult it is to deviate the tongue in laryngoscopy. And this thyrohyoid distances predicts the location of the larynx. If larynx is high, that is anterior, then laryngoscopy automatically becomes difficult. Larynx is high, then laryngoscopy becomes difficult. This is just to understand what these distances mean. Next two distances are very, very important for our exam. That is thyromental distance and sternomental. Thyromental is the distance between thyroid cartilage and chin. Distance between thyroid cartilage and chin, also called as Patil's test. Also called as Patil's test. Normally, this has to be more than 6.5 centimeters. Normally, this has to be more than 6.5 centimeters. If it is less than 6 centimeters, then it is considered to be abnormal. If it is less than 6 centimeters, then it is considered to be abnormal. Sternomental distance, on the other hand, is the distance between chin and manubrium sterni. Chin and manubrium sterni. This is also called as Sava's test. Sava's test. And normally it is more than 12.5 centimeters. Normally it is more than 12.5 centimeters. Now all these are tests, right? All these are tests. And every test has a sensitivity or specificity, right? So when you compare these different distances as tests, then you find that the maximum predictive value is with sternomental distance. Maximum predictive value for difficult airway is with sternomental distance. All these are exam questions that have already been asked. All these have already been asked. Right? So these are evaluating 332, and along with that two more distances, that is thyromental distance and sternomental distance. Let's move on to the next topic, which is anatomy of mouth opening for Malam Patti classification. So since you must have done ENT by now, you know this topic very well before I do, more than I do, that all the structures that you can visualize on mouth opening. But when we talk about airway assessment, then we are not concerned with all the other things. We are concerned with the four things that we need to look at. That is the pillars, uvula, soft palate, hard palate. Can be remembered very, very easily with push. Can be remembered very easily with push. Pillar, uvula, soft palate, hard palate. Pillar, uvula, soft palate, hard palate. And when you instruct the patient to open the mouth, so what is Malam Patti classification? It's a classification based on following instructions to the patient. Open the mouth wide, protrude tongue, no phonation. So you tell the patient to open the mouth wide, protrude tongue, but don't let them say ah, no phonation. Open the mouth wide, protrude tongue with no phonation. Open the mouth wide, protrude tongue, no phonation. What do you see? You see structures in the mouth. And based on what you see, there can be four classes, class 1, 2, 3 and 4. There are four classes in Malam Patti, class 1, 2, 3 and 4. Four classes in Malam Patti. Class 1, 2, 3 and 4. What are the four structures that you want to look at? Push, pillar, uvula, soft palate, hard palate. Pillar, uvula, soft palate, hard palate. When you can see all the four structures clearly, then it is Malampatti class 1. When you can see all the four structures clearly, then it is Malampatti class 1. When you can see all the four structures clearly, it is Malampatti class 1. Pillar, uvula, soft palate, hard palate. All the four structures clearly, Malampatti class 1. Now, can you tell me the difference between 1 and 2? What do you observe? What do you guys see? What is the difference between Malampatti 1 and 2? What is the difference between Malampatti 1 and 2? Can you spot the difference? Can you see pillars? Are the pillars visual? Can you visualize the pillars between 1 and 2? Okay, Deepak will come to that. Just concentrate here. Again, I'll go back there and you can complete it. Okay. What do you think is the difference between 1 and 2? Can you visualize the pillars? Yes. But is it a complete pillar? No. So there is a partial view of the pillars. Partial view of the pillars. Can you see uvula? Yes or no? Yes. But what is not visible? Tip of uvula. So tip is missing. You can visualize soft palate and hard palate. You can visualize soft palate and hard palate. Yes, Deepshika. Pillars seen but less. That is partial view of the pillars. Yes, partial pillars. Now in 3, can you see the pillars at all? No. Can you see uvula at all? Can you see uvula at all? No. But there is some part of uvula visible. That is base of uvula. Soft palate, hard palate, soft palate and hard palate. And finally, when only hard palate is visible, that is Malampatti class 4. When only hard palate is visible, then it is Malampatti class 4. Only hard palate is visible, then it is Malampatti class 4. You can complete this and let me know, then I'll put the previous slide. And then we'll come to the interpretation. You can look at these 4 images of Malampatti class 1, 2, 3, 4. And you can probably tell me what do you observe. If you go from 1 to 4, then is there something that you're observing anatomically, something happening anatomically? Something happening anatomically. Something happening anatomically. Can you observe something happening anatomically? Yes, what is happening anatomically? Either the tongue is getting bigger or the oropharynx is becoming smaller, right? So if you want to know what is Malampatti measuring, it measures relative size of the tongue with respect to oropharynx. What do you measure? Relative size of the tongue with respect to oropharynx. Deepak, you can note this table down now, this slide now. So relative size of the tongue with respect to oropharynx. What is it measuring? Malampatti classification measures relative size of the tongue with respect to oropharynx. And can you tell me which Malampatti classes would be easy to intubate and which Malampatti classes would be difficult? Which would be easy to intubate and which would be difficult? Deepak, are you done? Should I change the slide now? We don't talk about Malampatti in pediatric age groups, Jay. This is only for adults. Can you instruct a pediatric patient to open the mouth and protrude the tongue? Is it possible? Would they obey your commands? No. Right? So there only lies the basic difference. Yes, everybody is correct. 1 and 2 are easy. 3 and 4 are difficult. 1 and 2 are easy airways. 3 and 4 are difficult airways. All right. So there are 4 classes in Malampatti 1, 2, 3, 4 based on the 4 structures that you see. What are the names of 4 structures? Push, that is pillar, uvula, hard palate, soft palate, and therefore we have 4 classes. 1 and 2 are easy, 3 and 4 are difficult. Now what is this? I've added one more class, class 0. What all do you see here? Do you see pillars? Yes. Do you see uvula? Yes. Do you see soft palate? Yes. Do you see hard palate? Yes. Then what is different? What is different here? What is different? What is different here? Okay, Naurin, you said tonsillar hypertrophy, but when I described Malampatti to you, did I talk about tonsils and hypertrophy of tonsils? No, no. What are the 4 structures that you were looking at? Push. Was a tonsil anywhere? It was pillar. It was tonsillar pillar, not tonsil. Yes. Everybody seems to be noticing something in the midline, that is epiglottis. So when epiglottis is visible, then it is Malampatti class 0. When epiglottis is visible, it is Malampatti class 0. Malampatti class 0. Does that mean it's going to be an extremely easy airway? Does that mean it's going to be an extremely easy airway? No. This means that there is no correlation to difficulty. No correlation to difficulty. No correlation to difficulty. Right? So this is just a rare finding with no correlation to difficulty. Right? It's just a rare finding with no correlation to difficulty. Remember this thing. Malampatti classification consists of 4 classes, 1, 2, 3 and 4. And these are based on seeing structures, that is push, pillar, uvula, soft palate, hard palate. When you see epiglottis on mouth opening, That is a rare thing to happen, and that could be very well an easy airway, or it could be a difficult airway, or it could be moderately easy, moderately difficult, whatever you want to call it. But you cannot really comment about the ease or difficulty looking at mouth opening and malampatti. So it's a rare thing and it has no correlation with difficulty. Next is structures seen during laryngoscopy. So this malampatti classification was based on what you see pre-operatively. It is not necessarily that it is an enlarged epiglottis. It could be very well a long and floppy epiglottis that would be visible, and that in that case it would be difficult. That is why you can't comment. You might see that there is a big mouth opening, and then you might see that you can see all the structures. You would feel okay, this should be very easy, but it is not a rule. A malampatti class 0 can be a difficult airway as well. That is why I told you it's not a correlation with difficulty. Next, we come to structures that can be seen on direct laryngoscopy. Structures seen on direct laryngoscopy. Structures seen on direct laryngoscopy. So, three structures are of our concern in direct laryngoscopy: epiglottis, vocal cords, and posterior commissure. The whole of this V is called as posterior commissure. Epiglottis, vocal cords, and posterior commissure. These are the three things that you want to look at while you are doing laryngoscopy. Based on these three structures, there is a classification called as Cormack and Lehane classification on direct laryngoscopy, or CL grading. Cormack and Lehane classification, or CL grading. This is a classification based on direct laryngoscopy, the structures that you see on direct laryngoscopy. And grade 1 is when you can see all the structures, that is epiglottis, vocal cords, posterior commissure, very clearly. You can see all the three structures very clearly. When you can see all the three structures very clearly, it is called as Cormack and Lehane class 1. It is called as Cormack and Lehane class 1. Cormack and Lehane class 1. Grade 2 is when you have a predominant view of posterior commissure. You can see the look between 1 and 2, the area has become smaller. The structures are now crowded, but what you see in front is a predominant view of the posterior commissure. While in grade 3, what you see is that the epiglottis is now so big that it is hanging. So it is hanging epiglottis. It is hanging epiglottis. And finally, when you cannot see any glottic structures, no glottic structures are visible, then it is CL grade 4. Now look at these 4 classes and tell me which would be easy to intubate, which would be difficult to intubate. Which would be easy to intubate and which would be difficult to intubate. Look at these 4 classes and tell me which would be easy to intubate and which would be difficult to intubate. Yes, of course, where you can see the vocal cords would be easy. That means 1 and 2 are easy intubations. 3 and 4 would be difficult intubations. 3 and 4 would be difficult intubations. All right. All right. Next is range of motion. Next is range of motion. But before that, let's look at the actual images. Now this will tell you on actual video laryngoscopic images how things will look like. So you can see this is A, where you can see this epiglottis, vocal cords, posterior commissure very clearly. This is CL grade 1. When you see a predominant view of posterior commissure, this is CL grade 2. When you see an hanging epiglottis, CL grade 3. And when no glottic structures are visible, CL grade 4. This is just to give you a visual impression of how things will look on direct laryngoscopy picture, which can be expected now because we have a lot of these images from video laryngoscopes. All right. Next is range of motion. Next is range of motion. Can you all tell me, and if you know, what is the ideal position for laryngoscopy? What is the ideal position for laryngoscopy? What is the ideal position for laryngoscopy? Yes, that position is called as sniffing the morning air position, or barking dog position. Yes, very good. Dr. Ruchir, Bishop, Palak, Anishka, you have all told something that I wanted you to tell me. That is rose position and hyperextended. Look at this image and tell me, is this hyperextension of the neck? Is this hyperextension of the neck? Do you call it hyperextension of the neck? This is extension. What is hyperextension? You hang your head and then you do something like this. Hyperextension of the neck. Does this position looks like the hyperextension of neck? No. So rose position or hyperextension of the neck is not a position for laryngoscopy but a position for tonsillectomy. Right? That is why you have read it in ENT in the chapter of tonsil. What we use intraoperatively as a position for laryngoscopy is called as sniffing the morning air or barking dog position, which is simply two things: extension and flexion. Extension at atlanto-occipital joint, and flexion at lower cervical joints. This is achieved using this donut or ring pillow. This is achieved using a donut or a ring pillow, which elevates the occiput, which elevates the head, but the occiput falls in the well of the donut, which causes extension here at atlanto-occipital joint. And when we perform the laryngoscopy and we lift the mandible, then there is flexion at the cervical joint. How do you check for it? Normal extension is more than 85 degrees, while normal flexion is when your chin can touch sternum. Normal extension is more than 85 degrees. That is when your occlusal surface of the teeth moves more than 85 degrees. And normal flexion is when your chin can touch your sternum. Chin can touch your sternum. When your chin can touch your sternum. This is ideal position for intubation called as sniffing the morning air position or barking dog position. Sniffing the morning air position or barking dog position. Is there any confusion between sniffing and rose position now? Is there a difference? Is there a confusion between sniffing and rose now? This is what you give for laryngoscopy. Rose is what you give for tonsillectomy. Why do we want to give this position? You can see you don't have to draw this, just try and understand. When the patient is neutral, that is lying supine on the bed, then the oral axis, the pharyngeal and the laryngeal axis are all in different directions. You can only visualize the vocal cords here through the eyes here when all the axes fall in one line. So when you give this extension, then you see what happens. The pharyngeal and the laryngeal are in one line, and when you perform the laryngoscopy, the oral axis also, so all three axes come in one line with the eye, and you can visualize the vocal cords. Okay, Palak, Ruchir, Nivedi and Muhammad Rafi. This no sir was for what? Understanding the difference between rose and barking dog. Rose and sniffing. Look at it here. This is a sniffing position. Simply put the patient's head on a donut or a ring pillow. So what happens? There is elevation of the occiput. Occiput falls back in the well of the donut, and there is extension at the atlanto-occipital joint and flexion at the lower cervical joints. For it to be a position for tonsillectomy, you need to put a shoulder roll below the shoulder, and then the head will completely fall back, and it would be called as a hyperextended position, that is rose position. That is a position for tonsillectomy. That is not a position for intubation. That is a position for tonsillectomy. And then you apply those snares which go like this and go to the bottom of the patient head, and then you attach a snare which will then expose, and then you can do a tonsillectomy. No, it doesn't look like hyperextension. Hyperextension would look like hyperextension, the one that you see when you put a shoulder roll, the one that image that you see in ENT. Acha, you asked if there is any, okay, thank you. Okay, I thought that no sir, you didn't understand. Okay, yeah, right. So the ideal position for intubation is sniffing the morning air or barking dog position. That is something that you want to give in every patient, but not in every patient can you give this position. So in patients who are obese, or who have large breasts, we have a modification of the position in obese individuals and patients with large breasts. They cannot be put in sniffing position. Why? Because of the large breast or a large anteroposterior diameter of the chest. Because of the obesity, their head never really falls back and it is uncomfortable. So you give them a ramp position, also called as head elevated laryngoscopy position. Head elevated laryngoscopy position. So what you do, you put multiple pillows behind the shoulder and the head of the patient to ramp the patient up, like putting the patient on a ramp. The idea is to get EAC in line with the suprasternal notch. So you write help or ramp position It is a modification of the position. This is reserved for obese patients and patients with large breasts. And the idea is to get EAC, that is ear in line with the suprasternal notch. EAC in line with the suprasternal notch. Just write this thing. EAC in line with suprasternal notch. So this is modification of the position. So you have a position which is the ideal position for intubation, which is sniffing the position. Modified position is called as head elevated laryngoscopy position or HELP position, where the idea is to get the EAC in line with the suprasternal notch, right? So these are predictors of difficult bag and mask ventilation and predictors of difficult airway. Now, if there are any doubts in airway assessment, then I'll wait for 2 minutes for you to ask the doubts, and then we'll move ahead with the next topic, which is airway management. Since we are doing airway assessment, so we'll do airway management with it together. It's a side topic. It will take say maximum of 45 minutes to an hour, and then we can move ahead with the pre-operative assessment and preparation. So if there are any doubts, yes, we'll come to that later. Div will come to that later. Okay. No, Virat. See, Rose positions, Virat, we don't do tracheostomy in difficult airway. Trust me, tracheostomy is a very, very invasive procedure. And there are only very limited indications for doing tracheostomy. And a difficult airway is rarely the reason why we do tracheostomy. Zaid, Rose position is for tonsillectomy. You will know the details of that position in ENT. Just remember, Rose is not the position for intubation. Position for intubation is sniffing the morning air position or barking dog position. Just remember this thing. Rose is not a position for intubation. Okay. What is the importance of thyrohyoid distance? Position of the larynx. A small thyrohyoid distance, that means the larynx is very, very anterior. Anterior larynx, it becomes difficult for you to put the tube in. The position of the larynx becomes so anterior that the tube has to now negotiate very difficultly. You know?
Yeah. Why?
Yeah, sorry for that. Okay. So yeah, so thyrohyoid distance basically tells you whether the position of larynx is anterior or not. And Jay Patel, this is the slide of lemon. If you want to complete it, you can complete it. Jay Patel, retrograde intubation can be done in difficult airways. See, there are certain indications for retrograde intubation. Yes, one of the indications is difficult airway. But it is mostly to do with the type of surgery that we are doing. When we do a surgery of the upper airway for say CA, buccal mucosa or cheek, then retrograde intubation has an importance. Thyromental distance is also called as Patel's test. Aditya, Patel's test. Yes, Akansha. Flexion of cervical, that is, if your chin can touch your sternum, that means adequate flexion. Adequate flexion. Okay. Okay. Done. These are predictors of difficult airway, Prakriti. So if the distance is lesser, that means you can predict that it is going to be a difficult airway. You can predict that it is going to be a difficult airway. Okay. Let me know when you are done and then we'll move ahead. Sure. Moving on to the next topic, which is airway management. Okay, this image will tell you what is the significance of range of motion. Look at this image and tell me whether it is going to be an easy airway or difficult. Is this going to be an easy airway or difficult? It is obviously going to be difficult. There is post-burn contracture of the neck. So that will affect the range of motion. The flexion is restricted, the extension is restricted. Sometimes because of this PBC, post-burn contracture, even the mouth opening gets restricted because the tissues, they just stretch the mouth. So now the even mouth cannot be opened. So a combination of these would not allow you to do a proper laryngoscopy, and that would cause a difficult airway. So now you can understand when we measure these distances and we see the range of motion, then you can get a fairly good idea whether you can have a easy or a difficult airway. Now this is something that you can look externally and tell, okay, this is going to be a difficult airway, right? Now traditionally airway management is divided into two types: temporary airway management and permanent airway management. Can you name a permanent airway management technique? Can you name a permanent airway management technique? Yes, tracheostomy. Tracheostomy. And tracheostomy is taught to you by ENT, right? So this is not my cup of tea. Anyway, I as an anesthetist, I believe in temporary airway management, that is for the period of surgery. So we deal with the temporary airway management techniques that can be further divided into face mask ventilation, airways, and endotracheal tube. Endotracheal tube. Airways can further be divided into oropharyngeal airway, OPA, nasopharyngeal airway, NPA, and laryngeal mask airway, LMA. Just write the short forms. We'll discuss all of these things in detail now. Okay. Oropharyngeal airway, nasopharyngeal airway, and laryngeal mask airway. Oropharyngeal, nasopharyngeal, and laryngeal mask airway. Oropharyngeal airway, nasopharyngeal airway, and laryngeal mask airway. Let's start the discussion of face mask. This is how a typical face mask ventilation looks like. These are clear silicone face masks which are kept over the face of the patient like this, and then you ventilate the patient using a bag. The bag can be a bag of ambu bag, or it can be bag of the anesthesia machine, right? Let's discuss the nuances of face mask ventilation. It is the simplest and most non-invasive technique. It is simplest and most non-invasive technique. Simplest and most non-invasive complete technique. It allows gas administration to the patient from breathing system without introducing any apparatus in patient's mouth. So it's basically a non-invasive technique whereby you just keep the mask on the face of the patient and it allows the administration of gas without introducing anything in the patient's mouth. Physiologically, it increases dead space. Physiologically, it increases dead space. Now, who can tell me what is dead space? Can anyone tell me what is dead space? What is dead space? Yes. So dead space is all the parts of the respiratory system that is ventilated but not perfused. So there is no gas exchange. So normally our dead space starts with the oropharyngeal, nasopharyngeal cavity, then through the larynx, through trachea, through bronchus to respiratory bronchioles. Up to respiratory bronchioles is anatomical dead space. Now when you add face mask over it, your face, then whatever the volume of the mask adds to the dead space, adds to the dead space. Right? So when you put a face mask, it is adding to the dead space. If you talk about the order of dead space in airway management techniques, then you can plot the order as face mask causes maximum increase, followed by supraglottic airway device or LMA, followed by endotracheal tube, followed by endotracheal tube. This is very important. It has already been asked in AIMS once. Now tell me what should happen to dead space when you put an endotracheal tube. What should happen to the dead space when you put an endotracheal tube in the patient? What should happen to the dead space when you put an endotracheal tube in the patient? When you put an endotracheal tube, then what should happen to the dead space? It should always decrease. Yes, SAD is supraglottic airway device. We'll come to that in 5 minutes. Yes. With endotracheal tube, there is always a decrease in dead space. Always decrease in dead space, except when you use a long endotracheal tube in a preterm neonate. In a preterm neonate. When you use a long endotracheal tube in a preterm neonate. See, what happens is when you put a tube, endotracheal tube, basically it bypasses all the volume of the upper airway, that is nasopharyngeal, oropharyngeal cavity, and the tube is inside the trachea, and therefore the volume of tube is lesser than trachea, so the dead space decreases. But imagine a condition where you have a small preterm neonate and you have put a longer endotracheal tube, so that extra volume that is there in the endotracheal tube that is outside sometimes becomes more than the volume of upper airway, right? So that is when you can have a exception, and your long endotracheal tube can cause an increase in dead space. Otherwise, endotracheal intubation should always decrease dead space. Drawback. What is the biggest drawback of face mask ventilation? Increased risk of aspiration. Why do you think there will be increased risk of aspiration? See, there is a risk of aspiration in unsecured airway, yes. But with the use of face mask, there is increase in the risk of aspiration. Can you think of a reason why it would increase the risk of aspiration? Why it would increase the risk of aspiration? Yeah, because when you do a face mask ventilation, then the air not only goes in the trachea but also goes into the stomach via the esophagus. So there is increase in risk of aspiration because of gastric insufflation. With the positive pressure of the air that you are giving, gastric insufflation, right? So there is always an increased risk of aspiration with face mask ventilation. Now that you are doing face mask, let's discuss the most common way of giving a face mask ventilation, especially in ICUs and in casualty, that is AMBU bag, via an AMBU bag, which is ambulatory manual breathing unit. Ambulatory manual breathing unit, also called as artificial resuscitator. Now there are two questions that they commonly ask. What is the maximum FiO2 that can be delivered through an AMBU bag? What do you mean by FiO2? What do you mean by an FiO2? It is the fraction of inspired air, that is oxygen. FiO2 is fraction of inspired air, that is oxygen. The maximum FiO2 that can be delivered through an AMBU bag is 100% oxygen. 100% oxygen. Maximum FiO2 that can be delivered is 100% oxygen. Maximum FiO2 that can be delivered is 100% oxygen. And second, the volume of the bag of AMBU. Volume of the bag. So it depends on the age. You have three types of AMBU bag: neonate, child, adult. In a neonate, the volume of bag is 250 ml. In a child is 500 ml. In an adult is 1.5 liters. Okay, just note this thing down. I'll come in a minute. Okay. So in the meantime, you guys were discussing the bigger questions in life, which is how many pages to leave from this topic to that topic, right? The burning question of the day, how many pages to leave? So since I was just reading the discussion that was happening and you said that I wish the exam did not happen before April. So something that I want to ask you, let's discuss this point. How much time do you think is enough to prepare? How much time do you think is enough to prepare? How many months? You think a year is enough? Year and a half, 2 years, 3 years? See, the point is, no amount of time is enough. Frankly speaking, no amount of time is enough. And 5 months is enough time to prepare and do 2 revisions if you are doing smart study. If you are doing smart study. Now you'll say, sir, what is this smart study? Everybody keeps talking about this smart study. What is this smart study? We don't understand. There is so much to read. There is so less time. How to do smart? How to be smart in this, right? So smart study has few things that you need to really put into yourself. The first is one source of information. What happens is you get too caught up with multiple sources. What do you think is that the more I read, the more knowledge I will acquire, the better I'll do in exam? Doesn't happen so. Okay. It is only the thing that you can revise is what you are going to remember, and only that question or that topic is what you are going to mark right in the exam. So if you go for multiple sources, every time you read, it is like a new information for your brain. So you don't remember more than 50% of what you read for the first time. So idea is to have one source, and that one source is your notes. This is your Gita, Bible, Quran. This is everything. Just like how for every religion there is one supreme book, and the persons who are the preachers of the religion, they just keep on reading that book again and again and again and again and again for years together, and then also they understand religion very less or not completely. The reason is because they are now doing one source and they are trying to understand that source properly. So first thing is that you should have only one source of information, that is your notes. And the notes that you make in class right now with the time that you are remaining is more than sufficient. Class. Second, always remember that your exam is an MCQ based exam. So at any point of time, don't just dwell into theory. Always top up your notes with practice of questions. Practice of questions. Always top it up with practice of questions. So at every step when you do notes, there should be some practice of questions that starts with as small as class test that happens after the class. Then you have your DQB, that is the DAMS question bank. Then for each subject you have an SWT, and then you have GT, CBTs, mock. GTs, CBTs, mock. At every step you do something, follow it up with a question. Revision, follow it up with question. Again revision, follow it up with question. If you don't correlate your knowledge that you are reading in theory with the questions, then everything is in vain, because you'll be reading a lot of theory, but you would not exactly know from which aspect or which point they'll make a question and give it to you. Your idea of an exam is always to mark the right answer. It is not to gain the knowledge. It is not to be the most knowledgeable person in the room, but to be the most right person in the room. That is the one who marks maximum right questions. So there you will see there are a lot of students who you feel are not very good conceptually, but they do very well in the exams. The reason for that is because they are marking more questions correct. So you have to remove the emotional component of your preparation, that if I have read a topic, I have understood it, I am supposed to mark everything right. No, doesn't work that way. Even if you have read a topic, not understood anything, still you would not be able to mark everything correct. Okay, just a minute. So it doesn't really work that way, that you have read a topic and reading a topic is enough. Okay. All right. So when I say smart study, one source of information, always practice MCQs along with the reading of theory. And the last and the strongest strategy is read what you can revise and revise what you have read. This should be your mantra for smart study. There is no point in doing 200 topics in a subject but not revising them even once. Instead of that, you do 75 topics in a subject but revise them 3 times. Whatever comes from those 75 topics, you'll be able to mark them right 90% of the times, and that is what your target is. So only read what you can revise and only revise what you have read. These are the 3 things that put you on the map even with 5 months remaining. Even with 5 months remaining. 5 months is the standard amount of time that you read, even when you get 1 year. When you get 1 year, then you celebrate more, you take more breaks, you take 2 vacations, you go home, you even do job for 2-3 months. So eventually you end up reading only 5 months. When you have got 5 months, if you give your 100% in these 5 months, this is more than sufficient for your exam. And trust me, early exam is always better, late exam is never. Because the postponements in exam takes away a lot of your mental energy. You don't want that. Okay. So remember this thing. All right. So this is just a side thing that I wanted to talk to you. Thankfully, it came from the discussion when I went down. All right. Next is airways. Next is airways. So there are 3 types of airways: oropharyngeal, nasopharyngeal, and supraglottic airway device. Let's start with the oropharyngeal and nasopharyngeal airway. This is how they look. Oropharyngeal airway is a curved, short, stout structure, while a nasopharyngeal airway is a soft silicon. It's a soft silicon elongated structure, nasopharyngeal airway, right? They are both unsecured airway. That means they do not prevent the risk of aspiration, and the purpose of both of them is to lift the tongue and epiglottis away from the posterior pharyngeal wall. To lift tongue and epiglottis away from posterior pharyngeal wall. So whenever the patient loses consciousness, then what happens is, the first thing that happens is that they lose the upper airway tone. When they lose the upper airway tone, the tongue falls back on the posterior pharyngeal wall. Noreen, first thing, I am not going to provide you anything. Okay? You have to understand that you need to do the hard work. I can only guide you, right? So I am only going to tell you the things which I feel very strongly about, the type of strategy that one should prepare. Of course, to follow it or not to follow it again is on you. You can always devise your own strategy, because you cannot say that one strategy is the perfect strategy. Second, I would not provide any timetable to you. You are going to make a timetable and send it to me, right? This is what I want from you all, that whatever I tell you during the class, if at all you are interested in it and you are noting it down, then I would really appreciate and love if you make your plan according to what I am telling you, and then send it over to me over messenger in a photographic form, and then we can discuss what you have done, and you know that is something that will keep you motivated. Secondly, I think you have got something called as a DAMS planner. You have got it, right? DAMS yearly planner. Even I have a copy of DAMS yearly planner. It's one of the most wonderful things that you can get in a pre-printed format. Like, I mean, the sir and ma'am has really made your life very, very easy. Like, they've given you everything. Like, if I wish I would have had, you won't believe it, when I saw this DAMS yearly planner, I took it from one of the centers so that I can use it. So it is even good for me. So I'll show it to you. It's I think kept here only in my study. Yeah, so this is the DAMS yearly planner, and see, it has got everything: highlight of the week, daily to-do list. It has got topics, ticks for the topics, full syllabus it has given, calendars it has given, last minute revision topics that you can write. You can write this DQB tick list, which is an amazing tool, DQB tick list, whereby whatever DQBs you do, you just keep on ticking it, and you can write a reminder when you want to do it again. Highlight of the week is something that I would expect you to do, what you did good, what you did bad. You can divide it week number, so it is not based on the calendar year, but the weeks that you are remaining, so you can plan accordingly. And I think what I saw here, which was very nice, was habit tracker. Yes, depending on the month, there is habit tracker where the sir has put daily quizzes and decks. So I think sir has already given you one of the best resources that are available in the market. Nobody really cares so much about the students as he has made literally everything, he has cherry picked for you, and all you need to do is use the resources in hand and to get the best out of it. That is your job, right? Trust me, that is your job. You need to cherry pick these things and you need to do the best from what is given to you, right? All right, so coming back to the topic, what is the purpose of nasopharyngeal and oropharyngeal airway? It is to lift the tongue and epiglottis away from the posterior pharyngeal wall. You know what, Matthew? I am not appearing for NEET PG with you, but you know, I am also always on a timeline. Even I have a lot of things that I need to perform at. Yes, I do give exams very frequently, some fellowship exams, some training programs. I'm a very avid reader and I try to do new things, but I'm always on a short leash because I work a lot. So yes, it becomes difficult for me to manage things. And the reason why I've got this DAMS daily planner is the reason because when I saw it, I realized that it can help me also. It has got things like habit tracker and stuff like that. I'll start to fill it up from this week. And that I hope that it is going to help me achieve my goals also. It is something that is, I think, a lifestyle change. That is why you see that sir and ma'am are always there on the top. They are always up to date with everything. Whatever comes, they are the first ones to make a plan out of it and then help the students because they have this habit of doing everything immediately, right? So yes. Yes, I know you were joking, but I got serious. Chalo. So when you put oropharyngeal and a nasopharyngeal airway, then you are basically preventing the tongue to go and merge with the posterior pharyngeal wall. So it creates a open patent airway, right? What we are going to discuss is the oropharyngeal and nasopharyngeal airway. Oropharyngeal airway is also called as Gudel's airway. You can start writing. This is an extensive list. Nasopharyngeal airway is called as nasal trumpet. Nasopharyngeal airway is also called as nasal trumpet. Nasopharyngeal airway is also called as nasal trumpet. The material from which oropharyngeal airway is hard plastic, while nasopharyngeal airway is made up of soft silicon. Nasopharyngeal airway is made up of soft silicon. The most important question that is asked from this topic is how to choose an appropriate size. How to choose an appropriate size. So for an oropharyngeal airway, it is the vertical distance between angle of mandible and central incisor. It is the vertical distance between angle of mandible and central incisor, this. So you measure the distance, angle of mandible, central incisor, and whichever oropharyngeal airway fits in this length is the correct length of oropharyngeal airway, or distance between external auditory meatus to angle of lip. Distance between external auditory meatus, this to angle of lip. The same distance, just a different way of noting it. External auditory meatus to angle of lip. While for a nasopharyngeal airway, it is tragus to tip of nose, which is little longer. Tragus to tip of nose. 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 This is very, very important. Most of the questions from this topic is from how to choose an appropriate distance. Use. Apart from the fact that they both help in achieving patent upper airway, oropharyngeal airway prevents tongue fall and obstruction of airway. You saw that, and it prevents biting and occluding of the oral tracheal tube. It prevents biting and occluding oral tracheal tube and protects from tongue biting. So when you put an endotracheal tube in a patient, you always put an oropharyngeal airway, especially in ICU, so that when the patient wakes up, when the patient becomes more conscious and awake, they don't start biting the tube. They don't start biting the tube. For a nasopharyngeal airway, it's a specific indication, that is to apply continuous CPAP. So you put a nasopharyngeal airway, put high flow oxygen through it, it gives the CPAP, continuous positive airway pressure, and to dilate the nasal passages in preparation for nasotracheal intubation. To dilate the nasal passages in preparation for nasotracheal intubation. To dilate the passages in preparation for nasotracheal intubation. Dilate the passage in preparation for nasotracheal intubation. Let me know when you are done writing this thing. Then I'll move to the next slide. Noted? Okay, next is advantages, disadvantages, and limitations. So, advantage of an oropharyngeal airway we all know is easier to insert and less traumatic. Easier to insert and less traumatic. While the advantages of nasopharyngeal airway are for specific indications, like they are better tolerated in semi-awake patients, preferable in loose tooth or poor condition of the tooth, and can be used when mouth opening is restricted. So whenever the mouth opening is restricted, their use of nasopharyngeal airway comes into picture. Use of nasopharyngeal airway comes into picture. Disadvantage of an oropharyngeal airway is that pharyngeal and laryngeal reflexes should be depressed. So it can be only inserted successfully either when your patient is completely anesthetized or the patient is near comatose. Near comatose. So you need a deeper plane of anesthesia for successful insertion of a oropharyngeal airway. Successful insertion of an oropharyngeal airway. While for nasopharyngeal airway, the problem is the risk of bleeding in patients who are anticoagulated, a base of skull fracture, and history of nosebleeds. And history of nosebleeds. History of nosebleeds. All right. Have you written this thing down? Have you written this thing down? Okay. Namita, quickly note down what you have to note down in this slide and then we'll move on to the next portion. All right. Next is supraglottic airway device. Supraglottic supraglottic airway device, SAD, also called as laryngeal mask airway, LMA, or extraglottic airway device, EAD. I'll just come in a minute, guys. I'm really sorry. Okay. So this supraglottic airway device is something which is very unique. You can see here, it is something which is very unique. It is a device which is actually between an endotracheal tube, where you can see that the tube is placed in the trachea, and the cuff is inflated, and something as non-invasive as a face mask, which is outside the face. It is sitting in the oral cavity, but it is outside the larynx. So supraglottic airway device. Supraglottic airway device. SAD. Or laryngeal mask airway. Laryngeal mask airway. Yes, Shivangi? In 15 minutes, we'll take a break. Okay? We'll finish supraglottic airway devices and then we'll take a break. Don't worry. You will get lot of breaks. Don't worry. Today the class will finish at 7 only. And we are going to take a lunch break after 2.5 hours again for almost 45 minutes. And then in the evening, another 10-15 minute break. So it's going to be a very light session. So don't worry. You're not going to feel very tired. Just concentrate on the things that I'm telling you and we'll be done by tomorrow evening 7:30. Okay. Let's discuss the advantages and disadvantages of LMA over the two other traditional airway management techniques, that is face mask and endotracheal tube. Face mask and endotracheal tube. So the advantage of LMA over face mask is better ventilation, of course, because it is something that has a cuff. It forms a seal in the oral cavity, so better ventilation. Hands-free operation. Your hands are free because you can insert the LMA and fix it. So your hands need not be engaged in holding the mask. Less OT pollution. Less OT pollution. Can be used for a long time and no jaw pain. Can be used for a long time and no jaw pain. But if you have to really cherry pick something that is a disadvantage, otherwise there's no disadvantage of LMA over face mask. But if you just have to pinpoint, then incidence of sore throat, because a laryngeal mask airway is sitting in the throat and therefore there is more incidence of sore throat. With face mask, there is incidence of jaw pain. Advantages and disadvantages of LMA over endotracheal tube. Advantages and disadvantages of LMA over endotracheal tube. Now this is more important because you compare it with traditionally the most commonly used airway that we use in anesthesia, that is endotracheal tube, and you see that it has a lot of advantages. That is no need of muscle relaxation, first thing, and less anesthetic requirement. You don't need that much anesthetic requirement as much as you require for intubation, and no need of muscle relaxation. No damage to vocal cords because the LMA is sitting outside the larynx. So no damage to vocal cords. Can you think of a group of patients where this damage to vocal cords is really a concern for us? Can you think of a condition? Yes, in professional singers or teachers or whosoever vocation is based on their voice. It is useful in difficult airways. We'll see in some time how it is useful in difficult airways, and less post-operative sore throat. As compared to endotracheal intubation, less in LMA. As compared to face mask, more in LMA. The biggest disadvantage to the use of laryngeal mask airway doesn't prevent the risk of aspiration. Why? It's an unsecured airway. Doesn't prevent the risk of infection. Unsecured airway. Again, the cuff is not inflated in the trachea, and therefore it doesn't prevent the risk of aspiration, and it is not useful in distorted anatomy of upper airway. Why? If the anatomy is distorted, the mask will not form a seal and therefore it would not be adequately fit, and so there will be leak of gases and the ventilation will get hampered. Ventilation will get hampered. Let me know when you are done writing this topic. Then we'll move on to the next slide. right? This is how you insert the LMA. This is how you insert the LMA. It's as simple as opening the mouth and pushing the LMA in down the throat. Now look at this insertion of LMA and tell me what would be your anesthetic requirement when you have to insert the LMA. What do you think should be your anesthetic requirement when you insert the LMA? Yes, the gag reflex, the upper airway reflexes should be lost. Therefore, agent of choice, remember AOC is always agent of choice. I'm going to use this throughout the anesthesia. Agent of choice for LMA insertion is a drug called as propofol. Drug called as propofol. We'll discuss that again later on when we discuss propofol, but right now just remember that the drug of choice for LMA insertion is propofol. Drug of choice for LMA insertion is propofol. Okay, next is ideal position of LMA. So when you insert the LMA, you can see again, when you insert the LMA, so you open the mouth, take the LMA in hand, insert it down the throat. This is the final position of LMA. And if you see the final position of LMA, just a second. Hello. हाँ लोकेश्वर, गुड मॉर्निंग. अरे मेरी यार क्लास चल रही है ना? हाँ कोई बात नहीं. ओके. Okay. When you finally insert the LMA, then the tip of LMA is in front of esophagus. So remember, in an ideally placed LMA, the tip faces the esophagus. Can you remember this point? The tip of LMA faces the esophagus. In an ideally placed LMA, the tip of LMA is in front of esophagus. Tip of LMA is in front of esophagus. The tip of LMA is in front of esophagus. Let's look at the uses and contraindications of LMA. So LMA now has evolved as another airway management technique apart from endotracheal tube. So it can be used as an alternate to ET tube. It can be used as an alternate to ET tube. It can be used in professional singers. Why? Because it is sitting outside the larynx and therefore it doesn't really damage the vocal cords. Difficult airways, we'll discuss it in some time, how it is easy to introduce an LMA in a difficult airway. And right, CPR, it is very easily inserted, anybody can insert it, and therefore it has a lot of role in CPR and in short surgical procedures. So basically an alternate to endotracheal tube for short surgical procedures. Short surgical procedures. But contraindicated in distorted upper airway anatomy. Yes, distortion of upper airway anatomy is a big reason, because if the airway anatomy is distorted, then there would not be a seal. And in emergency surgery or full stomach patients. In emergency surgery or full stomach patients. Emergency surgery or full stomach patients. No, Bishop, it will not prevent aspiration. See, if you compare the risk of aspiration between a face mask and an LMA, definitely LMA has lesser risk of aspiration. But if you compare between LMA and ET tube, then LMA has a higher risk of aspiration. It will not prevent, it will definitely decrease the risk of aspiration as compared to face mask, but it will not prevent, because if the contents are regurgitated, then there is only tip at the esophagus, right? At the opening of esophagus, the contents can still come out of it. Okay. Now let's classify these LMAs. And LMAs are classified based on the number of tubes that they have into first generation and second generation LMAs. A first generation LMA is something that has one ventilating tube only. It has one ventilating tube only. While in a second generation LMA, there is a ventilating tube plus a gastric drain tube. Gastric drain tube. Now, where is the tip of LMA? In an ideally placed LMA, in front of esophagus. So what if I create a hole in that tip and put a tube behind? So that will cause the gastric drainage. Am I right? So you have a ventilating tube and you have a gastric drain tube. Examples: LMA classic, LMA classic, LMA unique. These are first generation LMA, while second generation LMA, LMA Pro Seal, LMA Supreme, and iGel. See, there are many types of second generation LMA, almost 16 to 18 varieties of second generation LMA, but we will be only asked about these three, if at all. They normally don't ask, they ask the names which you can remember, and we'll see how they look also, right? So when you see one lumen, that is a first generation LMA. When you see two lumen, it is second generation LMA. When you see two lumen, it is second generation LMA. What we are commonly asked is everything about the first generation LMA. So let's discuss LMA classic first generation LMA. 8 sizes are available. 1, 1.5, 2, 2.5, 3, 4, 5 and 6. 1, 1.5, 2, 2.5, 3, 4, 5 and 6. No, Tanisha, second generation LMAs will also not prevent aspiration, but they will be better than first generation. Yes, they'll be better because they'll keep on emptying the stomach, but they will not prevent aspiration. Remember, there's a difference. Prevention of aspiration versus decreased risk of aspiration. Prevention means aspiration will not happen even in an event of regurgitation. Prevention is that. Decreased risk is normally if there was an unsecured airway, yes, there will be an aspiration, but that risk will decrease with use of an LMA. Most commonly size used for an adult male is 5, female is 4, and a child with a weight 30 to 50 kg is 3. A child with 30 to 50 kg weight is 3. Also, it is a large child or a small adult. Large child or a small adult. You can see that there's a cuff. That cuff has to be inflated through a pilot balloon assembly. When this cuff is inflated, of course, there is going to be a pressure. The maximum intra-cuff pressure has to be 60 centimeters of water. The maximum intra-cuff pressure has to be 60 centimeters of water. Maximum intra-cuff pressure has to be 60 centimeters of water. Maximum intra-cuff pressure has to be 60 centimeters of water, right? So now they will ask us about classic LMA, and most of the time, if at all there's an image-based question, it would be based on classic LMA. You can see it has got one lumen, that is the ventilating tube. Suppose they ask you about a second generation LMA. How would you identify a second generation LMA? How would you identify a second generation LMA? Two tubes. Two tubes. So this is the ventilating tube. You can see it opens here at the base. You can also see that the tip has a tube that is opening behind. This is esophageal tube. So in every second generation LMA, you will see two tubes. So whenever you see two tubes, second generation LMA. Now there are three types of second generation LMA. Pro seal, no shape. You can see that there is no shape of LMA. The tubes are lying like this, no shape, right? In the same second generation LMA, if you put a anatomical shape, if you put an anatomical shape, that is the shape of upper airway, anatomical shape, it becomes LMA supreme. LMA supreme. And you can see that wherever there is a cuff, there is a pilot balloon assembly to inflate the cuff. So if you don't see a cuff or a pilot balloon assembly, that is a cuffless device, which is iGel. It's a cuffless device, which is iGel. Cuffless device, which is iGel. Right? So whenever you get an image-based question based on identification or about that LMA, you look at two things: one lumen, two lumen. If it is one lumen, it is first generation LMA. Two lumen, second generation LMA. There are three types of second generation LMA that can be asked to you: no shape, pro seal; anatomical shape, supreme; no cuff, iGel. Isn't it easy? Isn't it easy? Very, very easy. Just step by step do this. Okay. Look at this. This is a special type of LMA. It's a special type of LMA. It's a special type of LMA, which is LMA fast track, intubating LMA. You can intubate trachea through this LMA. You can intubate trachea through this LMA. How to identify? You will see a handle in the LMA. Whenever you see a handle like this, a bar in an LMA, that is an intubating type of LMA. LMA fast track. LMA fast track. See, these are potential questions, PQ, remember. They have never been asked before. But if at all they want to create an image-based question which is going to be a little difficult, they are going to ask this type of question. Okay. So this is about laryngeal mask airway. All right. The next topic would be laryngoscopes and endotracheal intubation. But why don't we take a break for how much time you want? 15 minutes is okay. Right. So we'll take a break for 15 minutes. We'll come back at 11:45. There is no cuff. You cannot have a cuff without a pilot balloon assembly to inflate the cuff. The cuff has to be inflated, right? A cuff has to be inflated. So if there is no pilot balloon assembly, that means it is not a cuff. This is not a cuff. This is a cuffless device, iGel. Okay. Now somebody asked, how do you monitor how much air? So depending on the size of the LMA, the air differs. Like for a 5 number LMA, you have to put 20 ml of air, and the maximum intracuff pressure is 60 centimeters of water, right? So there is a pressure manometer that can be used to measure the pressure of the cuff, right? So that is a manometer that will tell you how many centimeters of water. All right. Ankit, you have to go back and again come back. Go to back and then again press the live channel and then we'll start. Okay. So if everybody is here, then I can start. If everybody is here, then I'll start. If everybody is here, then I'll start. All right. Give me some thumbs up. Everybody who has come back, give me some thumbs up. Give me some thumbs up. So I'll start again. Perfect. So let's start with the next topic, which is laryngoscopes. Laryngoscopes. Now this laryngoscope is used to perform direct laryngoscopy. Laryngoscope is used to perform direct laryngoscopy. There are two, based on the shape of the handle, the blade. There are two basic types of laryngoscope: Macintosh blade, which is a curved blade laryngoscope, and Miller, which is a straight blade laryngoscope. This Macintosh blade or curved blade laryngoscope is most common used laryngoscopic blade, and it is used for adult intubations. While this Miller or straight blade laryngoscope is used for pediatric intubations. Miller or straight blade laryngoscope is used for pediatric intubations. It is used for pediatric intubations. Now tell me, in which hand do you hold the laryngoscope? In which hand do you hold the laryngoscope? Do you remember? Have you done laryngoscopy? In which hand do you hold the laryngoscope? So let's see the technique of laryngoscopy. And remember, you always hold the laryngoscope in left hand. Not in non-dominant hand, in left hand. Because if you say non-dominant, then for a left-handed person, right hand becomes the non-dominant hand, so he will hold it in right. But each laryngoscope that is commonly made is a left-handed laryngoscope. Remember this thing. So you always hold the laryngoscope in left hand. And from where do you insert the laryngoscope? Insertion. It is from right angle of mouth. It is from right angle of mouth. It is from right of angle of mouth. So you insert the laryngoscope in left hand, insert from right angle of mouth, sweep the tongue towards the left side and lift. Lift. What is the force with which you lift? It is upwards and forwards. The force applied is upwards and forwards towards the ceiling, upwards and forwards towards the ceiling. towards the ceiling. Towards the ceiling. So these are the three things that you have to remember in the technique of laryngoscopy. Technique of laryngoscopy, right? So the blades of laryngoscope, in which hand do you hold the laryngoscope, from where do you insert the laryngoscope, and what is the force that you apply. This is how a conventional laryngoscopy looks like. This is how a conventional laryngoscopy with curved blade looks like. It starts with this A, insertion of laryngoscope blade into the right side of the mouth. So you insert it from the right angle of mouth, you hold the laryngoscope in left hand. Then you go to the base of the tongue and then you lift. The lifting forces forwards and upwards. The lifting forces forwards and upwards. And when you do that, you see the laryngeal structures. And based on what you see in the laryngeal structures, there's a classification. What is the name of that classification? What is the name of the classification? What is the name of the classification in which you see the structures on direct laryngoscopy and then comment about it? What is the name of that classification? Yes, Cormack and Lehane classification. Cormack and Lehane classification. Alright. You want this slide? Technique slide? Yes, very good. Cormack and Lehane classification. Okay, Mihir, did you see this image? This image? Okay, tell me. Where is the position of laryngeal mask airway? This is LMA. Where is it positioned? Is it inside the larynx or outside the larynx? What is the starting point of larynx? What is the starting point of larynx? Yes, that is the epiglottis, the first cartilage of larynx, and the last is cricoid, right? So tell me, look at this thing. Look at this thing and tell me, is this device outside larynx or inside larynx? This is an endotracheal tube which crosses the larynx as is present in the trachea. That is why it is called as supraglottic airway device. See, supraglottic, this is the larynx, vocal cords, and the device is sitting outside the larynx. The device is sitting outside the larynx. Device is sitting outside the larynx. Alright? Mihir, I hope you understood. Is it clear now, Mihir? Okay. Up. Just look at this and finish it off. Then we'll move on to the next topic. Alright. Just like when you used a term called as ideal position for intubation, and you said that a sniffing the morning air position or barking dog position is the ideal position for intubation, and then you had a modification of position in the ramp position. Similarly, you do laryngoscopy the way we described in the technique, but if you are not able to visualize the larynx, then we do something called as a backward, upward, rightward pressure burp maneuver that improves vocal cord visualization during laryngoscopy. Vocal cord visualization during laryngoscopy. So it is called as a backward, upward, rightward pressure, burp maneuver. Backward, upward, rightward pressure. You need imagination. The patient is lying in front of you. You are holding the laryngoscope in your left hand. Insert it through right angle of mouth, right? And then you sweep the tongue and lift. So you are seeing from the right side. If you are not able to visualize the larynx, you put 3 fingers on the thyroid cartilage and you give a backward, upward, rightward pressure. Backward towards me, upward towards the ceiling, rightward. So backward, upward, rightward pressure. It will shift the entire larynx towards the right side and towards the intubator, and you will have a better visualization of vocal cords. So finish writing this thing, then I'll show you some images where it will be clear. So a modification in the laryngoscopy to improve visualization is called as backward, upward, rightward pressure or burp maneuver. Backward, upward, rightward pressure or burp maneuver. Backward, upward, rightward pressure or burp maneuver. See, these are the examples of how it improves visualization. You can see this is before burp maneuver, not able to visualize the vocal cord. You gave a backward, upward, rightward pressure. See, now you have a very clear vision. Why? Because you have shifted the larynx towards the right side and towards the intubator. Similarly here, you can see not much visualization, improved visualization, not much visualization, improved visualization. So it improves the visualization of vocal cords during laryngoscopy, called as backward, upward, rightward pressure, burp maneuver. Backward, upward, rightward pressure, burp maneuver. Shubhangi, you only tell me, na? Cormack and Lihani classification is when you see when you see the structures on what? When you see the structures on what? Direct laryngoscopy. And I just described you the procedure of direct laryngoscopy. No? So I told you, you will hold it in left hand, insert it from right angle of mouth, sweep the tongue towards left side, lift with the force that is upwards and forwards. And what you see, based on that, you have a classification called as Cormack and Lihani classification. That is just for you to correlate from airway assessment that is what we are talking about. The procedure is laryngoscopy. The classification is Cormack and Lihani. The structures that you can see on Cormack and Lihani classification. So somebody asked me, sir, what will we do in a situation of difficult airway? So let's do difficult intubation guidelines. Let's do difficult intubation guidelines. I'll just come in a minute. मैं भी आता हूँ. Okay. You only tell me, Kanimozi, which hand will you use for burp maneuver? which hand would you use for burp maneuver? This is how a burp maneuver looks like. Tell me, which hand are you using for burp maneuver? भाई सिंपल है ना एकदम. You are doing laryngoscopy, you are not able to visualize the vocal cord. So that is the time for visualization you will do a burp maneuver. So while you are doing laryngoscopy, how to improve visualization? Burp maneuver. And for laryngoscopy, in which hand do you hold the laryngoscope? Left hand. So with which hand will you do burp maneuver? Your right hand. Is it clear now? बच्चे, you will use your right hand to finally put the tube in. You do burp maneuver the moment you see the vocal cord, then your assistant does it for you. Then your assistant does it for you, है ना? चलो, बहुत अच्छा क्वेश्चन है. I will show you this video again and I'll show you how a burp maneuver is done. See, laryngoscopy. This is laryngoscopy, right? Now see the assistant's hand here. Can you see? He is performing a burp maneuver for me. He is performing a burp maneuver for me. See, I instructed him itna karo because I am seeing it. Now he is giving burp maneuver. ठीक है? समझ गए? That is how it is done. Very, very good. Very, very good doubt. That means you are able to visualize the things that are happening. That is something that I would love for you to have. You know? Very good point. Kanimozi, very good. Difficult intubation guidelines. Difficult intubation guidelines. So somebody asks, sir, what to do when there is a difficult airway? So now difficult airway can be in two scenarios. It can be either an anticipated difficult airway or an unanticipated difficult airway. So in anticipated difficult airway, you always have a plan B. You can use video laryngoscopes. We can use different types of laryngoscopes. We can do awake intubations. We can even do intubation with fiber optic. So when you know that there is a difficult airway, then it is very easy to manage. But the problem that happens is with unanticipated difficult airway. That is where your airway assessment told you that it is going to be an easy airway, but eventually it turned out to be difficult. And this is where you always land up in trouble because you have now induced the patient under anesthesia and now you are not able to intubate the patient, right? That is the definition of a difficult airway, one that is difficult in intubation. For that, we have set of guidelines called as DAS, Difficult Airway Society, Difficult Intubation Guidelines. And these Difficult Airway Society, Difficult Intubation Guidelines have 4 plans, plan A, B, C and D. So first plan is plan A, what we want to do in every patient, that is face mask ventilation and endotracheal intubation. We perform direct laryngoscopy. If we succeed, intubate, start the surgery. That is what happens almost like 99% of the times. But the problem happens when there is a failed intubation. That means multiple failures. You have tried to intubate patient multiple times, multiple users, and still the patient is not getting intubated. Then you will call it as a difficult airway. So when your plan A fails, then it is a difficult airway. What would you do? Immediately your management changes. Before that, your idea was to put an endotracheal tube. So intubation was on your mind. The moment you tried intubation multiple times and now it is not happening, now you want to just oxygenate the patient. You want to maintain oxygenation. And the next way of doing that is supraglottic airway device insertion. Supraglottic airway device insertion. You saw in supraglottic airway device that all you need to do is open the mouth, push the tube in the supraglottic airway device. No need of laryngoscopy, no need to visualize the vocal cords. just push the tube, and most of the times it works. So the next step is plan B, which is maintaining oxygenation through supraglottic airway device. You have to write the name plan B because that is what is asked in the exam. Maintaining oxygenation through supraglottic airway device. Suppose you failed at that also. You tried multiple attempts and you failed. So now your plan is final attempt at face mask ventilation. Now this is done to wake up the patient because now your patient cannot be intubated, cannot be put with SAD. So now you want the patient to be alive. And now you want the patient to come out of the effect of anesthesia. You want to postpone the surgery. We'll see later on what to do. We can then use different other techniques in difficult airway. But right now the priority is to awaken the patient and shift the patient. So final attempt at face mask ventilation, and if we succeed then we wake up the patient. But if we fail at this also, that is plan C. Now this situation is called as CICO, which is can't intubate, can't oxygenate. Can't intubate, can't oxygenate, CICO. Now this is a catastrophic condition because this can lead to patient going into hypoxia and finally dying. In this condition, we do a plan D, which is emergency front of neck access, or emergency FONA, which is cricothyroidotomy, which is making a hole in the cricothyroid membrane. Now this is a very good procedure, but of course this entails something invasive. It can save the life of the patient in an emergency when you have an upper airway obstruction or something like a CICO. You might have seen it in movies or sometimes in serials like sitcoms like House MD and Good Doctor, where they just poke a needle here in the neck and the patient starts to breathe again. That is a cricothyroid membrane, which is just at the opening of the trachea, right? And it is an avascular membrane which is subcutaneous. Avascular membrane which is subcutaneous. So if you poke a hole, then you can start giving passive ventilation through cricothyroid membrane and you can think of saving the patient. Okay. So what is expected from us is they ask us the names of these plans. Plan A, B, C and D. So what is plan A? Face mask ventilation and tracheal intubation. Face mask ventilation and tracheal intubation. Plan B is maintaining oxygenation through supraglottic airway device insertion. Plan C is face mask ventilation, and plan D is emergency front of neck access. Plan D is emergency front of neck access. Emergency FONA. So in a case of unanticipated difficult airway, this is how we proceed with the airway. So the plan is to intubate. If you fail at intubation, that oxygenate. If you fail at oxygenation, then just maintaining oxygenation, waking up the patient through face mask ventilation, and finally front of neck access. Front of neck access. Anshika, you only tell me at which level would be cricothyroid membrane. What is the name of the membrane? Cricothyroid. So it is between thyroid cartilage here and the cricoid cartilage here. It's a smooth membrane. You can feel it actually. If you start from your neck, then the maximum protrusion is for the thyroid cartilage, and the moment you go below thyroid cartilage, you find something smooth here, that is the cricothyroid membrane. All right, you're done writing this thing. Moving on to endotracheal tube. Moving on to endotracheal tube. Endotracheal tube is a secure airway. Secure airway. Mayor, did you join late? Did you join late? We started the discussion with steps of general anesthesia. Did you see what comes after induction and before intubation? It's for bag and mask ventilation. So doing a bag and mask ventilation or a face mask ventilation before endotracheal intubation is something that you commonly do. It is always something that you commonly do. Endotracheal intubation. Endotracheal tube is secure airway and it actually prevents aspiration. It actually prevents aspiration. It prevents aspiration. All right. Let's start with the discussion of the endotracheal tube. And endotracheal tube has a patient end and a machine end. The patient end has three things that we need to discuss. That is the bevel, Murphy's eye and a cuff. Bevel, Murphy's eye and a cuff. Now this cuff is connected to a pilot balloon assembly that has a spring loaded one-way valve. So you can push the air in, but the air will not itself come out. And then the machine end has a universal 15 mm adapter, that is to attach the breathing circuit. We'll start the discussion with the patient end of the endotracheal tube. Patient end of the endotracheal tube. And the first thing that we discuss is Murphy's eye. The first thing that we discuss is Murphy's eye. What is Murphy's eye? It is second opening in the wall of endotracheal tube. It is second opening in the wall of endotracheal tube. Second opening. What is the use? Even if the main lumen is blocked because of some reason, there is still ventilation through the secondary port. So it provides a secondary ventilation port in case the main lumen is blocked. In case the main lumen is blocked. Murphy's eye, secondary opening or a second opening in the wall of endotracheal tube. Second opening in the wall of endotracheal tube. Function is in case the main lumen is blocked, it helps in ventilation through other lumen. In case the main lumen is blocked, helps in ventilation through other lumen. Now the tubes with Murphy's eye present in them are called as Murphy types of tubes. The tubes where Murphy's eye is present are called as Murphy type of tubes. Tubes where Murphy's eye is absent are called as McGill type of tubes. Now this McGill type of tubes are used in pediatric patients, while the Murphy types of tubes are used in adult patients. McGill type of tubes are used in pediatric patients, while Murphy types of tubes are used in adult patients. So the first part of the tube that we wanted to discuss is the Murphy's eye. The tubes where Murphy's eye is present are called as Murphy tubes. The tubes where Murphy's eye is absent are called as McGill type of tubes. Next part of endotracheal tube that we want to discuss is the bevel. Bevel of the endotracheal tube. Bevel. Now what is a bevel? It is oblique cut margin of the tube. It is the oblique cut margin of the tube. Oblique cut margin of the tube. So you can imagine this as a tube, this pen as a tube. If it is hollow from inside, which it is a tube. Now you can see that there is an end. This is the end of the tube. This is a non-beveled end. That means it is a cylinder. Non-beveled end. Cylinder. If you cut this tube obliquely, here you cut this tube obliquely, then what will happen? It will become a beveled tip where one end goes straight, another is a flat portion. You can see here, this is beveling of the tip. Cut the tube obliquely. So all the endotracheal tubes are beveled and the bevel always faces left. In an endotracheal tube, the bevel always faces left. And what it helps is, it helps with improvising the view of vocal cords during laryngoscopy. You can see in the image below, if the tube is non-beveled, then while you are inserting the tube, you do not have a view of the vocal cords. While you are inserting the tube, you do not have a view of vocal cords. But if it is a beveled tip, then while you are inserting, you can actually see the vocal cords which are posterior to the tube, behind the tube, clearly while the tube is going in. So, in an endotracheal tube, the bevel always faces the left, and it improves the visualization of vocal cords while intubating. Improves the visualization of vocal cords while intubating. Improves visualization of vocal cords while intubating. And the third is the cuff. The third part is the cuff. Now this is a very, very important part. Cuff. Cuff is a very important part. Now based on the shape or the type, there are two types of cuff. A low pressure cuff or a high pressure cuff. Low pressure cuff will obviously require higher volume to inflate, so it is called as a high volume cuff, while a high pressure will require low, so low volume cuff. Low volume cuff. If you look at the shape after inflation, then a low pressure cuff, you can see low pressure, high volume, assumes the shape of a cylinder. Assumes the shape of a cylinder. A low pressure cuff assumes the shape of a cylinder, while a high pressure cuff assumes the shape of a sphere. You can see it assumes the shape of a sphere. Now if you look at this image, because it assumes the shape of a sphere, the contact area is very small in a high pressure cuff as compared to a low pressure cuff where there is large contact area. So in a low pressure cuff, the pressure on tracheal wall is low, while in a high pressure cuff it is high. The pressure on the tracheal wall is low in a low pressure cuff, while it is high in a high pressure cuff. Based on this, we have the advantages and disadvantages of both the types of cuff. The advantage of a low pressure cuff is low risk of tracheal stenosis. Why? See, if the point of contact is very small, so a very high pressure is applied on the tracheal mucosal wall. Because of this high pressure, the tracheal mucosal blood supply decreases. And when there is decrease in tracheal mucosal blood supply, there is ischemia that follows necrosis, and later on inflammatory mediators will come and they will then cause fibrosis that can cause tracheal stenosis. But if there is a large surface area of contact, then the pressure distributes, and so there is less risk of tracheal mucosal ischemia and low risk of tracheal stenosis. But the disadvantage is because of the high contact area, there can be undulations in the cuff, and so there can be micro aspiration that can seep out from the cuff. So there is a definitive risk of aspiration. A high pressure cuff has the advantage of no risk of aspiration. No risk of aspiration at the cost of increased risk of tracheal stenosis. 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 Is it okay? Is it okay? And now we actually use only low pressure cuff. PVC tubes that we see in the market are all low pressure cuff, while red rubber tubes are all high pressure cuffs, which we don't use anymore. And we keep the pressure to less than 25 mmHg by inflating a volume of air that is 4 to 8 ml. Noreen, it's written right here, right? And where are you getting confused? What is written here? What is the disadvantage of a low pressure cuff? Increased risk of aspiration. What you are saying is why high volume low pressure cuff has low risk of aspiration. Where have I written low risk of aspiration? Where have I written low risk of aspiration? सामने लिखा हुआ पॉइंट है बच्चे, गलती कहां हो रही है, कंफ्यूज कहां हो रहे हो? I am telling you that a low pressure cuff will assume the shape of a cylinder because there will be a large surface area of contact. There is a possibility that the contact might not be very snugly, and so there is a risk of aspiration with low pressure cuff. There is always a risk of aspiration with low pressure cuff. That is what I am trying to tell you. There is a risk of aspiration with low pressure cuff, while there is no such risk with a high pressure cuff. But high pressure cuffs increase the risk of tracheal stenosis, while a low pressure cuff has low risk of tracheal stenosis or no risk of tracheal stenosis. All right. We'll move ahead. Are you guys okay with this? You only tell me, Dr. Nishat. What do you think? Which should be used commonly? You have the advantages and disadvantages in front of you. Tell me, what do you think? If you are the anesthetist, then which type of tube would you want to use? If you are an anesthetist, then which type of tube would you want to use? Yes, obviously low pressure, no? Why would you want to use a high pressure where there is high risk of tracheal stenosis? You would always use a low pressure tube. That is why I told you, PVC tubes, which are the most commonly used tubes these days, are all low pressure tubes. Okay. Appropriate size. Appropriate size. How to choose an appropriate size? So for choosing an appropriate size, let's first discuss the sizes of endotracheal tube. Let's first discuss how do you define the size of endotracheal tube. How would you define the size of endotracheal tube? So endotracheal tubes can be of two types, cuffed and uncuffed. Most importantly, there can be cuffed and uncuffed tubes. And then the sizes depend on the internal diameter in mm. Internal diameter in mm. And the sizes range from 2.5 to 10.5. Every 0.5. So 2.53, 3.54, so on, so forth till 10.5. So this is how you define the size of endotracheal tube, that is internal diameter ID in mm, and that is what is written on the tube as well, internal diameter in ID mm, right? And the size depends on the age, whether it is an adult or if it is a child. For an adult, it is simple. A male will take a tube 7.5 to 9. A female takes usually 7 or 7.5. And you fix it (21 to 23 centimeters) on outer border of lip. So this is the depth of insertion, 21 to 23 centimeters on outer border of lip. 21 to 23 centimeters on outer border of lip. While if it's a child, then it depends on the age. So first thing is that in a child we always use uncuffed tubes till 6 years of age. We are using uncuffed tubes till 6 years of age. Uncuffed tubes till 6 years of age. Why do we want to use uncuffed tubes till 6 years of age? Because of very specific anatomical variation or anatomical difference between adult and pediatric larynx. Do you know what is the difference between an adult and a pediatric larynx? What is the difference between an adult and a pediatric larynx? Adult and a pediatric larynx. Yes. So pediatric larynx is funnel shaped. That is conical. So that means that narrowest portion of pediatric larynx is not the vocal cords but subglottic. Subglottic. So this subglottic portion is narrow, so that means that the cuff of tube can cause damage to tracheal mucosa, and this can lead to post-intubation croup. There will be edema. It will cause post-intubation croup. Post-intubation croup. That is the reason why we use uncuffed tubes till 6 years of age, because the pediatric larynx is like this, conical. So a tube in the subglottic region will mostly affect the blood flow of the subglottic region, and it can cause edema later on where there will be inflammation, and that can cause post-intubation croup. So when you take the tube out, the patient will have post-intubation croup. So therefore, it depends on the age of the baby, what size of tube you are going to use, right? So if it is a preterm neonate, then it will take us tube 2.5 or 3. A term neonate will take 3 or 3.5. A child, or rather an infant that is less than 1 years will take 4 or 4.5, and a child which is more than 1 year will take age by 4 plus 4. Age by 4 plus 4. Age by 4 plus 4. Where do you fix the tube in this age group? Fixed at age by 2 plus 12 centimeters. Age by 2 plus 12 centimeters. Age by 2 plus 12 centimeters. Yes, there is a risk of aspiration in children. Therefore, after intubating the child with an uncuffed tube, we do throat packing. We pack the throat. So we take the roller gauze and then we put that roller gauze all around the larynx. We fill the laryngeal opening that is around the tube with a bandage, roller gauze piece. That is called throat packing. So the secretions, they don't go inside. So this is how you choose the appropriate size. Very, very important topic. Very, very important topic. How to choose an appropriate size of the endotracheal tube. Very, very important topic. Adult, pediatric, the reason why we use uncuffed tubes in pediatric, till what age group we do not use uncuffed tubes in pediatric, and then depending on the age, what are the sizes of the tube that is used. Depending on the age, what are the sizes of the tubes that is used. Okay. Next is confirmation of the placement. Confirmation of the placement. Surest sign of intubation is visualization of vocal cords during intubation. That means while you are intubating, you can actually see the tube passing through vocal cords. When you are actually intubating, you can see the tubes passing through vocal cords. That is surest sign. No, Aditya, we have stopped using high pressure tubes. We have stopped using high pressure tubes now. The side effect, the adverse effect of high pressure tube, that is the damage to tracheal mucosa, outweighs the risk of aspiration with a low pressure cuff. So traditionally we discuss high pressure, low pressure, but with low pressure cuff the risk is marginally more than the high pressure, but the risk of tracheal stenosis is too high. So considering the risk benefit, we still use a low pressure tube. Now PVC tube is the standard tube that we use, which has a low pressure cuff. So surest sign of placement is visualization of vocal cords during intubation. That means while you are putting the tube through, you can actually see the tube going through the vocal cords. But the gold standard method is fiber optic bronchoscopy. FOB, fiber optic bronchoscopy, while the most commonly used method is capnography. Most commonly used method is capnography. Fiber optic bronchoscopy, and most commonly used is capnography. Most commonly used is capnography. This was a NEET 2021 question. NEET 2021 question. And what they gave in the option was ETCO2. This monitor is also called as ETCO2 monitor. And a lot of people got confused with ETCO2. They said, sir, capnography was not given. You taught us capnography. So capnography is measurement of end tidal CO2. And what they gave in the option was ETCO2 rather than capnography. So that is something that you have to remember, the tact in the question. Like, sometimes they are not going to give you the things that you have written in your notes, but you have to still understand them and accordingly write them. Right? Next is a note on nasal intubation. Nasal intubation, that is endotracheal intubation through nose. Nasal intubation. Indications are restricted mouth opening, oral surgeries, cervical spine injuries. Restricted mouth opening, oral surgeries, cervical spine injuries. That is anywhere where the surgical field is in the oral cavity, or you cannot open the mouth for direct laryngoscopy. Contraindications are base of skull fracture, CSF rhinorrhea, bleeding tendency and nasal polyp. Base of skull fracture, CSF rhinorrhea, bleeding tendency and nasal polyps. At least an hour from now, Matthew. At least an hour. We have to finish this portion and then start with the pre-operative assessment part. Unless until we finish pre-operative assessment and preparation, we are not going to have a lunch break. So at least an hour from now, between 1:30 to 1:45, depending on how fast you write. So now you can understand these two as a contraindication for nasal intubation, right? Because nasal mucosa is a highly vascular mucosa. So if you are putting a tube through it, there is a possibility of trauma, and then trauma can lead to torrential bleeding. But what about these two? Why do you think these are contraindications for nasal intubation? What are why these two are contraindications for nasal intubation? See, both of these conditions are associated with weak cribriform plate of ethmoid bone. So if you push the tube, there's a possibility that there is intracerebral migration of the tube. There is intracerebral migration of the tube. There's a possibility that there might be intracerebral migration of the tube. No, the common PVC tubes are both nasal and oral. The common PVC tubes are nasal and oral. They can be used both nasally and orally. All right. Next is complications of endotracheal intubation. It can happen at three levels. At intubation, when the tube is in situ, after extubation. At intubation, the most common complication is trauma. And the order of structures traumatized is larynx, pharynx, esophagus. Larynx, pharynx, esophagus. Larynx, pharynx, esophagus. Second is physiological response to laryngoscopy and intubation. That will include increase in heart rate, increase in BP, arrhythmias, increase in ICP, increase in IOP, These are all physiological responses to laryngoscopy. Physiological responses to laryngoscopy and intubation. Physiological responses to laryngoscopy and intubation. Physiological responses to laryngoscopy and intubation. What can happen when the tube is in situ? There can be endobronchial intubation. There can be endobronchial intubation. Can you tell me in which bronchus endobronchial intubation will be more common? In which bronchus endobronchial intubation will be more common? Yes. Right will always be more than left because right is shorter, wider, more in line. It is a shorter bronchus, wider and more in line with the main trachea. So if you put a tube, then it is mostly going to go to the right side. How would you diagnose endobronchial intubation? Most common used method is auscultation. What do you see on auscultation? Unilateral breath sounds. Unilateral breath sounds. Gold standard is again fiber optic bronchoscopy, FOB. Fiber optic bronchoscopy. Namita, ICP and IOP standard terminology, no? ICP is intracranial pressure, IOP is intraocular pressure. अंशिका, इट इज नॉट वी ना, अरिदमिया का वाई ऊपर से नीचे आ गया बच्चे. Increase in ICP and increase in IOP. Which modality has no role in the diagnosis of endobronchial intubation? Capnography. Capnography has no role. Why? Because even if your tube is in one of the bronchuses, still capnography will measure CO2 because the CO2 is coming from lungs. So you can't really differentiate between an endobronchial and endotracheal intubation simply by looking at a capnographic waveform. Simply by looking at a capnographic waveform. So when the tube is in situ, then the most common complication is endobronchial intubation. After extubation, the most common complication is sore throat. After extubation, the most common complication is sore throat. Sore throat. Noreen, what do you understand by endobronchial intubation? First of all, what do you understand by endobronchial intubation? That means what is the position of your tube? Is it in the trachea? Is it in trachea? No. Your tube is in one of the bronchuses, most commonly in the right side. So if your tube is in one of the bronchus and you are now ventilating through this tube, then which lung will be ventilated? Where the tube is present. So what will happen to another lung? Will you hear any breath sound in another lung where there is no tube present, where there is no ventilation happening? Tell me, Noreen. Yes, very uncommon, Nishat. Very uncommon. Mostly prolonged intubation in a hypotensive patient can lead to recurrent laryngeal nerve palsy, but that is also very uncommon. Noreen? I'm waiting for your answer. When you tell me, then I'll move ahead. Okay, okay, you said understood. All right, right? So that is why you'll get unilateral breath sounds. So this was about airway management, right? I'll wait for 2 minutes for you to ask any queries in whole of airway management, that is LMA, face mask, anything. And then we'll move on to the next topic, that is risk assessment. All right. Bougie can be used to the nasal intubation to prevent complication. See, bougie doesn't really prevent complication. Bougie helps in intubation where, uh, right, for an example, you are trying to do a oral intubation or a nasal intubation where you are not able to negotiate the tube through the vocal cords. So obviously if you insert a bougie, bougies are usually made up of flexible material, so they can be very easily bent. And so bougie will go through the vocal cords and then you can railroad the tube through the bougie, right? So you can't really say that bougie will prevent complication, but yes, bougie helps in intubation. Yes, Bishop, we use plan C, we use face mask ventilation. What about it? Who told you that face mask ventilation fails in plan A? Fails means in plan A you are just checking for face mask ventilation and then going ahead with the laryngoscopy. That is what I told you, no? Laryngoscopy is what you do to intubate. So when you say failed plan A, that means multiple attempts of laryngoscopy has failed in putting the endotracheal tube in. That is failed intubation. Where is it written that face mask ventilation fails in plan A? You check for face mask ventilation and then you do a laryngoscopy and then you do a endotracheal intubation. So your intubation fails in plan A. That is why it is called as a difficult intubation, right? So your intubation fails, not your face mask ventilation. Is it clear, Bishop? Motive not important. Leave it. Jay knows about it, therefore I answered him. If it would have been important, I would have taught him. Leave it. Not important. Okay. Now, risk assessment is done by a classification called as ASA Physical Status Classification, ASAPS. ASA is American Society of Anesthesiologists. And we have divided all the patients into 6 categories. Any patient that you get will get one of the 6 categories, and this tells us about the increasing risk of morbidity and mortality associated with anesthesia. ASA1 is a normal healthy adult. ASA1 is a normal healthy adult, non-smoker, non-drinker, the one which is very difficult to find these days. Usually I call it an imaginary patient. You don't find an ASA1 these days. Normal healthy adult. ASA2, mild systemic disease. Mild systemic disease. So the patient has a systemic disease. It is well controlled. It is mild, which does not limit any functional activity. It does not limit any functional activity. So the patient is as good as normal, like controlled hypertension or diabetes, old age, and here age is more than 70 years, old age. Age more than 70 years. Then occasional smoker, social drinker, and pregnant female. Pregnant female. These are considered to be ASA2. These are just the examples. What you have to understand is that the description is more important than the examples. And examples are just there to give you an idea that what kind of individuals will be in ASA2. But what is important is the mild systemic disease that is not limiting functional activity. A mild systemic disease that is not limiting functional activity. Now, I have highlighted pregnant female. Is pregnancy a disease? Is pregnancy a disease? No. It's just an altered state of physiology. But this alteration in physiology puts the patient at a higher risk of complication, and that is why even a normal pregnancy, normal pregnant female, that is a pregnancy not associated with any comorbidities, will still be considered as ASA2. This is the point that you have to remember. This is a very, very important point. Very, very important point. Very, very important point. Next is ASA3. Next is ASA3. It's a severe systemic disease which limits activity, but it is not incapacitating. It limits activity, but it is not incapacitating. Limits activity, but not incapacitating. What are the examples? Severe systemic disease. So uncontrolled hypertension or diabetes. Now he becomes an alcohol addict and a chronic smoker. Chronic smoker. History of myocardial infarction, coronary artery disease, stent, TIA, which is transient ischemic attack, stroke, all of which that was in distant past, that is not recent, that is more than 3 months old. More than 3 months old. A patient of ESRD, that is end stage renal disease, on regular dialysis. ESRD on regular dialysis. These are some of the examples of ASA3. These are some of the examples of ASA3. That is why I told you, no? You can't remember examples because examples can keep on changing. They can give any condition. What you have to remember is the description of that particular class. Like it is ASA1, normal healthy adult. So whenever they give you an example, you will find everything normal. ASA2, a mild systemic disease that is not limiting functional activity. ASA3 would be a systemic, severe systemic disease that limits the functional activity, but it limits the functional activity, but it is not incapacitating, that the patient is not lying on the bed, the patient is not immobile, but yes, it definitely decreases the functional activity of the patient. The next would be ASA4, which would be a severe systemic disease which is a constant threat to life. A severe systemic disease that is a constant threat to life. Severe systemic disease that is a constant threat to life. Examples: severe sepsis, ESRD, not on regular dialysis. Not on regular dialysis. Yes, months. And again, history of MI, coronary artery disease, stent, TIA, stroke. But now all of this is recent, less than 3 months old. Less than 3 months old. Less than 3 months old. So now it is recent. Now it is recent. Now it is recent, less than 3 months old. So see, there are 6 ASA classes, 1, 2, 3, 4, 5, 6. You saw 1 is normal, 2, 3, 4 are increasing risk of medical comorbidity. Medical comorbidities, increasing risk of medical comorbidities. But what about a condition where there is a surgical emergency? So let's look at ASA 5, a moribund patient not expected to survive without surgery. So it's now a surgical emergency. Example: massive trauma, head injury with raised ICP, bowel obstruction, ruptured aortic aneurysm, these are all surgically emergent conditions. These are all surgically emergent conditions. Here, surgery is imminent to saving the life of the patient. You have to immediately do the surgery. So they carry highest risk of complications that are associated with anesthesia. Highest risk of complications. right? All right. So these are the five classes where you commonly find patients, and you can classify each of them in one of these classes, and they are in the increasing order of risk that is associated with the surgery. Now again, what you will do is you will keep asking me individual doubts regarding whether it is ASA 2 or whether it is ASA 3 or it is a chronic systemic disease or it's an autoimmune disease or it is this disease or that disease. But the idea is very simple. The idea is very simple. Look at the description. Severe systemic disease, constant threat to life. Severe systemic disease limits activity. Mild systemic disease, no limitation of functional activity. So whatever you are asking me, you look at what is the level of that disease, whether it is controlled, uncontrolled. If it is controlled, then it would be 2. If it is uncontrolled, it could be 3 and 4. Between 3 and 4, if it is limiting functional activity but not incapacitating, 3. But if it is a constant threat to life, then 4. That is all I would like to tell you. Because you cannot keep asking individual things like, sir, iska kya hoga, uska kya hoga. That is why I am insisting that description pe dhyan dena hai. The description will tell you whether it is going to be ASA 3 or 4. Now the last is ASA 6, which is a brain dead organ donor. ASA 6 is brain dead organ donor. It's a brain dead organ donor. It's a brain dead organ donor. A declared brain dead organ donor. Now you'll ask, sir, why do we need to give a brain dead patient anesthesia? That is for ethical reasons, because a brain dead patient doesn't mean that they cannot feel pain. It's just that they are not able to respond to that pain, right? So we give all the things in anesthesia which we give to a normal individual, we give to a brain dead patient. Okay, so a declared brain dead organ donor. Now what is the biggest drawbacks of ASA physical status classification? Biggest drawbacks. So the biggest drawback is that it's a subjective scale. It is a subjective scale. So you and me, we can have an argument whether it is an ASA 2 or it's an ASA 3. It's a subjective scale. And second is that it has not considered the type of surgery done. Which of course becomes important because lot of complications are surgery related. In fact, the bigger the surgery, more is the risk of complication. But ASA physical status classification hasn't really considered the type of surgery as a risk factor for complications, right? So these are the two drawbacks of ASA physical status classification, that it's a subjective scale and not considered the type of surgery. Next part is pre-operative preparation, and the most important thing in preparing a patient pre-operatively is the pre-operative drug therapy. So next topic is pre-operative drug therapy. So the drugs which we discussed, the conditions that we discussed in ASA physical status classification would obviously require some treatment. So the patient will always be under some treatment because of the comorbidities that they are having. Now we need to look at the drugs that can be stopped during the surgery or the drugs that are safe to be continued. So let's start with drugs that can be stopped during surgery, that should be stopped during surgery, are the drugs affecting coagulation. Drugs affecting coagulation. The first class of drug is drugs affecting coagulation. Most common drug is aspirin. Most common drug is aspirin. And aspirin is given in two types of doses, low dose and high dose. Low dose is when you give less than 100 milligrams of aspirin per day. And high dose of aspirin is more than 100 milligrams per day. Now, a low dose aspirin can be continued during the surgery because it doesn't really increase the risk of bleeding. So, can be continued during the surgery. Low dose aspirin can be continued during the surgery, while high dose aspirin need to be stopped 3 to 5 days before surgery. It needs to be stopped 3 to 5 days before surgery. Second is a drug which is commonly given with aspirin, that is clopidogrel. Clopidogrel need to be stopped 7 days before surgery. Need to be stopped 7 days before surgery. 7 days before surgery. Then a very common drug that affects coagulation is warfarin. And we know that warfarin is a vitamin K antagonist. So it affects in coagulation factors 2, 7, 9 and 10. And this can be measured by an investigation called as PTINR. And the target PTINR for surgery is less than 1.5. So your target before you start the surgery is that the INR should come less than 1.5. Less than 1.5. But of course, if they ask you the number of days you need to stop, then 3 to 5 days before surgery. 3 to 5 days before surgery. Last is a drug which is very commonly used, low molecular weight heparins. Heparins can be unfractionated heparin and low molecular weight heparins. Unfractionated heparin is a short acting drug, so need to be stopped 4 to 6 hours before the surgery. Low molecular weight heparin again will depend on the dose, whether you are giving prophylactic dose or therapeutic dose. Prophylactic dose you need to stop 12 hours before surgery. Therapeutic dose 24 hours before surgery. Therapeutic dose 24 hours before surgery. All right. Okay, Gayatri, just finish this drawback slide. It's very simple. I've repeating it multiple times, subjective scale, and not considered the type of surgery. Jay Patel, there is no importance. Its only importance is the management of the comorbidities, right? So if the patient presents with comorbidities and if we have time and we want to control the comorbidities, then of course we send it to the physician. He gives the management plan, and only when the comorbidities are under control, then we go ahead with the surgery. So that is the importance of physician fitness. All right. Moving on to the next group of drugs, that is antihypertensives and anti-diabetic meds. Antihypertensives and anti-diabetic meds. So there is a problem. What if you stop these drugs before the surgery? What will happen if you stop these drugs before the surgery? So if you stop antihypertensive, the patient will become hypertensive and there will be hyperglycemia. Both will cause the patient to be not taken up for surgery, because then the patient would not be fit for surgery, more risk of complication. So let them be continued. So if you let them be continued, then what will happen? Antihypertensives, if continued throughout the surgery, then they will cause profound hypotension. And antidiabetics can cause unchecked hypoglycemia. Unchecked hypoglycemia. So this is the problem with antihypertensives and anti-diabetic meds. You can't stop it for a long time. You can't continue them throughout the surgery. So what do? You take drugs like ACE inhibitors and ARBs. You take all diuretics except thiazide. And you take all OHAs and insulin. All these drugs you only omit the dose on day of surgery. So it's usually a morning dose. So what happens? The immediate drug levels will fall. The immediate drug levels will fall. Right? Immediate drug levels will fall. So you will have the patient with control of hypertension and sugar, but there will not be profound hypotension or hypoglycemia. So that because the immediate drug levels will fall, the risk of profound hypotension and hypoglycemia decreases. So that is something unique. As an intern, you might have written that, omit morning dose of the antihypertensive. Usually it is telmisartan or any other ACE inhibitor that is being given, and you usually write this thing mindlessly, not thinking why you're doing this thing. The reason why you omit the morning dose is because you don't want a complication of profound hypotension and hypoglycemia. Next is herbal and Ayurvedic meds, which is very, very common these days. People take it for all types of things. They have to be stopped minimum 2 weeks before surgery. They have to be stopped minimum 2 weeks before surgery. They have to be stopped minimum 2 weeks before surgery. Psychiatric meds. As a rule, continue all meds except lithium and MAO inhibitors. Lithium and MAO inhibitors. What is the problem with lithium? Lithium causes sedation. It increases neuromuscular block and it causes dyselectrolytemia. So continuing lithium carries a lot of risk during the surgery. But if you stop them, then what will happen? The patient will go into relapse of bipolar. So therefore you need to stop it for how much? 24 to 48 hours before the surgery. If both are given in the option, best answer would be 48 hours. Best answer would be 48 hours. This is lithium. MAO inhibitors have a problem that they cause cheese reaction with opioids. Now there are two types of MAO inhibitors, irreversible and reversible. Irreversible MAO inhibitors need to be stopped 2 to 4 weeks before surgery. Reversible MAO inhibitors, you only omit the dose on day of surgery. Omit the dose on day of surgery. Omit the dose on day of surgery. Right? So this is about psychiatric meds that need to be stopped before the surgery. Psychiatric meds that need to be stopped before the surgery. Next is estrogen containing OC pills. They increase the risk of thromboembolism. Increase the risk of thromboembolism, so need to be stopped 4 to 6 weeks before surgery. Therefore need to be stopped 4 to 6 weeks before surgery. 4 to 6 weeks before surgery. Four to 6 weeks before surgery. All right. So these were all the drugs that needed to be stopped before the surgery. Rest all the other drugs can be continued. So let's write a list of these drugs. Drugs that need to be continued before the surgery. The antihypertensive cardiac medications like beta blockers, NTGs, CCBs, thiazide diuretics, statins, steroids, emergency contraception in the form of progesterone only pills, anti-epileptics, thyroid meds, ATT and ART, anti-tubercular treatment and antiretroviral therapy. Vishwajit, if you are an anesthetist and you get a case of uncontrolled hypertension for an emergency surgery, then you tell me what will you do? You tell me what will you do? In fact, because chronic steroid therapy causes suppression of HPA axis, therefore you need to supplement more steroids during the surgery. in a patient who is on chronic steroid therapy, you would actually supplement more steroids during the surgery. You would supplement more steroids during the surgery. All right. Next is cessation of smoking. ART is antiretroviral therapy. ART is antiretroviral therapy for HIV/AIDS. Cessation of smoking. Now, smoke is not a drug, but it is no less than a drug. It's a very common form of addiction, and smoking has a lot of problems associated with it. Something related to nicotine and carbon monoxide. Nicotine is an indirect sympathomimetic drug. So increases heart rate, increases BP, increases myocardial oxygen demand. Carbon monoxide causes chronic tissue hypoxia. Chronic tissue hypoxia. So it causes decreased O2 supply. So you can see when the person smokes, then there are two opposite things happening. Something that will increase the risk of complications during the surgery. Increased risk of complications during the surgery. Vishwajit, I'm still waiting for your answer. You can't simply ask a question and not answer to what I'm asking you. Doesn't work that way. See, anesthesia is a very, very practical subject. So whenever you get a question in your mind, the answer should also come from you only. And because it's a science of common sense, therefore you would find that if you ask the right questions, then the answers would automatically come to you, right? So you tell me the answer to your own question. If you are an anesthetist and there is an emergency case, something that has to be taken immediately, and the patient is, say, uncontrolled hypertensive, say 170, 180 BP, then what would you do? Now, since it is difficult to stop smoking, therefore there are different recommendations for stopping of smoking. Ideal, advised, or minimum. Ideal is when the patient stops smoking for 3 to 6 months before the surgery. Here the patient reaches the pre-smoking levels. That means it is as normal as it could be, like what he was before. But of course, waiting for 3 to 6 months for a surgery is not possible. So we advise them to stop for 4 to 8 weeks. In this, there is decreased airway reactivity and less chances of bronchospasm. Yeah. So when you are saying this thing that there is an emergency surgery, then there is no question of what will happen. You will have to continue these drugs, and then whatever happens, you will have to see and manage accordingly, right? In an emergency, nothing matters. करना है मतलब करना है. That is why it is called as an emergency, right? Where the risk of dying from the condition is more than the risk of dying from the complications of anesthesia and surgery. That is what emergency is, right? Minimum is 12 to 24 hours, which improves oxygenation, and effect of nicotine and carboxy hemoglobin is negated. effect of nicotine and carboxyhemoglobin is negated. Okay, you write this thing down. I'll remove myself from the picture. Let me know when you are done with this thing. All right. So what do you want to do? You want to finish one more topic or you want lunch break? I'm giving you an option. We have a topic of 10 minutes, 10-15 minutes, that is pre-anesthetic medication, or you want a lunch break. Since there is that issue of mess and everything, that is why I'm asking you, because I think post Diwali there is usually a problem of food. So you want a lunch break, then we can come back and start this topic. Finish the topic. Okay, so let's start with pre-anesthetic medication. So this is a very, very simple topic. Mostly you will only tell me these are all the drugs that are given before induction. These are all the drugs that can be given before induction of anesthesia. That is why the word pre. That is why the word pre. So wherever you see the word pre in anesthesia, what is the state of the patient? What does this pre mean? Pre what? Pre means before something. So in anesthesia, what does pre mean? Pre. No, Vishwajit, I'll tell you it in the break now. That was a slide that was long time back. Okay, we'll not go back. If you have something that you have not written, then we'll do it in the break or at the end of the day. You can ask me everything at the end of the day. I'll show you all the slides again. Okay. So what do you understand by the word pre? So understand this thing. Pre means before something and before induction, right? Because that is the start of anesthesia. So what is the state of the patient whenever you see the word pre in your description of anesthesia? So the patient is pre-induction. That means it's a spontaneously breathing patient, right? So this has a very important significance that will come later on, where a word pre will make a lot of difference, like conscious patient. So these are the drugs that you give to the patient before the start of induction. That is why they are called as pre-medication. So let's look at the goals. So all the problems that one would face before exam or before anything very, very important is all the problems that a patient will feel just before the surgery. So the first is anti-anxiety. Anti-anxiety. Sedation. Why? Anyone who is that anxious would not sleep. Of course, you want amnesia before surgery. What kind of amnesia? Enterograde amnesia. Enterograde amnesia. Then lot of secretions, so anti-sialagogue. Usually surgery happens for a reason. The reason is usually pain. So analgesia. Analgesia. Then so much of sleeplessness, so much of anxiety will lead to acidity. So anti-aspiration. Anti-aspiration. And all of this usually accompanies lot of nausea and vomiting. So anti-emetic. Anti-emetic. And lastly, prevention of infection, that is antibiotics. 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 These will be the goals of pre-anesthetic medication. You can all correlate to this thing. These are some things that you all experience before exam, right? So it's any stressful situation you will experience these things. Let's look at the class of drug that is used for these problems. So for anxiety, for sleeplessness, for amnesia, the class of drug that you prefer is benzodiazepines. The class of drug that you prefer is benzodiazepine. So benzodiazepine becomes the most common used pre-medication. Most commonly used pre-medication. And the agent of choice, that is the drug that is most useful as a pre-medication in benzodiazepine, is midazolam. Midazolam, because it is fast in onset and short in duration. That is what you want. You only want to tide over the crisis before the start of induction. So you want a drug that starts its action immediately after giving and is short in action. Second most common used pre-medication is anticholinergic. The drug preferred is glyco over atropine. Glyco over atropine. For analgesia, we use NSAIDs and opioids. For aspiration, we use PPIs, H2 blockers. Antiemetic, we use 5-HT3 receptor antagonist. And antibiotic type depends on the surgeon. What we are concerned about is the timing. So within 60 minutes of incision. Within 60 minutes of incision. This is a very, very important topic, that is pre-anesthetic medication. Pre-anesthetic medication. That is all the drugs that you give to the patient. All the drugs that you give to the patient before the start of anesthesia. All the drugs that you give to the patient before the start of anesthesia. All the drugs that you give to the patient before the start of anesthesia. Any doubt in this topic? Any doubt till now? All right. Now I think we can safely take a lunch break. How much time you want? 40 minutes is okay. 40 minutes is okay. So we'll take a lunch break till. Is that fine? Okay. So we'll come back at 2:25 p.m. and we'll resume with monitoring under anesthesia. Monitoring under anesthesia. In the meantime, I'm waiting for 5 minutes. If you have any doubts, you can ask me right now. Whatever we have done till now, you can ask any doubts if you want. I'll wait for 5 minutes. I'll clarify the doubt and then I'll proceed for lunch. Nikhil, see, this is something that you have to understand that the lectures that are remaining will be covered and they will be covered over a very short span of time, right? What you need to do is you need to do all the subjects that have already been covered. I'm pretty sure you have not done that till now, and start a simultaneous revision package. So November and December are the 2 months that you will keep for your first read. From January you have to start your revision. So your idea is next 8 weeks you will finish all the subjects that you have done along with all the subjects that will be done in these 8 weeks. And then from 1st of January you will start with your revision, the first revision. So that will go simultaneously with the new subjects that are happening. So you will start the revision of, so say out of 19 you are done with 15 subjects by the time it is December end. Say by the time it is December end or first week of January, everything will be over. So your idea should be, as things are happening right now, everything should be done along with it. Everything should be done along with it. Yes, that is what I am talking about, Anshika. Prophylactic antibiotic that are given before incision, that has to be given within 60 minutes of incision. Okay. So Nikhil, the idea is that you do all the subjects simultaneously that you are being done right now. So don't keep anything lagging now. कि हाँ वो करेंगे वो करेंगे. Whatever is remaining will happen. But have you done everything that has been already taught to you? No. So start doing them. Start their revision. And in the meantime, when the subjects keep getting added on, then you will keep doing them, and along with them, you have to have a revision plan. You tell me, Fatima, capnography is measuring end tidal CO2. So when your tube is in the bronchus, will it measure something else? No, it will still measure CO2. So how will you differentiate whether the tube is in trachea or bronchus? Vishwajit, again you are getting confused. If you can't discontinue, then you will get hypertension, not hypotension. When you continue it, then you get hypotension. So if the patient is on ACE inhibitors, ARBs, or all diuretics except thiazides, then you need to stop them before the surgery, on the day of surgery. While if the patient is taking any other antihypertensive, that can be continued. That is what I am telling you. It is pre-operative preparation. See, if you stop, you will get hypertension, hypoglycemia. If you continue, hypotension, hypoglycemia. So for these ACE inhibitors, ARBs, all diuretics except thiazide, OHs and insulin, you will only omit on the dose day of the surgery. Apart from that, all other antihypertensives you will continue. Anushika, you can write it. I'm showing the slide. You can write it here. Have I taught you NTR, fasting period before surgery? No, no. Don't ask things which I haven't taught you. Ask the doubts that you have from what I have taught you. And everything will be covered at the right time, at the right place. Don't worry. Okay. Now, if you all will give me permission, can I go ahead with my lunch? So, we started with pre-operative preparation and assessment. And now we'll move on to the next topic for the day, that is monitoring under anesthesia. Monitoring under anesthesia. So the first question that I want to ask you all is, why do you feel that we need monitoring under anesthesia? Why do you think we need to monitor anything under anesthesia? Is there a reason why you want to monitor anything under anesthesia? To check extubation. Okay. Can you elaborate this thing a little bit? To check extubation. What do you want to check in extubation? Risk of collapse. What kind of collapse? Why do you think we need monitoring under anesthesia? ओके शिल्पा एंड शिव दिव्यांशी, अगर आप लोगों के बीच का प्यार मोहब्बत हो गया हो तो यू कैन कॉन्सेंट्रेट ऑन द क्लास. शुभांगी, यू आर ऑलवेज कंसर्न्ड अबाउट हाउ मेनी पेजेस. बच्चे, आई टोल्ड यू द क्लास विल स्टार्ट एट 2:25. इट इज 2:35. इन 10 minutes हाउ मेनी पेजेस विल हैपन? The moment one starts the class, one should start concentrating on the thing in hand, what the faculty is trying to start the discussion or ask or something like that. Okay, the chatter should die down. Okay. Yes, so we got few answers like spontaneous respiration, smooth course during surgery, into no patient condition, to maintain homeostasis, patient responsiveness, to track patient's physiology, right? That is exactly why we are doing it. It's not just to check for extubation. Intraoperative findings are also very important, right? So what these guys are saying to check the homeostasis, or not exactly hemostasis, what you meant, Palak, was homeostasis. To check for patient responsiveness, track patient's physiology. Why? Because anesthesia is a state of altered physiology. Am I right? It's a state of altered physiology. We are changing the physiology of patient to our needs. Normally, when you give pain to someone, they will wince in pain. They will experience pain. There will be hypertension, tachycardia, moving the limb away from the stimulus. All those things doesn't happen under anesthesia. So you are changing, altering the physiology depending on your needs, and therefore you need to check every single level of that physiology. Okay. So there are different types of monitors that are used under anesthesia. Usually you see them on a multi-para monitor like this. And the types of monitoring are depth of anesthesia monitoring, pulse oximetry, capnography, temperature, ECG. These are common types of monitors that we use under anesthesia. Common types of monitors that we use under anesthesia. Right? We'll start the discussion with first monitor, that is ECG, electrocardiography, which is a non-invasive monitor. It's a non-invasive monitor. Why? It doesn't cross any body cavity. It is outside the body. So non-invasive monitor. It is used to check arrhythmias and risk of myocardial infarction, risk of MI, to check for arrhythmias and MI during the surgery. Risk of MI during the surgery. Now, of course, we cannot monitor 12 lead ECG during the surgery. So we use a combination of 3 leads, that is V4, V5 and lead 2. This gives us a 96% ischemia detection rate. 96% ischemia detection rate. So since this is a non-invasive monitor for myocardial infarction, can you think of an invasive monitor that will do the same function intraoperatively? Invasive monitor for myocardial infarction, detection of myocardial infarction intraoperatively. Invasive monitor for intraoperative myocardial infarction. Can you think of an invasive monitor for intraoperative myocardial infarction? Yes, very good. Perfect answer. TEE. Transesophageal echocardiography. That would be an invasive monitor that will monitor the myocardial infarction intraoperatively. Transesophageal echocardiography. Transesophageal echocardiography. Very good. Right? So this is the first monitor, that is ECG. Let's look at the next monitor, which is depth of anesthesia. So what do you understand by depth of anesthesia? Depth. What do you understand by the depth of anesthesia? Yes, so depth means how deep is your anesthesia, how strong is your anesthesia, right? How much have you suppressed the brain activity? So if it is checking the brain activity, then it is essentially what type of monitor? It's a CNS monitor, brain monitor. And how do we check the activity of the brain? Yes, EEG. So let's look at the depth of anesthesia monitor. The name of the monitor is bispectral index. BIS. Bispectral index, BIS. Bispectral index, BIS. It is nothing but a frontal processed EEG. It's a frontal processed EEG. So you attach the EEG electrodes on the frontal cortex, and this monitor will detect the change in the waveform and then will give it a number, right? It will give it a number. This number will tell you the level of anesthesia, right? So BIS, bispectral index, is a frontal processed EEG monitor that is used for depth of anesthesia monitoring, and it ranges from 0 to 1, so 100. 100 being a completely awake state and 0 being flatline on EEG, also called as isoelectric EEG. Isoelectric EEG. Isoelectric EEG. Now, depending on the number, you can comment about the depth of anesthesia, and you guys experience this in your classes. So this is not something that you will forget. So when you come in the morning, you start between 80 to 100. That is an awake state. That is an awake state. 80 to 100 is an awake state. Then as the class progresses, slowly, you start getting down between 60 to 80, mild sedation. Mild sedation. That is responding to loud commands, mild prodding or shaking. Then in the post-lunch session, which you are in right now, this is the best time during the class, BIS 40 to 60. That is adequate general anesthesia. There is low probability of explicit recall, unresponsive to verbal stimulus. Then by the time it is 5 or 6 in the evening, you reach a state of deep hypnotic state, which is deep GA. Deep GA. And then finally you have burst suppression and isoelectric EEG, that is just before you reach home and after you have your dinner, that is usually a heavy dinner, chicken biryani and all, because it is weekend. So then you go into a state of burst suppression or isoelectric EEG and then you go back to deep sleep. So every student during any class passes through this same phase, right? So you can always remember it by the phases that you pass through in the class. That starts with being awake, mildly sedated, general anesthesia, which is adequate, deep general anesthesia, burst suppression, and isoelectric EEG. Isoelectric EEG. All right. So this is one monitor for depth of anesthesia. There is another monitor called as entropy. Another monitor for depth of anesthesia, entropy. But both of them are commonly used, but the gold standard is middle latency auditory evoked potential, which is even more sensitive than BIS regarding anesthetic drift. So it is gold standard. It is gold standard. See, the biggest marker that in the post-lunch session the BIS goes down very rapidly is the fact that you make a joke and only 2 people respond to it. Rest of them, they probably haven't heard it, or even if they have heard it, they are like, okay, it's too boring to now go and click that you are laughing. All right. Next, let's see a very interesting monitor, that is pulse oximetry. That is pulse oximetry. Very interesting monitor, that is pulse oximetry. Pulse oximetry. Now this is something that everybody knows, especially after COVID, right? Especially after COVID. It's a non-invasive monitor. It's a non-invasive monitor. It detects O2 saturation of hemoglobin. Detects O2 saturation of hemoglobin. O2 saturation of hemoglobin. Normal value is 97 to 100%. 97 to 100%. That's an advanced neuromonitoring technique. You know evoked potential monitoring, right? Brainstem auditory evoked potential BAEP is something that you are being taught in ENT. It is just an extension of that which we use for intraoperative depth of anesthesia monitoring. Now the concept, the principle behind pulse oximetry is this law called as Beer-Lambert law. Is this law called as Beer-Lambert law? Now essentially this is very easy. What it says, we use light of different wavelengths, two wavelengths. One that has a maximum peak of absorption for oxygenated hemoglobin, another that has a peak of absorption for deoxygenated hemoglobin. And we pass it through periphery. So whichever quantity of hemoglobin is more light of that particular will get absorbed, and the returning light will tell you what is the effective saturation of hemoglobin with oxygen. This is the principle of working of pulse oximetry, which is the Beer-Lambert law, where the concentration of a given solute in a solvent is determined by the amount of light that is absorbed by the solute at a specific wavelength. Right? So the concentration of a given solute in a solvent. So here the solute is the oxygenated and the deoxygenated hemoglobin in the solvent, that is blood, is determined by the amount of light that is absorbed. So what we do is we take two wavelengths, 660 and 940. Deoxygenated hemoglobin absorbs more at 660. Oxyhemoglobin absorbs at 940. So just write this thing down. Beer-Lambert law. Beer-Lambert law. Let me know when you are done writing Beer-Lambert law. Okay. All right. Now, in this topic, the most important thing is the factors affecting pulse oximetry reading. Since morning we have started, it's been almost 6 hours since we have started. This is the single most important topic that we are going to discuss till now. सबसे ज़्यादा, every year you get question from this topic. Okay. So let's start with factors that affect pulse oximetry reading. There can be three types of factors. Factors that will cause falsely low reading, factors that will cause falsely high reading, and then there is no change in the reading. When I say falsely low reading, what does that mean? That means actual O2 saturation is higher. What you see on the monitor is lower. That is false low reading. There can be multiple reasons. The first is MET-HB, methemoglobin. That causes saturation to decrease to 85%. Why? Because methemoglobin has a absorption spectrum at deoxygenated hemoglobin. Deoxygenated hemoglobin, right? So it causes in the same spectrum as deoxygenated hemoglobin. So when there is methemoglobinemia, you see a saturation of 85%. Second is methylene blue, which shows a maximum decrease in saturation to 65%. Then a dye called as indocyanin green, ICG, indocyanin green, ICG, indocyanin green. Then peripheral vasoconstriction. And we do get conditions where we get peripheral vasoconstriction intraoperatively, like hypotension, shock, where you get falsely low reading. Then nail paints, blue, black, purple. Yes, they are a very important reason for decrease in O2 saturation. Falsely low reading and shivering. Shivering. These are some of the reasons where you get falsely low reading on pulse oximeter. Falsely low reading on pulse oximeter. Falsely low reading on pulse oximeter. Falsely high reading. That means actual O2 saturation is lower. What you see on the monitor is higher. Thankfully, we have only one example, carboxyhemoglobin. Carboxyhemoglobin. It causes chronic tissue hypoxia. You also know carbon monoxide causes chronic tissue hypoxia. So the O2 delivery to tissues is very less. So there is chronic tissue hypoxia. Still what you see on the monitor is 100% saturation. Still what you see on the monitor is 100% saturation. And then there are factors that will cause no change in the reading, like dark skin, bilirubin, sulfhemoglobin, henna or mehendi. These are certain factors where you would think that there will be decrease in saturation or there will be decrease in the reading or something like that, but actually there is no change in the reading. All right, done. So this was about pulse oximetry. Next is a very interesting monitoring technique, that is capnography. So guys, what is your BIS? How's the Josh? In the post lunch session, everybody goes quiet, you know? The doubts decrease, the activity decreases. And God knows if you are at home and you are attending the class sitting in the comforts of your bed, then by this time I think half of them you would have been asleep only. Isn't it? Happens to everyone. Oh wow, that is good. So I have 4 5 people who are listening. That is good. 4 5 is a good number. You know? Okay. As the name is suggesting, what is capnography? Capnography. It is measurement of end tidal CO2. EtCO2. Measurement of end tidal CO2. It's nice to see so many of you awake. Measurement of end tidal CO2. What is its normal value? 35 to 45 mmHg. 35 to 45 mmHg. Normal value is 35 to 45 mmHg. 35 to 45 mmHg. Right? The technology that we use to monitor end tidal CO2 is infrared spectroscopy. Infrared spectroscopy. This is the technology that we use to monitor end tidal CO2, EtCO2, infrared spectroscopy. Now, if you are monitoring capnography, that is measurement of end tidal CO2, then tell me what exactly are you monitoring in it? When you get a capnographic waveform, then what exactly is it telling you? What information you get out of it? What are you monitoring in capno? What are you monitoring in capno? So Zayed, you said CO2. Yes, that is the definition of capnography. ET tube placement, yes, but that is not what I'm asking. What I'm asking is that what exactly is it monitoring? Which physiological process is it monitoring? Correct answer is what Jawahar told. Ventilation. Yes. So if you want to know what capno monitors, then it is monitoring respiration. That is breathing. Respiration. Is it only monitoring respiration or is it monitoring something else as well? Is it also a monitor for circulation? If there is no circulation, will you get capnography? If there is no circulation, will you get capnography? No. So it's a monitor for both respiration and circulation. It's a monitor for both respiration and circulation. Yes, Shubhangi, Akshay, Bishop, Nivedi, these are all the correct answers that you are telling. All right. So it's not only a monitor for respiration but also for circulation, right? Now I want you all to draw this normal capnogram. Draw this normal capnogram. In the meantime, I'll just go down and get my cup of tea. Just draw this normal capnogram. Yep. So I'm back. Yes. At home you have to do everything yourself, especially when there are no maids post Diwali. All right. So we were discussing normal capnogram, right? So for understanding normal capnogram, you need to remember two things. One, you have to imagine being this transducer. What is this transducer's function? It is to detect CO2 in the gases that are passing through it, and the moment they get the CO2 to plot it on a graph, right? So you have to imagine being the transducer, and then second thing that you have to imagine is always start from expiration. So imagine yourself being at the end of the endotracheal tube and start with expiration. So what will you get initially? Will you get CO2 straight away? No. First you will get dead space gases. There is no exchange. So dead space ventilation. So you will get a respiratory baseline. Then the dead space gases will start getting mixed with the alveolar CO2. So dead space plus alveolar CO2. So you get a rapid expiratory upstroke. You get a सभी को करना पड़ता है बाबू. Everybody has to do everything on their own. That is the beauty of being at home. See, in hostels you can just leave the stuff and go, but somehow at home you have to do everything. घर में रहना है तो बर्तन भी धोना पड़ेगा. So expiratory upstroke. Then what will happen? Soon all the dead space gases will be exhaled out and now you will get pure alveolar CO2, that is alveolar plateau phase. So you will get a plateau, alveolar plateau phase. And at the end of this alveolar plateau phase is where you will measure the EtCO2 because that is when you have highest concentration of CO2. And what happens after expiration? There is inspiration. So there will be inspiratory downstroke. There will be inspiratory downstroke. Inspiratory downstroke. So you get respiratory baseline, expiratory upstroke, expiratory plateau, and then inspiratory downstroke. Even if you can't remember everything, just remember the basic. This is expiratory part of the curve and this portion is the inspiratory part of the curve. इतना याद रहेगा? Will you be able to remember this much? Expiratory and inspiratory part of the curve. Expiratory and inspiratory part of the curve. Will you be able to remember this much? Yes or no? Now based on this normal capnogram, we will see variations of capnogram. ठीक? So let's start with the ventilatory variation. So what happens when you hypoventilate, that is decrease in the rate or depth of breathing. When one hypoventilates, there is CO2 accumulation in lungs. CO2 accumulation in lungs. So what you will see, increased peak of the graph. This is a normal capnogram. In hypoventilation, you see hypercapnia. You see hypercapnia. In hypoventilation, you see hypercapnia. So increased peak of the graph. Increased peak of the graph. Opposite to that will happen in hyperventilation or hypocapnia. Hypocapnia, where there will be decrease or CO2 washout. There will be CO2 washout. There will be CO2 washout. Right? This is something that you will see after the event has happened. Right? So this capnograph will tell you that hypoventilation has happened. You are seeing the effect of hypoventilation, that is hypercapnia. But what if it is happening right in front of you? This is real-time picture that is happening in front of you. Suppose you decrease the respiratory rate. So what you will see subsequently, the peak goes on increasing. This is real-time picture. Or you increase the respiratory rate, so there will be decrease in the peak. This is real-time picture. This is real-time picture. This is real-time picture of capnograph. Real-time picture of capnograph. Let me know when you are done with this, then I'll move ahead. What is the width telling you? What is this width telling you? This is the expiratory phase, right? So if there is width is more, that means prolonged expiration. If the width is less, that means less time for expiration. So if the rate has increased, then the inspiration, the whole cycle shortens, right? Yes. Real-time pictures of hypo and hyperventilation. Next is this capnograph. What is happening? Baseline, expiratory upstroke, plateau. Inspiration, inspiration, again baseline, upstroke, plateau. Inspiration, inspiration, expiration. Now, what you are getting? You are getting some CO2 in inspiration, some CO2 in inspiration. What would be your interpretation of this thing? Some CO2 in inspiration. What would be your interpretation? Do you normally inspire CO2? Does your inspiratory gases contain CO2? No. So if you are getting inspired CO2, that means what is the source of this CO2? Your exhaled gases. So when you inspire your exhaled gases, this is called as rebreathing. This is called as rebreathing, which is inspiration of exhaled CO2. Inspiration of exhaled CO2. How do you identify it? The graph doesn't touch the baseline. The graph doesn't touch the baseline. What are the reasons for rebreathing? Exhausted CO2 absorber of the circuit and defective expiratory valve of the circuit. Exhausted CO2 absorber and defective expiratory valve of the circuit. Defective expiratory valve of the circuit. All right. So this is a graph of rebreathing. This is a graph of rebreathing. Rebreathing of exhaled CO2. Inspiration of exhaled CO2. Rebreathing. Rebreathing. All right. Moving on. What is happening here? What is happening? Expiration, upstroke, plateau. While the patient is expiring, there is a downstroke. Again goes back and then there's a proper inspiration. What do you think is happening here? What do you think is happening here? What do you think is happening here? Yes, there's a notch. But what is the interpretation of that notch? What is the interpretation of that notch? Yes, it's an inspiratory effort. So, this is first spontaneous breath in a patient under muscle relaxation. First spontaneous breath under muscle relaxation. This is a typical graph of curare notch or curare cleft. Curare notch or curare cleft. Curares are muscle relaxants, NDMRs. Just write muscle relaxants. Jibin, why would oxygen in expired air should cause dip in CO2? Remember, your capnograph is measurement of CO2. It has nothing to do with oxygen. Okay. But yes, when the patient inspires, then the CO2 decreases. Why? Because inspiratory gases contain no CO2 or less CO2, right? So this is curare notch or curare cleft. Now, Tell me, what would you do next? If you find this intraoperatively, what would be your next step? What would be your next step? If you find this intraoperatively, what is your next step? What would you do? So you're sitting in a case, you're a first year resident, your senior left you with the case and you got busy with your phone, checking WhatsApp and looking at Facebook. And then suddenly you look up and you realize this graph on the capnographic waveform. What would you do? What would be your next step? The surgery is still going on. Yes, so you will supplement more relaxant. Supplement more relaxant. And this is what they ask these days in the exam. They don't ask you per se the diagnosis, but what they'll give you the capnographic waveform and then they'll tell you what would be your next step. Your next step would be to supplement more relaxant. Tanisha, why would you increase the depth of anesthesia? Is anesthesia a problem here? Is anesthesia a problem here? No. You have to understand. Anesthesia is suppression of the brain, right? So there's a very good possibility the patient might be completely anesthetized, that is no explicit recall of events and the patient doesn't feel any pain, but still might be spontaneously breathing. So you don't increase the depth of anesthesia when muscle relaxant is fading off. You simply give more dose of muscle relaxant, right? Remember, increase in depth of anesthesia would not be the right answer to this question. Increase in depth of anesthesia would not be the right answer. Alright. Next. Problem is in which part of the curve? Problem is in which part of the curve? Inspiratory or expiratory? Problem is in which part of the curve? Inspiratory or expiratory? You tell me, Bishop. You tell me why notch occurs. If the patient is breathing, breathing means spontaneous breath. That means inspiratory effort. So in capnogram, in a normal capnogram, how does inspiration look like? How does inspiration look like? How does inspiration look like? Downstroke. And when the inspiration is complete, it goes back to zero. What is happening here? Is there inspiration happening? Yes. But is it an adequate inspiration, complete inspiration? No. So there will be just a notch. Again, the respiratory cycle will continue with expiration and then proper ventilator induced inspiration, right? Yes. So the problem is in the expiratory part of the curve. This is a typical curve of shark fin appearance where you see a partially obstructed endotracheal tube or obstructive lung diseases like COPD, bronchospasm, upper airway obstruction. COPD, bronchospasm, upper airway obstruction. This is a typical capnographic waveform of obstructive lung disease. You can see this looks like the fin of the shark coming out of the water. Fin of the shark coming out of the water. That is why it is called as a shark fin appearance. That is why it is called as a shark fin appearance. All right, you're done. Okay, next, tell me what is happening here. Tell me what is happening here. COPD is what type of disorder? COPD is a obstructive lung condition where there will be difficulty in expiration. So you see a acute and steep expiratory waveform, right? Which looks like a shark fin. Width of capno, simple no? The expiratory phase, this is normal capnograph. You only can tell na, if the phase 3 is longer, that means longer expiration is happening. So wider the width of capno, that means more prolonged is the expiration. Yes, very good. Cessation of expiration. Only expiration. Inspiration is present here. This is a typical flat capnogram. Typical example of a flat capnogram. What are the differentials for flat capnogram? Most common is accidental extubation. Accidental extubation. Second is disconnection. Disconnection. Then comes cardiac arrest. And when you say apnea in a ventilated patient, apnea, the reason could be ventilator failure. Ventilator failure. These are the differentials of flat capnogram. Yes, Matthew. Tube has come out. Accidental extubation. Accidental extubation. Or the transducer has disconnected. The transducer has disconnected. Or cardiac arrest. Somebody said pulmonary embolism. Somebody said pulmonary embolism. Do you think it is possible to get bilateral major pulmonary artery thromboembolism, that too at the same time? Is it possible? No. So to get a flat capnogram in pulmonary embolism, you need to have cardiac arrest as the reason for pulmonary embolism. Then only you can say pulmonary embolism is the reason for flat capnogram. Okay. Now out of these three conditions, what do you do in cardiac arrest? What do you do in cardiac arrest? When you encounter cardiac arrest, then what is that you do? Immediately start CPR. And when you do CPR, what exactly are you doing? What exactly are you doing in CPR? What exactly are you doing in CPR? You are doing chest compressions. When then chest compressions do what? Do they cause pumping of heart? Yes. So with chest compression there is pumping of the heart. There is pumping of the heart. There is pumping of the heart. So will it create ejection fraction? Will it create ejection fraction? Yes. But will it be normal ejection fraction? Will it be normal? No. So will you get normal capnogram? Will you get normal capnogram? No. So what will you get? You will get small waveforms which are erratic. This is CO2 waveform during CPR. CO2 waveform during CPR. What is the outcome of a successful CPR? The heart restarts, spontaneous cardiac rhythm. So immediately the blood flow to the pulmonary vasculature will become normal. You will get a normal capnogram. Abrupt rise of EtCO2 called as ROSC, return of spontaneous circulation. ROSC, return of spontaneous circulation. Return of spontaneous circulation. So you get three types of waveforms. One in cardiac arrest, flat capnogram, then waveform during CPR, third ROSC, return of spontaneous circulation. Is it acceptable? Have you understood this point? Have you understood this point? Yes, no, okay, thank you, sorry, good night, goodbye. Anything? Okay, moving on. What is this? Esophageal intubation. Esophageal intubation. Now, should you normally get CO2 in esophagus? Should you normally get CO2 in esophagus? Yes or no? Should you normally get CO2 in esophagus? No. Still you are getting some waveforms with esophageal intubation. Can you tell me the source of CO2 in stomach? What are the sources of CO2 in stomach? Yes, swallowed air, bacterial metabolism, bacterial metabolism, and aerated drinks. Coke, Pepsi, aerated drinks. Yes, swallowed means your exhaled gases only, which you have swallowed. Like normally when you talk, you drink water. So you are breathing, your exhaled gases contain CO2 and you can swallow some amount of that air that will contain some CO2. That is why there is a dwindling waveform that goes back to zero. Because it is very small amount of CO2, right? It's a very small amount of CO2. Problem is in which part of the curve? Problem is in which part of the curve? Problem in which part of the curve? Expiratory or inspiratory? Expiratory or inspiratory? Problem is in which part of the curve? Expiratory or inspiratory? Inspiratory. This is the only graph where there is inspiratory problem, that is incompetent inspiratory valve. Incompetent inspiratory valve. Only condition where there is problem with the inspiratory part of the curve, that is incompetent inspiratory valve. Incompetent inspiratory valve. Savita, Jibin, Virat, are you really getting confused between expiratory and inspiratory part of the curve? Go back and check your normal capnogram. Why are you saying expiratory? Is this expiratory problem? Here there is inspiration getting prolonged. This is the inspiratory part of the curve and the inspiration is getting prolonged. That happens in incompetent inspiratory valve. Incompetent inspiratory valve. incompetent inspiratory valve. All right. So these were some capnographic waveforms that I wanted to tell you, right? Now I'm going to tell you something very, very unique, that is the clinical approach to capnography, and this is what will help you solve questions in the exam. A clinical approach to capnography, clinical approach. So whenever you find a question on capnography, just look at the value of EtCO2. Value of EtCO2, that is value of capnography. Either you will get hypocapnia or hypercapnia. Either you will get hypocapnia or hypercapnia. Hypo or hypercapnia. Let's start with hypocapnia. That is when the EtCO2 is less than 35 mmHg. That is hypocapnia. Then in the question, look at whether it has happened gradual or sudden. Gradual or sudden. So hypocapnia, whether it has developed gradually or sudden. If it is gradual hypocapnia, that is because of either hyperventilation or hypotension. Hyperventilation or hypotension. Hyperventilation or hypotension. But if this gradual hypocapnia goes to zero, that means it was esophageal intubation. So dwindling waveforms going to zero. Dwindling waveforms going to zero. Dwindling waveforms going to zero. If it is hypocapnia that has happened suddenly and the position of the patient is sitting, that is, it is a sitting surgery, then it tells you that it is pulmonary air embolism. It tells you it is pulmonary air embolism. It tells you that it is pulmonary air embolism. And if it goes to zero, that means either it is disconnection or cardiac arrest. Either it is disconnection or cardiac arrest. Disconnection or cardiac arrest. Yes, we'll do it. Don't worry. Let's come to hypercapnia. Let's come to hypercapnia. Again, see whether it has happened gradually or sudden. If it is gradual and the graph is touching baseline, that means it is because of hypoventilation. If a graph is not touching the baseline, that is rebreathing. If there is sudden hypercapnia that is happening intraoperatively, that could be because of malignant hyperthermia. And if it is happening during CPR, that means it is ROSC, return of spontaneous circulation. Return of spontaneous circulation. This is the complete slide. This is a clinical approach to capnography. You can note this thing down. The moment you are done, let me know. Then I'll move ahead. If there is any doubt in monitoring in anesthesia, then you can ask now. We are done with the topic. Monitoring under anesthesia. Right. Done. So in a normal placement of airways devices can affect the capnographic form. But I didn't understand, Jay, your question. Normal placement of airway devices can affect the capnography graph. Didn't understand. Try to explain me the question first. One show malignant hyperthermia graph. Will graph touch the baseline? Depends. If there is rebreathing, the graph will not touch the baseline. If there is no rebreathing, graph will touch the baseline. But there will be sudden and abrupt rise of EtCO2. We will discuss malignant hyperthermia tomorrow, don't worry. No. Middle latency auditory evoked potential is a separate monitor. What I meant was BIS is one monitor, entropy is another monitor that relies on the same technology, that is frontal processed EEG, just it has a different name and a scale. But the gold standard is middle latency auditory evoked potential. What do you mean by abnormal placement, Jay? That is what I'm trying to understand. Now, what do you mean by abnormal placement of airway devices? If you have an endotracheal tube, either that tube is in the trachea or that tube is in the esophagus. If it is in the esophagus, you will get an esophageal graph. If it is in the trachea, you will get a normal capnograph. What other placement device are you talking about? Another is supraglottic airway device. If it is correctly placed, you will get a normal capnogram. If there is leak all around it, then of course you will not get normal capnogram. Alright. This was about monitoring techniques under anesthesia. Now let's discuss one topic before we start induction agent, and that is pre-oxygenation. So after monitoring, what we do is a step called as pre-oxygenation or denitrogenation. Pre-oxygenation or denitrogenation. Pre-oxygenation or denitrogenation. What is normal value of capnographic waveform, Anshika, sorry. 35 to 45. So anything above 45 is hypercapnia. बच्चे रियल टाइम में क्या इशू है आपको? इट इज जस्ट हैपनिंग इन फ्रंट ऑफ यू. टी ब्रेक एटलीस्ट At least an hour after this. We just started at 2:30, I guess, है ना? It's 1 hour 15 minutes. You want a tea break now? You guys want a tea break now? Are you guys sleepy? If you want it now, then we can take it now. Okay. Pre-oxygenation. What is pre-oxygenation? It is spontaneously breathing 100% oxygen to a patient before induction. Before induction. Before induction, if the patient spontaneously breathes 100% oxygen, it is called as pre-oxygenation. Okay, we'll have it after we start induction agent and we finish first two induction agents. So we'll have it around say 4:45. An hour from now. Okay. Spontaneously breathing 100% oxygen. Rather, I think I've written it little wrong. 100% oxygen to a spontaneously breathing patient before induction is called as pre-oxygenation or denitrogenation. Pre-oxygenation or denitrogenation. There are two techniques by which you can do it. Techniques. Tidal volume respiration for 3 minutes and 8 to 10 vital capacity breaths. 8 to 10 vital capacity breaths. Eight to 10 vital capacity breaths. What do you mean by tidal volume respiration? That is what you breathe, you and me breathe normally. That is 500 ml in, 500 ml out. Tidal volume respiration for 3 minutes. What is its use? Increases safe apnea time. Increases safe apnea time. What it does is it increases safe apnea time. Safe apnea time. Let's try and understand pre-oxygenation. So what are we giving? We are giving 100% oxygen to the patient. It is also called as denitrogenation. Why it is called as denitrogenation? Because 100% oxygen replaces N2 from alveoli. That is why it is called as denitrogenation. So what happens? See, we all know that what is the FiO2 or what is the, so let's see what happens before pre-oxygenation. and after pre-oxygenation. Before and after. What is the reserve of the lung for O2? That is a capacity called as functional residual capacity, which volume is 2.5 liter in a male. 2.5 liters. What happens after pre-oxygenation, or what is the O2 content of FRC? Before pre-oxygenation, 21% of 2.5 liters, that is 500 ml. After pre-oxygenation, 100% of 2.5 liters, that is 2.5 liters. What is safe apnea time? It is the time after apnea when the patient doesn't desaturate. Considering the O2 requirement to be 250 ml per minute, the safe apnea time before pre-oxygenation is 2 minutes and after pre-oxygenation is 10 minutes. This increase in the safe apnea time, will help you intubate the patient properly, because this is a good margin, right? Okay, Medha, now you tell me. You already know airway management techniques, right? Which is the first airway management technique? Which is the first airway management technique? Face mask. Okay, so you held the face mask over the face of the patient and then you ventilated through an ambu bag, the bag of ambu bag. So bag and mask ventilation, is it a spontaneous respiration or is it a controlled respiration? Is it a spontaneous respiration or is it a controlled respiration? Medha. Is it spontaneous or is it controlled? Controlled. And what is the first line you have written in pre-oxygenation? What is the first line that you have written in pre-oxygenation? What is the first line? 100% oxygen to a spontaneously breathing patient. So can it be called as a bag and mask ventilation? No, bag and mask ventilation is positive pressure ventilation given through bag and mask. This is simply spontaneously breathing 100% oxygen. So you hold the mask and you give 100% oxygen to the patient, but the patient is breathing spontaneously. The patient is breathing spontaneously. So no, pre-oxygenation is not bag and mask ventilation. Pre-oxygenation is not bag and mask ventilation. Medha, understood? So this is a very, very critical step before we start the induction of general anesthesia, that is pre-oxygenation or denitrogenation. It basically increases the safe apnea time. It increases the safe apnea time. So when we see steps of general anesthesia, we started with pre-operative assessment and preparation done, monitoring done. Let's start with induction of anesthesia. Let's start with induction of anesthesia. And what is the hallmark of induction? What is the hallmark of induction? Rapid loss of consciousness. Rapid loss of consciousness. If you don't achieve rapid loss of consciousness, then you can't call it as an induction agent. Like for an example, this lecture. Now it started at 9 in the morning and now you are still half sedated, right? You're still half sedated. Okay, finish it. Finish it and let me know. All right. Okay. So these drugs will be covered in pharmacology or not? I have no idea. I don't know what pharmacology guys teach. Safe apnea time is a time for which the patient will remain apneic during anesthesia procedure. No. When the patient is apneic, the patient doesn't desaturate. That is the safe apnea time. That is the safe apnea time. Okay. 250 ml, bacha, 250 ml. All right. So let's start with induction agent. Now, can you call this lecture as induction? Can you call this lecture as an induction agent? No. So you started at 9 and by the time it is evening 5 o'clock now, 4 o'clock. So you can't call this lecture as an induction agent. At best, it's a very good sedative agent, right? Induction hallmark is rapid loss of consciousness, and you can use two types of agent for induction: IV agents and inhaled anesthetic agents. IV agents are most common used induction agent, while inhaled anesthetic agents need to be sweet smelling for them to be used as induction agents, sweet smelling. Therefore, halo and SIVO are the only two agents that can be used for induction of anesthesia. Halo and SIVO are the only two agents that can be used for induction of anesthesia because they both are sweet smelling. They both are sweet smelling. They both are sweet smelling. Alright. Let's start with IV induction agents, and they are classified based on the receptor on which they act into GABA agonists and NMDA antagonists. GABA agonist and NMDA antagonist. GABA agonist and NMDA antagonist. Start with barbiturates. Propofol, etomidate, benzodiazepines. Can you name one NMDA receptor antagonist? Yes, ketamine. Ketamine. NMDA receptor antagonist, ketamine. Now you would wonder that how come benzodiazepines are both excellent pre-medication and they can be induction agents, so they cannot be. In modern anesthesia, there is no role of benzodiazepine as an induction agent. Now they are not used anymore. But if at all they ask you which agent could have been used for induction, the answer would be midazolam only. No other benzodiazepine is capable of inducing a patient. Only midazolam is, right? All right. Now what we are going to do is we are going to compare and contrast two agents. So we'll start with barbiturates and ketamine. So we'll do them together because that way it is easier to remember. So let's start with the first two induction agents, that is barbiturates and ketamine. Barbiturates are barbituric acid derivatives, while ketamine is a phencyclidine derivative. Barbituric acid derivative and phencyclidine derivative. There are two drugs which are important in barbiturates, thiopentone and methohexytone. Thiopentone and methohexytone. Thiopentone is the prototype drug and we'll discuss thiopentone in great detail. Methohexytone is not used anymore. It is a pro-convulsant agent. And that is why it only finds its use as the agent of choice for ECT. You know what is ECT? Electroconvulsive therapy, ECT. Because it's a pro-convulsant agent, so it is considered to be agent of choice for ECT, electroconvulsive therapy. Electroconvulsive therapy. That is its only theoretical indication. Otherwise, this drug is not available in the market anymore. Right? Now what we are going to do is we are going to discuss thiopentone and ketamine as drugs. So let's start with physical and chemical properties. Thiopentone is a yellow amorphous powder. It is a yellow amorphous powder. It is available in a vial with nitrogen as atmosphere and sodium carbonate It is a highly alkaline drug. pH is 10.5. Therefore, it needs to be reconstituted in normal saline or distilled water. Because it is so alkaline, therefore avoid Ringer's lactate. Otherwise, there will be precipitation of the drug. Ketamine, on another hand, it's a clear, colorless, water soluble liquid that causes no pain on injection. Clear, colorless, water soluble liquid that causes no pain on injection. It is a clear, colorless, water soluble liquid that causes no pain on injection. No pain on injection. Alright. These are physical and chemical properties of thiopentone and ketamine. Now, Namita, just finish this slide fast. Finish this slide fast. All right. Done. Are you done writing this thing? Let me know when you are done. Then we'll move on to the next portion. All right. It is available in a vial, bacha. You can see this is a thiopentone vial. It contains a powder that is yellow. The air under this vial contains nitrogen, and as a stabilizer there is a chemical called as sodium carbonate. That is what it means. Next is mechanism of action. Mechanism of action. So let's look at the receptor on which thiopentone acts. GABA A. What is the action on this receptor? Agonist. And how does it cause agonism? Increased duration of opening of GABA. Increased duration of opening of GABA. What is the site of action? Reticular activating system, RAS. That is why there is immediate unconsciousness. That is why there is immediate unconsciousness. If you look at ketamine, the receptor on which it acts is NMDA, and the action is antagonist. And the site of action, just like how you remember any other, pharmacology is all about this only, right? How do you remember pharmacology? It's just repetition. You just keep on reading it again and again. If you apply it in questions, then you will start remembering everything. Everything is correlated, no? अभी तो information चालू हुआ है. You have just started knowing the information things, right? It is just the second point in a drug, that is mechanism of action. There will come pharmacokinetics and dynamics and adverse drug reactions. And that for all the 4 induction agents, then all the 6 inhaled anesthetic agents, all the muscle relaxants, all the reversal agents, everything, right? So it's step by step. Just keep on reading and keep on revising. That is the way you will remember everything. The site of action makes the use of ketamine very, very unique. The site is thalamocortical junction. The site of action is thalamocortical junction. And this site of action causes a state called as dissociative anesthesia. Dissociative anesthesia, where the person appears awake. How can you tell that the person is appearing awake? How can you remember that the person, how can you appreciate that the person is appearing awake? So they will show signs of being awake, like blinking of eyelid, swallowing, lip smacking, nystagmus, but no response to sensory stimulus. But no response to sensory stimulus. This is a typical state called as dissociative anesthesia, and that is because of its unique site of action, that is thalamocortical junction. Unique site of action because of action on thalamocortical junction. All right. So this is about mechanism of action of thiopentone and ketamine. Let's see the pharmacokinetic properties. Pharmacokinetic properties. Let's start with onset of action. So onset of action of thiopentone is called as one arm brain circulation time. That in a normal individual is 15 to 20 seconds. So an agent that starts at action in 15 to 20 seconds is called as ultra fast. Ultra fast. Duration of action. Duration of action less than 20 minutes. That is ultra short. This is only seen after single dose. After single dose, due to the phenomena of redistribution. Phenomena of redistribution. That is because thiopentone is a highly lipid soluble drug. So the moment you give it, it redistributes to the peripheral compartment. Zayed Ras is reticular activating system. Reticular activating system. Metabolism. Liver. Metabolism, liver. One arm brain circulation time. Arm brain circulation time. It is the time for the drug to reach from the site of administration, say peripheral dorsal vein, to the brain. Arm brain circulation time. Arm brain circulation time. Complete this. Let me know when you are done writing. All right. Everybody okay with this? Let's see ketamine. Let's see ketamine. So most important thing in ketamine is routes of administration. And there are wide variety of routes of administration like IV, IM, oral, rectal, intrathecal, epidural. So almost all possible routes of administration are possible with ketamine. Second is metabolism. And metabolism of ketamine is by liver, and that forms an active metabolite, that is norketamine, which is active, and this is then excreted renally. Excreted renally. Which is then excreted renally. Right? So wide variety of routes, IV, IM, oral, rectal, intrathecal, epidural, even subcutaneous, intranasal. All these are routes of administration of ketamine. Metabolism by liver makes an active metabolite, norketamine, excreted renally. Excreted renally. Next is pharmacodynamics, that is effect on body systems. And this forms the basis of use. So this is very, very important, right? This forms the basis of use. So very, very important. Let's start with CVS. Let's start with CVS. Not important. Whatever I'm making you write is the only thing that you have to remember. We are not discussing everything about everything. Remember this thing. These are very, very concise pharmacological points that I'm telling you. We will only cover things that are important. ठीक है, सब ड्रग का सब कुछ ना जानना है ना करना है. CVS. So thiopentone is a myocardial depressant. So it decreases cardiac output, which in turn will decrease BP. And what is the reflex response to decrease in BP? Increase in heart rate. So you will find tachycardia with hypotension when thiopentone is given. Tachycardia, hypotension. Tachycardia, hypotension. Ketamine, on the other hand, has two distinct action: an indirect sympathomimetic action and a direct myocardial depressant action. Direct myocardial depressant action. This indirect sympathomimetic action is the dominant action, and therefore use of ketamine is associated with increase in heart rate and increase in blood pressure. That is because of increase in the SVR. What is SVR? Systemic vascular resistance. So this happens because of increase in the SVR. Systemic vascular resistance, that is peripheral vasoconstriction. Systemic vascular resistance, that is peripheral vasoconstriction. All right. Next is respiratory system. Next is respiratory system. So thiopentone causes apnea on induction. Thiopentone causes apnea on induction. At the same time, it causes incomplete suppression of airway reflexes. It causes incomplete suppression of airway reflexes. This can pose a problem in two groups of individuals. If the patient is lightly anesthetized, this can cause laryngospasm. But if the patient is a known case of asthma, then this can lead to bronchospasm. This can lead to bronchospasm. If you look at ketamine, it is exactly opposite of thiopentone. Max preservation of respiration. Max preservation of respiration. Max preservation of reflexes. Max bronchodilation. And increased airway secretions. Increased airway secretions. So you will see that the actions of ketamine and thiopentone are almost opposite to each other. They are almost opposite to each other. One causes apnea on induction, other causes maximum preservation of respiration. One causes incomplete suppression of airway reflexes, another preserves the airway reflexes. One causes bronchospasm, another causes bronchodilation. Bronchodilation. Right? Next is CNS. Next is CNS. So, thiopentone is a cerebral vasoconstrictor. Cerebral vasoconstrictor. So, if it causes cerebral vasoconstriction, then it decreases cerebral blood flow, which in turn decreases cerebral blood volume, which decreases ICP. And this action of thiopentone is maximum amongst IV agents. Preserves as in suppression matlab? Divyanshi? Preserves airway reflexes. That means doesn't suppress ना, तभी तो preserve हुए ना. Airway reflexes suppress हो गए तो preserve कैसे हुए? It preserves airway reflexes मतलब doesn't suppress airway reflexes. Second, it decreases CMRO2. It decreases CMRO2. What is CMRO2? Cerebral metabolic rate for oxygen. That is O2 requirement of the brain. If an agent decreases CMRO2, what do you think it is? Neuroprotective or neurotoxic? Neuroprotective or neurotoxic? Neuroprotective. Why? Because the neurons under the effect of thiopentone will be better protected against hypoxia. Because their requirement is less, so they will be better protected against hypoxia. Better protected against hypoxia, right? So they decrease CMRO2. Then thiopentone is anti-analgesic. Thiopentone is anti-analgesic. It's an excellent anticonvulsant. Anticonvulsant. No muscle relaxation. No muscle relaxation. No muscle relaxation. These are some of the CNS properties of thiopentone. If you look at ketamine, exactly opposite. Cerebral vasodilator. So increase in ICP, increases CMRO2, excellent analgesic, proconvulsant, and antidepressant. Antidepressant. So you can see that the CNS properties are also opposite to each other. CNS properties are also opposite to each other. Right? Let me know when you are done writing this thing. Cerebral blood volume, Kritika. Cerebral blood volume. Alright. Next is an action that is different. For thiopentone, let's talk about its action on liver. And since thiopentone is a hepatic enzyme inducer, therefore it increases porphyrin production. That can precipitate an attack of porphyria. Precipitate an attack of porphyria. Therefore, use of thiopentone is contraindicated in patients with AIP and variegate porphyria. Therefore, use of thiopentone is contraindicated in patients with variegate porphyria. While it is safe to use in Porphyria cutanea tarda. Porphyria cutanea tarda. Porphyria cutanea tarda. Alright. Next system or for ketamine is uterus, and ketamine has max uterotonic action. Maximum contraction of the uterine muscles. Max uterotonic action. Okay, Namita, is it clear? Your query got embedded in the chat, so I couldn't do it, but Noreen was kind enough to explain it in a very precise manner that when cerebral metabolic rate decreases, O2 requirement decreases, and so yes, they are better protected against hypoxia. Let's start with indications and contraindications. So indications of thiopentone, its use as an induction agent is very famous. It is actually second most common used induction agent, first being propofol, and it is agent of choice for raised ICP surgery. Raised ICP surgery. It is also considered to be second best for neurosurgeries. Second best for neurosurgeries. Thiopentone is also used for narco analysis. It is also used for narco analysis or lie detector test. Narco analysis or lie detector test. And it is used as an anticonvulsant. It is used as an anticonvulsant. Contraindicated in cases of shock or hypotension, status asthmaticus, and AIP. Shock, hypotension, status asthmaticus, AIP. Right? Ketamine, on another hand, has wide variety of indications. Let's look at its indication as induction agents. It is agent of choice for asthma because of bronchodilation, acute shock because of increase in heart rate and BP, pediatric patients, painless injection, PPH, increase in tone of uterus and increase in heart rate and BP, field anesthesia, that is anesthesia in war zones, field anesthesia, that is anesthesia in war zones, and full stomach patients. Full stomach patients. So ketamine is used as an induction agent of choice for wide variety of cases: asthma, acute shock, pediatric, PPH, field anesthesia, full stomach patients. They are also used as agent of choice for cyanotic congenital heart disease, right to left shunt patients, that is TOF, tetralogy of Fallot, TOF. Florence. What is Florence, Jay? Never heard of such a drug. Florence. Is it a, is it a pharmacological drug or a drug of abuse? Now, what is the importance of using ketamine in cyanotic congenital heart disease? Increase in SVR causes decrease in right to left shunt. Increase in SVR causes decrease in right to left shunt. So less risk of hypoxia. Less risk of hypoxia. Second, it can be used for short surgical procedures. Short surgical procedures. Example, burns dressing. All right. बेटा अगर कुछ पीछे छूट गया आप लोग का तो then that would be considered in the last, है ना. I have already reached the end of indications and you are now asking a slide of liver, so that is going way too back, है ना. That means that you just missed it that time, so we can cover it later on when we take a break. I will give you 2 minutes where you can ask all these things, right? Contraindications of ketamine. Contraindications of ketamine. Contraindications of ketamine. So it should not be used in uncontrolled hypertension, ischemic heart disease, aortic aneurysm, Yeah, I told you at the start only, no? Sevoflurane can be used as an induction agent. Suddenly, why did it crop in your mind? Is this discussion boring for you, Jay? I mean, we are in the middle of indications and you are asking about sevoflurane. क्या logic है? Raised ICP, open eye injury, glaucoma, and history of psychiatric disorders. History of psychiatric diseases. These are contraindications to the use of ketamine. Contraindications to the use of ketamine. Contraindications to the use of ketamine. All right, let's see the adverse drug effects. Let's see the adverse drug effect. So otherwise it's a very safe drug, but when thiopentone gets accidentally injected in an artery, then it causes problem. Why? Because it's a highly alkaline drug. So it's very noxious for the artery, right? So immediately what will happen? That there will be thrombosis, which will lead to vasospasm, that will lead to ischemia, necrosis, and finally gangrene. So intra-arterial injection of thiopentone can cause losing of limb. That is the seriousness of the situation. First symptom would be intense pain on injection. Intense pain on injection. First sign would be no effect of the drug. These two things should prompt you to believe that it is intra-arterial injection. Like you gave the drug and the patient yelled in pain. He not only yelled in pain, but at the same time there was no effect of the drug. So there was no induction of anesthesia. The patient was still awake and wincing in pain. How would you manage this condition? Management. The first step is to keep the needle in situ. First step is to keep the needle in situ. That means do not remove the needle, because this is the only source by which you can give drug to the artery. So keep the needle in situ. Flush the artery with heparinized normal saline. Flush the artery with heparinized normal saline. So this will decrease the chances of thrombosis and will dilute the drug. Then give intra-arterial lignocaine that acts as a membrane stabilizing agent and prevents vasospasm. Then for pain relief, we can give stellate ganglion block and brachial plexus block, which acts as both analgesia and sympathectomy. And then vasodilator substance like prostacyclins. Vasodilator substances like prostacyclins. This is how you manage intra-arterial injection of thiopentone. This first step is what is the source of maximum number of questions, that is keeping the needle in situ. Keeping the needle in situ. Keeping the needle in situ. Alright, let's look at adverse drug effect of ketamine, and the effect is called as emergence delirium, whereby a patient experiences extrasensory perceptions and hallucinations, which are auditory more than visual. This is a very classic phenomena described with ketamine. Okay, I'll go back to that slide, not a problem. Shubhangi, don't worry, I'll go back to that slide. You want to finish this? Okay, first finish this, no problem. First finish management of intra-arterial injection of thiopentone. We'll again go back to emergence delirium, not a problem. Let me know when you are done writing this thing, then I'll move to the next thing, that is adverse drug effect of ketamine. Okay, Mohammad Rafi. Done? Okay. Next we'll see adverse drug effect of ketamine, which is the phenomena called as emergence delirium, where the patient has extrasensory perceptions and hallucinations which are auditory more than visual. If it is not acceptable to the artery, it will immediately show that response. There will be immediately thrombosis, formation of thrombus. Because it's a highly alkaline drug, it is not acceptable to the artery. So it's very noxious to the artery. Therefore, there will be immediate thrombosis. Right? It's like an inflammatory response in the artery. And that inflammation, localized inflammation, will lead to intense vasospasm. That vasospasm is the reason for intense pain. All right. So we are done with the first two induction agents, that is thiopentone and ketamine. Now, who said lignocaine causes vasoconstriction? Is it written anywhere that lignocaine causes vasoconstriction? Lignocaine is a local anesthetic. It mostly causes vasodilatation, one. Second, it has an excellent membrane stabilizing action. It has an excellent membrane stabilizing action. So it actually prevents the development of vasospasm. It prevents intra-arterial lignocaine will prevent the development of vasospasm. Okay. So let's take a break for 10 minutes. We'll come back at 5 and we'll start with the discussion of propofol and etomidate. Okay. We'll start with the discussion of propofol and etomidate. All right. Yes, Virat. All right. So let's take a break. Only in the artery, bache. That is why it is written, no? If the same thing happens in veins, then how would you give the drug? आप पेशेंट इंड्यूस कैसे करोगे अगर सेम चीज वेन्स में होगी तो? सोचो ना, इंट्रावेनस लाइन से ही तो ड्रग इंड्यूस कर रहे हो. इफ द सेम थिंग हैपेंस इन वेन्स, देन हाउ कैन? ओके, लिवर. Management is nothing. It is you give less dose of ketamine, one, and secondly, you can use certain sedatives along with ketamine like midazolam that will decrease the intensity of emergence delirium. Otherwise, it's a complication of the administration of ketamine. I mean, that's like an extension of effect which is causing the trouble. So there's nothing much you can do about it. Sahil, because no pain on injection. In pediatric patients, you would want something that is acceptable to the baby. So no pain on injection. No pain on injection. That is why it is preferred in pediatric patients. All right. So let's take a break, come back in 10 minutes, and then we'll resume with propofol and etomidate. Right. So we'll start again. Right. Let's start with the next two, which is propofol and etomidate. Propofol and etomidate. Next two induction agents, that is propofol and etomidate. Everybody is here? Now, since you saw that thiopentone and ketamine were quite opposite to each other, right? They were quite opposite to each other. Propofol and etomidate, they are pretty similar to each other, right? So let's start with physical and chemical properties. Physical and chemical properties. So propofol is a phenol derivative. while etomidate is a imidazole derivative. Propofol is a phenol derivative, while etomidate is a imidazole derivative. Let's look at the things that are common between the two. Let's look at things that are common between the two. Both are milky white, oil in water emulsions. They are both milky white, oil in water emulsions. Oil in water emulsions. They both cause pain on injection. They both cause pain on injection. This pain can be decreased by choosing a larger vein, adding lignocaine, and aspirating blood in syringe before administration. Choosing a larger vein, adding lignocaine, aspirating blood in the syringe. Let's look at the contents. Let's look at the contents. So propofol contains eggs. That is egg lecithin, glycerol, soybean oil. Egg lecithin, glycerol, soybean oil. You can see, since it contains so much of edible material, therefore it is prone to bacterial infection, bacterial contamination. Therefore you discard an open vial after 6 hours. You discard an open vial after 6 hours. Prone to bacterial contamination, therefore you discard an open vial after 6 hours. Also, you can add EDTA to the solution that acts as preservative. You can add EDTA that will act as preservative. Since propofol contains egg lecithin, it should be contraindicated in egg allergy. Yes? Yes or no? Since propofol contains eggs, it should be contraindicated in egg allergy. Yes? So write safe in egg allergy. Safe in egg allergy. Now, etomidate causes maximum pain on injection. Max pain on injection. That is because it contains propylene glycol. That is because it contains propylene glycol. That is because it contains propylene glycol. Is it? Sahil? Have I told you wrong? Or have I written it right and now I'm wanting you to justify this thing? Contains egg lecithin but still safe in egg allergy. Contains egg lecithin but still safe in egg allergy. What is the component of the egg that is an allergen, that acts as antigen? It is it is the yes, the proteinaceous part of the egg, no? While what you're adding in the propofol is the lipid component of the egg. Lipid component of the egg. So there is no cross reactivity. So it's actually safe in egg allergy. It is actually safe in egg allergy. Okay. Just write this table down. I'll come in a minute. Okay. Right? Sorry. Let's start with mechanism of action. And the mechanism of action of both propofol and etomidate is one of the best mechanisms that you will come across, because we only know that they are GABA agonists, nothing else. So one less thing to remember, only GABA agonists. One less thing to remember. All right. Next is pharmacokinetics. Only relevant pharmacokinetics will be discussed for propofol onset. Again, ultra fast. That is 1 arm brain circulation time. That is 15 to 20 seconds. Duration of action, ultra short, which is less than 10 minutes. So it is even less than thiopentone. And the hallmark is clear-headed recovery. The hallmark of this ultra short duration of action is clear-headed recovery. Ultra short duration of action is clear-headed recovery. That means no residual neurological deficit. No residual neurological deficit. That means the level of consciousness of the patient after the effect of propofol has weared off will be exactly the same as it was before. So no residual neurological deficit. No residual neurological deficit. Etomidate, on another hand, we need to know only two things: metabolism by non-specific ester hydrolysis, and also shows the phenomena of redistribution. 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 All right, done. Next is pharmacodynamics, that is the effect on body systems. Let's start with CVS. And propofol again is a myocardial depressant. Propofol again is a myocardial depressant, so decrease in cardiac output, that will cause decrease in BP, but there won't be reflex tachycardia. In fact, there will be bradycardia because it also blunts the baroreceptor reflex. So there will be bradycardia and hypotension. On the other hand, etomidate is unique that it is the only cardiostable agent. It is the only cardiostable agent. That means it maintains cardiac output and in turn maintains heart rate and blood pressure. So whatever is the state of the heart, whatever is the level of hemodynamics, it will remain the same. Whatever is the level of hemodynamics, it will remain the same. It's a cardiostable agent. It's a cardiostable agent. Respiratory system. Propofol causes apnea on induction and maximum suppression of airway reflexes. Maximum suppression of airway reflexes. Apnea on induction and maximum suppression of airway reflexes. Is this of any advantage to us? Have we read it before? Why is this of an advantage to us? Maximum suppression of airway reflexes. Maximum suppression of airway reflexes. Yes. This is the reason why it is agent of choice for SAD insertion. Agent of choice for SAD insertion. Etomidate causes less apnea than propofol. Etomidate causes less apnea than propofol. Less apnea. Yes, Akansha, absolutely correct. Less apnea than propofol. Third is CNS. Third is CNS. Now, first 2 points are common between the two. Decrease in, so Sahil, I didn't understand your question. Decrease He by propofol. It also blunts the baroreceptor reflex, which is responsible for mounting the tachycardic response to hypotension. It also blunts that. So you not only get hypotension, but you also get bradycardia. In CNS, propofol and etomidate both are cerebral vasoconstrictors. So they both decrease ICP. They both decrease CMRO2. So they both are neuroprotective. Although maximum decrease in CMRO2 amongst all IV agents is seen with propofol. Maximum decrease in CMRO2 is seen with propofol. These two properties on CNS are common between the two. It is common between the two. Then propofol is actually an anticonvulsant, while etomidate is a proconvulsant. Propofol has no muscle relaxation, while etomidate causes myoclonus and hiccups. Propofol has anti-emetic and antipruritic property. Anti-emetic and antipruritic property, while etomidate is associated with max post-operative nausea and vomiting, PONV, max post-operative nausea and vomiting. Propofol also decreases IOP, intraocular pressure. It also decreases IOP, intraocular pressure. Yes, PONV is post-operative nausea and vomiting. Post-operative nausea and vomiting. It's short form for post-operative nausea and vomiting. Let's look at the uses. Let's look at the uses. And propofol as an induction agent is most commonly used induction agent. As an induction agent, it is most commonly used. As an induction agent, it is most commonly used. It is agent of choice for neurosurgeries, daycare surgeries, known case of malignant hyperthermia, known case of AIP, known case of acute intermittent porphyria, and SAD insertion. It is considered to be second best agent of choice for raised ICP surgery. Second best agent of choice for raised ICP surgery. So this is where you can use interchangeably thiopentone and propofol. Most best drug for raised ICP surgery, thiopentone. Second best second best propofol. Best for neurosurgery, propofol, and second best for raised ICP surgery is propofol. Okay. Now, etomidate, because of its unique action of being cardiostable, it's used as an induction agent of choice for cardiac patients. Low ejection fraction, aortic aneurysm, and it is second best agent of choice for ECT, electroconvulsive therapy. Second best agent of choice for ECT, electroconvulsive therapy. Now let's look at the order of drugs that can be used for ECT. Order, which is the agent of choice, methotrexate. First is methotrexate. MH is malignant hyperthermia. Second is etomidate. Third is ketamine. Fourth is thiopentone, and finally propofol. You have to remember this order of induction agents that can be used in ECT. This was asked in JIPMER 2 years back. This was asked in JIPMER 2 years back. All right. So this is about their uses. Let's look at the adverse drug effects. Let's look at the adverse drug effects. And otherwise, propofol is a very safe drug. But when it is over abused, that is, it is used in large doses of more than 4 mg per kg per hour for more than 48 hours, then it causes it causes free fatty acid metabolism error. causes free fatty acid metabolism error, which presents as a syndrome. Which presents as a syndrome. It causes free fatty acid metabolism error, which presents as a syndrome with cardinal feature of acute refractory bradycardia that can progress to asystole. It is that severe. Acute refractory bradycardia that can progress to asystole with along with one or many of the following: skeletal myopathy, rhabdomyolysis, hyperkalemia, metabolic acidosis, acute cardiomyopathy, and fatty liver. Acute cardiomyopathy and fatty liver. Acute cardiomyopathy and fatty liver. This is a fatal condition. Very difficult to treat. Fatal condition. In treatment, you can try hemodialysis. Usually doesn't work. When the cardiac arrest happens, then CPR can be given. And finally, you can put the patient on ECMO, that is artificial life support. ECMO. ECMO. Right? So it's a cardinal feature of acute refractory bradycardia. I'm not going anywhere, don't worry. So I have written my part, then I'll just wait for you guys to write it. See, this is just enumeration, there is nothing much. So I want you to all write very fast. Right? When there is enumeration, there is nothing much. If there is some concept, then I will definitely deal with it. But it is just enumeration, right? So when you give propofol in a large dose of more than 4 mg per kg per hour for more than 48 hours, then it causes free fatty acid metabolism error, which then presents as acute refractory bradycardia that can even progress to asystole with one or many of the following features. Okay, you want me to wait? I'll wait. Okay, take your time. Okay, okay. Somebody wanted this intermediate slide, right? Just finish this thing, intermediate slide. I'll wait for 2 seconds here. Done? Let's look at etomidate. Now, etomidate causes dose-dependent inhibition of an enzyme. Etomidate causes dose-dependent inhibition of 11 beta hydroxylase enzyme. Dose-dependent inhibition of 11 beta hydroxylase enzyme. This enzyme is involved in steroid synthesis, so it causes adrenocortical suppression. Causes adrenocortical suppression. Right? Causes adrenocortical suppression. So this is the problem with etomidate. Right? So these were induction agents in anesthesia, IV induction agents in anesthesia, IV induction agents in anesthesia. Now there is something that I want you to note, that is identification of induction agent based on change in hemodynamics. So when you are given hemodynamic parameters, then based on that you can always comment about which induction agent was used. Which induction agent was used. So if you get, there are 4 scenarios. You will get hypotension, bradycardia, hypotension, tachycardia, hypertension, tachycardia, and no change in heart rate and BP. So come on, tell me. You can refer to your notes also, not a problem. Flip your notes and tell me the right answer. If you give an induction agent and you see hypotension, bradycardia, then which induction agent was being given to the patient? Yes, propofol. If you get hypotension, tachycardia, that means you have given thiopentone, hypertension, bradycardia, ketamine, and no change in heart rate and BP, etomidate. And this is a very common source of questions that we get in exam, whereby there will be a long stem question where they will just change the hemodynamic parameters before induction, after induction, and they will ask you which of the following agents was used for induction of anesthesia. All right. So this was about induction agents in anesthesia. Let's now move on to the next topic, which is, so we have done pre-operative assessment, monitoring, induction. Next step is bag and mask ventilation, and after that we intubate the patient. For intubation we require muscle relaxants. We require muscle relaxants. So tell me, what is the need of doing bag and mask ventilation between induction and intubation? Now this is something that I've already taught you. Now this is a correlational question. This will establish whether you are aware of the proceedings in anesthesia or not, or things are still very discrete for you. So think about it for a minute. I'll give you a minute's time and tell me, why do you think there is a need of performing bag and mask ventilation between induction and intubation? Between induction and intubation. Okay, Ram said pre-oxygenation. Managing sudden apnea to prevent cerebral hypoxia. Okay, tell me, after pre-oxygenation, what did your safe apnea time become? Lot of people are saying pre-oxygenation. Very good. Very proud of you. What do you understand by the word pre in pre-oxygenation? Ram, Akansha, Zaid, Mamdha. Tell me, what do you understand by the word pre in pre-oxygenation? What do you understand by the word pre in pre-oxygenation? So if the pre in pre-oxygenation means before induction and you are doing it after induction, can it be called as pre-oxygenation? Also, pre-oxygenation is spontaneously breathing 100% oxygen. Is the patient spontaneously breathing in bag and mask ventilation? After induction, most of your induction agents cause apnea. And you said, sir, to maintain oxygenation during apnea. But when you did pre-oxygenation here, what did your safe apnea time become? 10 minutes. Induction usually takes one arm brain circulation, that is 15 to 20 seconds. So say even it takes 30 seconds. Then you still have 9.5 minutes left of oxygen with you. Why do you need to do bag and mask ventilation? Think of it. If it would have been so easy, then I wouldn't have asked you. I have already taught you the importance of this bag and mask ventilation between induction and intubation. You just have to correlate that. You can flip your pages and try and see if there is some place where you can use this concept of bag and mask ventilation to effect. This is a very, very important reason why we perform bag and mask ventilation between induction and intubation. Nobody? Nobody? Okay. Chalo, it's fine. Now I want you to go to difficult airway guidelines and tell me what is plan C of difficult airway guidelines. What is plan C of difficult airway guidelines? Plan C. Seriously, bag and mask ventilation to decrease aspiration? Is that what I taught you in drawbacks of bag and mask ventilation? Is that what I taught you? Final attempt at face mask ventilation, right? So when your plan A fails, then you go to plan B. When your plan B fails, then you go to plan C. And when your plan C fails, then you are in a very difficult situation because then your patient is almost going to die. It is CICO, can't intubate, can't oxygenate. So your plan C is what will save the patient from dying. But how will you know that if you can do plan C properly? That is only when you check for it before you actually give muscle relaxants, because once you give muscle relaxants, there is no going back. So just right in front of this bag and mask ventilation, that is to prepare for plan C. Prepare for plan C. To prepare for plan C. Right? This is the importance of bag and mask ventilation between induction and intubation, because once you give muscle relaxants, then you cannot do really anything. Once you give muscle relaxants, you cannot really do anything. Once you give muscle relaxants, you cannot do anything. Understood? Did you understand what I'm trying to tell you? All right. Let's start with muscle relaxants. Jay Patel, that is exactly what I'm trying to tell you. That after you do pre-oxygenation, you have a margin of 10 minutes. Why do you immediately need to check for bag and mask for oxygenation? You are already oxygenated. You cannot oxygenate yourself more than 100%, right? So the idea of checking for bag and mask ventilation between induction and intubation is so that you prepare yourself for plan C. If you are able to bag mask the patient at that point of time, then you will be able to bag mask the patient if at all it turns out to be plan C of difficult airway guidelines. Can't. So he will never wake up. Ram, muscle relaxants are not something that works for eternity. Otherwise, every patient that we have induced till now for anesthesia would have always been muscle paralyzed. No? At some point of time, the action of drugs is going to wear off, right? When it wears off, then what will happen? The patient will start spontaneously breathing. Isn't it? They don't wake up by face mask ventilation. You do face mask ventilation and wake up the patient. That means you wait till the time patient starts spontaneously breathing. Yes, of course. That is exactly what I've told you. No? For intubation, you require muscle relaxants. For intubation, you require muscle relaxants. Now the next question, why do you need muscle relaxants for intubation? Why do you need muscle relaxants for intubation? I hope you understand. Sahil, Ram, I hope you understood. Okay. So we need muscle relaxants for intubation for two reasons. One, for ease of laryngoscopy. For ease of laryngoscopy. Okay, Ruchir. This is answer to what tubes are in foreign body and during ventilation need to take control over patient's respiration. Okay. And you guys are saying gag reflex, gag reflex, gag reflex. But don't you think that reflexes are already blunted by induction agents? Don't you think reflexes, you have written everywhere that they cause reflexes, loss of reflexes. चल साहिल तेरे को लास्ट में समझाता हूं मैं है ना रेस्ट एवरीबडी हैज अंडरस्टूड लेट्स मूव ऑन है ना? I'll explain it to you at the end. See, reflexes are already blunted by induction agents. So when you give muscle relaxants, that is to have ease of laryngoscopy, and second to prevent vocal cord injury. Ease of laryngoscopy and to prevent vocal cord injury. These are the two reasons why you require muscle relaxants for intubation. Otherwise, muscle relaxation is a surgical requirement. Patient not moving is something that surgeon wants. Anesthetist has nothing to do with it, right? It is not per se an anesthetic requirement. It is more of a surgical requirement, right? So let's start the discussion of muscle relaxants, and for understanding muscle relaxants, let's understand the site of muscle relaxants, which is this NMJ, neuromuscular junction. If we understand the physiology of NMJ, then the action of muscle relaxants become very easy. How is the NMJ working? The nerve impulse arrives and at a peripheral motor nerve. This causes influx of calcium, which then causes these vesicles, which are filled with acetylcholine, to fuse to plasma membrane and release acetylcholine in the junction, which will go and bind to the acetylcholine receptors, which will cause wave of depolarization, which will be transmitted through the sodium channels in the muscle, In the muscle, it causes release of calcium from sarcoplasmic reticulum, which will then cause exposure of actin and myosin, active sites on actin and myosin, which will cause muscle contraction. In the meantime, in the clefts of the NMJ, you find a enzyme called as acetylcholine esterase enzyme, which will then split acetylcholine into acetyl and choline, which will be taken up by the presynaptic nerve terminal, and this membrane will be ready with next action potential after repolarization. This is normal NMJ. This is normal NMJ. Now, based on this site of action, we have two types of muscle relaxants: NDMR, which is non-depolarizing muscle relaxants, and DMR, which is depolarizing muscle relaxants. So let's start with the discussion of the easier one, which is NDMR, non-depolarizing muscle relaxant. They are also called as curares, non-depolarizing muscle relaxants, which are also called as curares. Now, mechanism is very simple. They are competitive antagonists at nicotinic acetylcholine receptors in post-junctional muscle membrane. They are competitive antagonists at nicotinic acetylcholine receptors in post-junctional muscle membrane. Competitive antagonist at nicotinic acetylcholine receptors in post-junctional muscle membrane. What do you mean by competitive antagonist? Competitive means they are competing for the same site. Antagonist means it binds to the receptor but no action. So in the same NMJ, let's say you now have a NDMR molecule. So it will come and bind to the receptor, not let the acetylcholine bind. So no transmission of nerve impulse, and so you get flaccid paralysis. This is a very simple mechanism of action of NDMR. Simple mechanism of action of NDMR. Right? Very, very easy. Molecule will come, bind to the receptor, not do anything. When it does not do anything, the muscle is in a state of relaxation. The unique mechanism is the next muscle relaxant, which is DMR. which is only one example, that is scoline, depolarizing muscle relaxant. So whenever you think of scoline, think of acetylcholine. Now they are very similar. Why? Scoline as a molecule is also diacetylcholine. That means two molecules of acetylcholine, when they are joined, it forms choline. Just like how acetylcholine is a complete agonist, full agonist at acetylcholine receptors, choline is a partial agonist at acetylcholine receptors. It is a partial agonist at acetylcholine receptors. It's a partial agonist at acetylcholine receptors. The metabolism of acetylcholine is by acetylcholine esterase, which is present where? At the junction. Metabolism of scoline is by plasma choline esterase, which is present where? In the plasma. What is another name for plasma choline esterase? Do you know another name for plasma choline esterase? Yes, pseudocholine esterase. Any other name? Yes, butyl choline esterase. Butyl choline esterase. These two unique properties of scoline makes it a relaxant rather than a muscle contracting agent. Can you imagine somebody whose name is depolarizing muscle relaxant? Depolarization in NMJ means muscle contraction, and still it is causing muscle relaxation. Still it is causing muscle relaxation. Still it is causing muscle relaxation. Now a combination of these two will cause relaxation. Let's see how. So there are two things that you have to remember. One is that there are two types of sodium channels in the post-junctional muscle membrane. One is a junctional sodium channel. These are voltage gated. And then you have perijunctional sodium channels. These are time gated. What do you mean by a time gated channel? Time gated channel means that will open and close after a particular time. So once they are open, they will close after a particular time. They would not keep open. That is a time gated channel, while a voltage gated channel is one where there is a change of voltage that leads to opening, and it will only close when the voltage change has gone, otherwise it will be open. So the junctional channels are voltage gated, but the perijunctional channels are time gated. Perijunctional channels are time gated. So let's see what happens when the scoline molecules now arrive and they go and bind to acetylcholine receptors. What will they do? They are agonists, but they are partial agonists, right? They are partial, so they will cause partial depolarization. So instead of muscle contraction, what will we see? We will see fasciculation. We will see fasciculation. So there will be depolarization that will cause fasciculation. But the metabolism of scoline is by plasma choline esterase, which is present where? Back in the plasma. So tell me, will they cause this depolarization constantly for a long time, or will it be short? There will be persistent depolarization, right? Because it is not getting metabolized, so it will be on the receptor. Because it will be on the receptor, it will keep on depolarizing the post-junctional muscle membrane, right? So if it is continuously depolarizing, then what will happen to these perijunctional time-gated sodium channels? They will close. Because they are time gated, so after a point of time they'll close and the muscle will relax. Why? Because now the impulse is not getting transmitted. So if you have to write this thing down, then the partial agonistic action on acetylcholine receptor is responsible for muscle fasciculations, while metabolism by plasma cholinesterase is responsible for persistent depolarization. Persistent depolarization. This persistent depolarization leads to closure of time-dependent perijunctional sodium channels. Closure of time-dependent perijunctional sodium channels. Closure of time-dependent perijunctional sodium channels. Time-dependent perijunctional sodium channels. This will cause muscle relaxation. And this type of muscle relaxation that happens after an initial phase of muscle fasciculation is called as phase 1 block. It is called as phase 1 block. This type of muscle relaxation that happens after an initial phase of muscle contraction is called as phase 1 block. This is the mechanism of action of muscle relaxation. It's very, 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 very important, extremely important topic. There are a lot of questions that have been asked simply on the mechanism of action. Simply on the mechanism of action. Do you understand these two properties of scoline? First is it's a partial agonist. Second is metabolism by plasma cholinesterase. Partial agonistic action causes muscle fasciculation instead of muscle contraction, fasciculation. So that is fasciculation of individual motor units. That is very fast contraction, but that is not complete. And because it is metabolized by plasma cholinesterase, so it stays at receptor for a longer time, because the enzyme of metabolism is present in the plasma while the scoline is present at NMJ. So it will not get dissociated so easily and go and get metabolized. So because it is not getting metabolized, therefore it is staying at the receptor for a little longer. So it will keep on depolarizing the NMJ. Persistent. But inherently, this causes closure of perijunctional sodium channels because they are time dependent. So they will close after a point of time. Doesn't matter how much you stimulate the NMJ. So this will cause muscle relaxation. So despite of scoline being a partial agonist, that is a muscle contracting compound, still it causes muscle relaxation. That is because of the unique metabolism by plasma cholinesterase. Unique metabolism by plasma cholinesterase. Metabolism by plasma cholinesterase. Is it clear now? Perfect. Let's start the discussion of scoline, which is very, very interesting, very extensive and very, very important. Onset of action is ultra fast, which is 30 to 60 seconds. Duration of action ultra short, which is less than 10 minutes. How can we administer it, sir, means? Okay, so Jawahar, if you're thinking that when we inject the drug, then it will get immediately metabolized. So that is the reason why there is such a low potency drug, because a large amount of drug already gets metabolized before it reaches the site. So you're giving a larger dose. So that is why the dose is higher, so that you compensate for that metabolism and still the drug reaches the NMJ. Okay. And after how much time will depolarize the time dependent, after how much time will time dependent sodium channel be ready for depolarization? Again, after the scoline gets metabolized, it will leave the receptor and then the time dependent sodium channels will again open, because that impetus of depolarization will stop. Metabolism is by plasma cholinesterase. Excretion is renal, and dose is 1.5 to 2 mg per kg. Dose is 1.5 to 2 mg per kg. Overall, this is fastest and shortest. Overall, this is fastest and shortest. Overall, that means if you compare between all muscle relaxants, then it is fastest and shortest. Overall, fastest and shortest. Right? Indications. Now the best part about use of scoline is its ultra short duration of action, that is less than 10 minutes. So it is agent of choice for tracheal intubation. Agent of choice for tracheal intubation. Agent of choice for tracheal intubation. It is also considered agent of choice for RSI. Just write RSI and leave it. Tomorrow when we discuss RSI, then you will know what it is and why scoline is agent of choice. Right? Now the whole pretext of use of scoline is based on the fact that it acts within a very short interval of time, that is less than 10 minutes. So any factor that will cause increased duration of action of scoline is something that we have to know, and this is divided into two categories: phase 2 block and altered metabolism. Phase 2 block and altered metabolism. Altered metabolism can again be then divided into three categories: hypothermia, decrease in enzyme, and abnormal enzyme. Hypothermia, decrease in enzyme, and abnormal enzyme. Like in hypothermia, the duration of almost everything will prolong. Why? Because there is decrease in metabolism overall in general because the temperature decreases. So there will be increased duration of action of every drug. Decrease in the enzyme, that is decrease in the pseudocholinesterase enzyme, that is deficiency, is seen in conditions like liver failure, renal failure, pregnancy, and certain drugs. Example, neostigmine, cyclophosphamide, ichthyopate. This ichthyopate is a topical anti-glaucoma drug. It has been asked in question before. This has been asked in a question before. Topical anti-glaucoma drug. Topical anti-glaucoma drug. Shubhangi, whatever is left, you can ask me later. Okay? I'm not going to go to the previous slide now. Concentrate on the topic that I'm teaching. So increased duration of action of scoline can have two factors, phase 2 block and altered metabolism. Altered metabolism is seen in hypothermia, where metabolism in general decreases. Decrease in the enzyme, these are the factors that will cause decrease in the enzyme. And abnormal enzyme, that means genetic abnormality of the enzyme. For understanding this genetic abnormality, we use a concept called as Debye number, which is percentage inhibition of the enzyme by pseudocholinesterase, by Debye, percentage inhibition of the enzyme by Debye. नौरीन, बच्चे जो पढ़ा रहा हूं उस पे क्यों नहीं कंसंट्रेशन है? हैव आई टॉट फेज 2 ब्लॉक टिल नाउ? व्हाट आई एम टेलिंग यू इज व्हाट यू शुड अंडरस्टैंड ना. जब पढ़ाऊंगा फेज 2 ब्लॉक, पेशेंस. I have only written that phase 2 and altered metabolism. So let me come to phase 2. In the meantime, what I am teaching you is what you should understand and write in your notebook. Then I'll pass this. Then you will say, okay, sir, go back to previous slide. Go this, do this. I have not completed, because while I am teaching this thing, you are thinking about phase 2 block. Trust me, na? I'll teach everything. Don't worry. Won't leave anything. So we use a long-acting local anesthetic, Debye, that inhibits normal pseudocholinesterase enzyme by 60 to 70%, right? So whatever percentage of the enzyme inhibition happens with Debye, that gives us an idea about what is the type of the enzyme that we are dealing with. So percentage inhibition, also called as Debye number, even if you have missed it due to internet issues on your side, that doesn't mean that you will not do the topic that I am teaching in hand. You're getting my point. Even if you missed it, even if I taught it before and you missed it due to internet, so you want me to leave this topic and then first teach you that, or you would immediately start writing the topic in hand, and then later on when I tell you that if there is any doubt, you can ask, okay sir, I missed that part, can you explain it again? You're getting the point. I can't interrupt my class to tell you something else, even if you have missed it due to internet. Okay, so just keep this thing in mind. That tells you about the level of atypicality of the enzyme, and based on that we have the duration of action. So normal dibukane number is between 60 to 80. That means it is a normal enzyme. That means the duration of action is less than 10 minutes. Less than 10 minutes. If the dibukane number decreases, that means it's an abnormal enzyme. And initially the abnormality is heterozygous abnormality. The duration of action prolongs to almost twice, that is 20 minutes. But if it is very low, that is 20 to 40, that means almost no inhibition. That means it's an abnormal homozygous enzyme. Severe form of abnormality. Now the action can be between 1 to 3 hours. 1 to 3 hours. One to 3 hours. Right? So if you look at this table, if you look at this table and if I ask you that what information does dibukane number give you? Does it give you the qualitative assessment of enzyme function or quantitative assessment of enzyme function? Then what would be your answer? It's a qualitative assessment of enzyme function. It is a qualitative assessment of enzyme function, right? It will only tell you about the quality of the enzyme, whether it is normal, abnormal, and if it is abnormal, whether it is heterozygous or homozygous, right? It's a qualitative assessment of enzyme function, not quantitative. At any point of time, it is not telling you what is the percentage of normal and abnormal enzyme in the sample. It's a qualitative assessment of enzyme function. Right? Last is phase 2. So it's basically a complication of scoline. When you give large dose scoline, that is more than 7 to 10 mg per kg for long duration, that is more than 60 minutes, then this causes some non-specific changes in the receptor and now the block behaves like NDMR block. Block behaves like NDMR type of block. The block behaves like a NDMR type of block. Right? These are the factors that are involved in increased duration of action of scoline, and the treatment of all of them is sedation plus mechanical ventilation. Sedation plus mechanical ventilation. Sedation plus mechanical ventilation. Sedation plus mechanical ventilation. Any apnea, this is how you manage it. Sedate, ventilate. Sedate and ventilate. Alright. Next, let's look at the adverse drug reactions of scoline. Adverse drug reactions of scoline. Let's start with CVS. And since choline is a partial agonist at acetylcholine receptors, so it can cause muscarinic stimulation of SA node. This can lead to bradycardia, junctional rhythm, and ventricular ectopy. Bradycardia, junctional rhythm, and ventricular ectopy. How do you treat bradycardia? IV atropine. IV atropine. Right? Next is fasciculations, and fasciculations cause myalgia, that is muscle pain. Fasciculations cause myalgia. Now fasciculations are continuous contractions of individual motor units, and it increases the oxygen utilization, it causes myalgia. So how can you decrease the intensity of fasciculation? How to decrease intensity of fasciculation? We do it by using a defasciculating dose of NDMR. Defasciculating dose of NDMR, that is 1/10 dose of NDMR, that will block certain receptors and it will decrease the intensity of fasciculation. The agent of choice for defasciculating dose is rocuronium. The agent of choice for defasciculating dose is rocuronium. Rocuronium. I will discuss this rocuronium, why it is the agent of choice later on when we discuss NDMR. Later on when we discuss NDMR. Alright. Next is myalgia, and for myalgia it is pain, so you will give analgesics. You will give analgesics. Apart from that, there is increased ICP and IOP, masseter It's a trigger for malignant hyperthermia, histamine release, and hyperkalemia. Histamine release and hyperkalemia. Just note this thing down. I'm coming in a minute. What else will be AOC for tracheal intubation, Shubhangi? We are discussing choline, so choline will be the agent of choice. Na? Good morning, Joshi Maria Das. Very warm good morning. Okay. Now, who can tell me why should choline cause hyperkalemia? Why should choline cause hyperkalemia? Because choline is a partial agonist. Partial agonist causes depolarization. Depolarization means sodium goes inside and potassium comes outside. So when it happens in all the muscles of the body together, then there is a, under normal conditions, there is a rapid and transient rise of serum potassium by 0.5 milliequivalents per liter. Rapid and transient rise of serum potassium by 0.5 milliequivalents per liter. Is this of concern to us? Not under normal circumstances. Unless until the patient is pre-existing hyperkalemic, this small rise will not cause real problem. But problem happens when there is a chronic de-innervation injury. There is a chronic de-innervation injury. What do you mean by de-innervation? What do you mean by de-innervation? Where there is mass denervation of the muscle. That means the nerve is now not attached to the muscle. We'll see the conditions where there is denervation injury. So what happens is there is compensatory increase in the acetylcholine receptors in the muscle. Increased production of extrajunctional acetylcholine receptors. Increased production of extrajunctional acetylcholine receptors. These are leaky. These are leaky. So it causes massive release of potassium. It causes massive release of potassium, which can even cause sudden cardiac arrest. Which can even cause sudden cardiac arrest. So all the conditions where there is chronic denervation injury, there will be risk of sudden cardiac arrest with the use of choline. There will be risk of sudden cardiac arrest with the use of choline. Sudden cardiac arrest with the use of choline. So all these conditions you would avoid the use of choline. In all these conditions, you would avoid the use of choline. What are these conditions? Burn, massive trauma, spinal cord injury, stroke, GB syndrome, tetanus, prolonged total body immobilization, myopathies like Duchenne muscular dystrophy. These are the conditions where you would get sudden increase in serum potassium, and that can lead to even death. Now burns in itself presents with a unique condition, because burns patient you see at the beginning, immediately after burns, then some time after burns, and then chronic as post-burn contracture. So will you not use burns at any point of time? No. It takes time for the muscle to make these extra receptors. So it is safe to use choline in first 24 hours after burns. After that, it is unsafe up to 2 years. After that, it is unsafe up to 2 years. After that, it is unsafe up to 2 years. And all these conditions are contraindications to the use of choline. All these conditions are contraindications to the use of choline. burns, massive trauma, spinal cord injury, stroke, GB syndrome, tetanus, prolonged total body immobilization, myopathies like Duchenne muscular dystrophy. Myopathies like Duchenne muscular dystrophy. Right? Sudden and massive hyperkalemia. Sudden and massive hyperkalemia. Let me know when you have written this thing. Let me know when you're done writing with this topic. Done? Let's see now contraindications of choline. So apart from all these conditions where you cannot use choline, you should also not use it in head injury, malignant hyperthermia, open eye injury or glaucoma, hyperkalemia, myotonica dystrophica, and pediatric patients below 8 years of age. That is after burns. It is safe to use choline in the first 24 hours after burns, and then it is unsafe to use up to 2 years after burns. Class, I think 45 more minutes. 45 more minutes, Mohammed. And we have NDMRs. We'll finish NDMRs and then we'll stop for the day. These are contraindications to the use of choline. Okay. Are you done with this? Shall I move ahead to NDMRs? All right. Next we'll come to NDMRs, and NDMRs are very easy. They are very easy. You will realize now it is just an extension of their mechanism. If you have understood the mechanism, then everything else about NDMR is very easy, right? So let's finish off NDMR in shortest possible time so that we can hang up for the day, and then we'll start tomorrow at 9 a.m. right? So first is classification of NDMR, and classification is based on two things: chemical structure and duration of action. Chemical structure, benzyl isoquinoleum derivatives, benzyl isoquinoleum derivatives that can be remembered with the suffix curium, and steroidal derivatives that can be remembered as onium, and according to duration, long, intermediate, and short acting muscle relaxants, NDMRs. So a long acting benzyl isoquinoline derivative is doxacurium and DTC. Intermediate acting is atracurium and cis-atracurium, and short acting is gantacurium and mevacurium. Gantacurium and mevacurium. Steroidal long acting is pancuronium, pipecuronium. Intermediate is rocuronium and vecuronium, and no short acting steroidal derivatives. No short acting steroidal derivatives. No short acting steroidal derivatives. Whenever we have an order like this, they often ask us longest, shortest. So first shortest is gantacurium, second is mevacurium. First shortest is gantacurium, second is mevacurium. Now you will say, sir, ये क्या है first and second? Short तो short होता है. So yes, gantacurium theoretically is the shortest acting, theoretically, but it is not available in the market. It is still a research drug. So if the examiner is asking you about the theoretical thing, then he will give gantacurium in the option. But if he wants to know which is the shortest acting available in the market, that is practical use, then he will ask mevacurium. So you have to remember both. You have to remember both, right? Let's do the pharmacokinetics of NDMRs, and they are very, very easy. We can remember them by this table. It will have 7 columns: relaxant, metabolism, excretion, onset, duration, histamine release, and vagolytic action. You can make it in a page. There is nothing much to write. There is mostly notations. And this will cover all the pharmacokinetic properties of commonly used NDMRs. Let's start with the benzyl isoquinoline derivatives. Benzyl isoquinoline derivatives, cis-atra, atra, meva. Cis-atra, atra, and meva. It is shortest. It is shortest. Okay. Amongst NDMR. Overall, which is shortest? Scoline. Metabolism of cis-atra and atra is by a unique mechanism called as Hoffman's elimination, which is a non-organ dependent process. Hoffman's elimination. Onset of both of them is moderately rapid, that is 3 to 5 minutes. Duration is intermediate. There is no histamine release with cis-atracurium, but atracurium does release histamine, and they both are non-vagolytic. They both are non-vagolytic. Mevacurium is the only NDMR that is metabolized by plasma cholinesterase. Again, non-organ dependent process, so no role of excretion. Onset again moderately rapid, duration is short. Histamine release non-vagolytic. Histamine release non-vagolytic. These are 3 benzyl isoquinoline derivatives. Let's see the 3 steroidal derivatives: vecuronium, rocuronium, pancuronium. Vec, roc, and pan. Vec is metabolized by liver, excreted renally, moderately rapid onset, intermediate duration, non-vagolytic, non-histamine release. Rocuronium has no metabolism, that is excreted unchanged in bile and renal. Onset is fast, that is 60 to 90 seconds. That is only agent that has onset similar to scoline. Duration is intermediate, non-histamine release but very slight vagolytic action. And pancuronium, metabolism by liver, excretion renal, slow in onset, long in duration, no histamine release, and very potent vagolytic. Very potent vagolytic. This one table covers everything that you need to know about the pharmacokinetics of NDMR. Everything. Right? So this is a very, very precise table. And once you understand this table and you remember it, you will be able to solve all the questions related to the pharmacokinetics of muscle relaxants. Right? All right. Moving on. Indications. So indications of NDMR again can be used at three places: at intubation, for defasciculation or precurization, and for maintenance phase of relaxation. For intubation and defasciculation, your agent of choice is rocuronium. Why? Because ultra fast onset of action. Onset is moderately rapid. लिखा है ना बाबू? देखो सेम है ना, moderately rapid, similar to above. While for maintenance phase of relaxation, you need an agent that has a very predictable offset of action. So atra and cis-atra are preferred because they are intermediate in duration and have a very predictable offset of action. So atra and cis-atra. Atra and cis-atra. All right. Next is drug interactions of NDMRs. So there can be two types of drug interactions. One that will increase the potency of muscle relaxants, another that will decrease the potency. Increased potency of muscle relaxants is seen with certain antibiotics like streptomycin, amikacin, aminoglycosides, drugs like dandrolin, which are skeletal muscle relaxants, magnesium sulfate, inhaled anesthetic agents are inherently muscle relaxants. The order is desflurane has highest, followed by sevo, followed by iso, followed by aloe, and furosemide. These are the agents that will increase the potency of muscle relaxants. That means they will cause more relaxation. Then there are certain drugs that will decrease the potency of muscle relaxants like cholinesterase inhibitors, calcium, and anti-epileptics. Cholinesterase inhibitors, calcium, and anti-epileptics. Cholinesterase inhibitors, calcium, and anti-epileptics. Right? So these are drug interactions of NDMRs. Drug interactions of NDMRs. Next, we'll discuss something about individual muscle relaxants, and we know everything about them. We'll only discuss the very specific things, like for atracurium, we know that it is a benzyl isoquinoleum derivative that has a moderately rapid onset of action, intermediate duration of action. Metabolism is by Hoffman's elimination. So let's discuss metabolism of atracurium. And metabolism is by two processes. One is a non-specific ester hydrolysis and another is Hoffman's elimination. Non-specific ester hydrolysis and Hoffman's elimination. Non-specific ester hydrolysis is also a non-organ dependent process. While Hoffman's elimination is spontaneous degradation under physiological pH and temperature. So this is also non-organ dependent. So you now know that there are two ways in which atracurium gets metabolized: non-specific ester hydrolysis and Hoffman's elimination. Both are non-organ dependent, while Hoffman's elimination is spontaneous degradation of the molecule. Non-specific ester hydrolysis is non-organ dependent, right? Ames has already asked what is the individual percentage of the drug metabolized. So 2/3 metabolism is by non-specific ester hydrolysis and 1/3 is by Hoffman's elimination. This is an Ames question. That is the level of nonsense that one has to remember. Hoffman's elimination, whenever the molecule spontaneously degrades, it forms a metabolite called as laudanosine, and this laudanosine is excreted renally. So in renal failure patients, there can be accumulation of laudanosine, and this has seizure potential. This has seizure potential, and this is a theoretical concern. It's a theoretical concern. So don't say that I won't give atracurium in a renal failure patient because of laudanosine toxicity, because it is a theoretical. It has never been reported in human beings. It is just a theoretical concern. देखो कुछ चीजें क्या होती है, करनी पड़ती हैं. जैसे कि they took a rat, they punctured the kidneys, caused renal failure, and then put him on long-term atracurium infusion. And then after a long time, they found some seizure activity in the brain. So they said, okay, laudanosine toxicity has caused this. So they reported it, but that has never been seen in human beings because, one, we don't give long-term muscle relaxant infusion anymore. Second, we don't do it in renal failure patient. Third, we will not do it with atracurium. So anyway, this is not going to be reported in a human being. So remember, it is still the agent of choice for patients with renal and hepatic failure. All right. So this is about atracurium. Next is cis atracurium, which is big brother of atracurium, and it is 100% pure cis isomer of atra. It is 100% pure cis isomer of atra. 100% pure cis isomer of atra. 100% pure cis isomer of atra. Four things that differentiate cis atra from atracurium. 4 times more potent, no histamine release, no ester hydrolysis, no laudanosine toxicity. 4 times more potent, no histamine release, no ester hydrolysis, no laudanosine toxicity. 4 times more potent, no histamine release, no ester hydrolysis, no laudanosine toxicity. Let me know when you are done writing this thing. Next is rocuronium, and the first 2 letters only will tell you about it. Rapid onset. Rapid onset. It has a onset of action which is 60 to 90 seconds, which is nearest to scoline. It is fastest NDMR. Fastest NDMR. It is only NDMR that shows no metabolism. Only NDMR that has no metabolism. Only NDMR that causes pain on injection. And only NDMR that can replace scoline from RSI. Why? Because it is the only NDMR that has an onset of action similar to scoline. Scoline is 30 to 60 seconds. Rocuronium is 60 to 90 seconds. So very, very similar. Therefore, every indication of scoline can get replaced by rocuronium. Every indication of scoline can get replaced by rocuronium. Right? So these are common NDMRs that we use in our practice. Common NDMRs. So we know everything about them. Now we'll just write down to complete the list something about these old NDMRs. This old NDMRs. Replace choline from RSI. RSI. We'll discuss RSI tomorrow in complications, don't worry. Then you will know what is RSI. RSI, rapid sequence induction or intubation. Rapid sequence induction or intubation. It's a different technique of intubation. Let's discuss something about old NDMRs. Old NDMRs. The first one is the oldest, that is D-tubocurarine. First muscle relaxant to be used clinically. Maximum histamine release, blocks autonomic ganglia. Maximum histamine release blocks autonomic ganglia. First muscle relaxant to be used clinically. Remember, all these NDMRs are called as curares because they are extracted from a South American arrow poison. South American arrow poison. Second is galamine, which is most potent vagolytic and shows renal excretion. And then mivacurium, which is shortest acting NDMR that is available, releases histamine, only NDMR metabolized by pseudocholinesterase, and therefore it is considered to be agent of choice for daycare surgery. Therefore it is considered to be agent of choice for daycare surgery. Agent of choice for daycare surgery. एकदम स्लो है रफी. I'm not moving only at one place. This is just writing. I don't have to be really fast in it. Just take your time and write it. I have no problem. What second drug, beta? Galamine. Okay. So this finishes our discussion of muscle relaxants, right? Muscle relaxants. Now, if there is any doubt in muscle relaxants, then I'm waiting. You can ask me. Else we'll hang up for the day and tomorrow we'll start again at 9 o'clock with reversal of muscle relaxants and then neuromuscular monitoring. Two very, very important and very easy topics. And then from there on, we'll move on to inhalational anesthetic agents and then anesthesia delivery system and then complications. Okay. So if there is any doubt, then I'm waiting now. You can ask me any doubt if it is there. Metabolized by pseudocholinesterase. Only NDMR that is metabolized by pseudocholinesterase. Ram, what is propofol? What is propofol? Ram, what is propofol? It is which agent? This is drug interactions of NDMR. Have I written scoline? Have I written scoline, norine? बेटा हम पूरा स्कोलिन फिनिश करके पूरा एनडीएमआर स्टार्ट करके then we have discussed everything about NDMR and the fourth topic is drug interaction and you are saying drug interactions of scoline. Yes, so Ram, if propofol is the induction agent, then how is that you are asking this question that now we use propofol and instead of mivacurium? Are propofol and mivacurium the same thing? Are propofol and mivacurium the same thing? No. Propofol is induction agent of choice for daycare surgery. Mivacurium is muscle relaxant of choice for daycare surgery. Later on you will have a maintenance agent of choice for daycare surgery. So for every step of anesthesia you use a different drug and therefore for every condition you will have 3-4 agents of choice for individual uses, right? All right. हाँ साहिल भाई अब ये समझने की कोशिश करो. Do you understand that plan C we used when plan A and B will fail? Sahil? plan C will be used in difficult airway when plan A and B will fail, right? And plan C is to keep doing bag and mask ventilation, face mask ventilation till the patient wakes up and then postpone the surgery, because that is the time when you are very tensed because you have tried to intubate the patient multiple times, you failed, you tried to put an SAD multiple times, you failed. So now your patient is actually in a state where he can become hypoxic and can die. So then that at that point of time, the only thing that saves you is plan C of difficult airway guidelines. But how would you know whether you'll be able to do plan C or not? So you need to be sure that your plan C will work in time of need. So before you give muscle relaxant, see, once you give muscle relaxant, then the muscles are relaxed, then nothing can be done. So before you give muscle relaxant, you always check for bag and mask ventilation. If you are able to do bag and mask ventilation, then only you give muscle relaxants. Then only you will give muscle relaxant. Otherwise, you will then wait and then you will change your plan of anesthesia. Understood? So when I say what is the importance of bag and mask ventilation between induction and intubation, your answer should be to prepare for plan C of difficult airway guidelines. To prepare for plan C of difficult airway guidelines. Now did you understand? Now did you understand? Okay. You're not saying anything, Sahil. I'm just waiting for you. I think he left. Is it? Okay, chal. So let's hang up for today and I'll see you guys at 9 a.m. tomorrow. What did you not understand in chronic denervation? You have to first tell me what is that you did not understand. Then I'll explain that point. What is that you did not understand in chronic denervation part? What do you mean by denervation? When the nerve supply to the muscle gets denervated, that is avulsed. So there are certain conditions which cause mass denervation. So what happens? There is compensatory increase in the number of receptors that will be produced by now the muscle, because the muscle is not contracting. So the muscle feels deficient. So now it wants to make more and more receptors so that it starts contracting. So it will increase the production of extrajunctional acetylcholine receptors. And these receptors are leaky by nature. Leaky means there's a large exchange of ions across the channels. Now when you give scoline, there will be massive release of potassium because these are leaky channels. So when the scoline goes, it will cause massive release of potassium that can cause sudden cardiac arrest. So these conditions where use of scoline can cause sudden cardiac arrest are all the conditions where there is chronic denervation injury and you should avoid the use of scoline. That is what it means. That is what it means. Now did you understand? Ruchir, Zaid? Okay. So should we stop for the day? Should we stop for the day? Are you guys okay? Are there any doubts? Wonderful. So let's meet at 9 a.m. tomorrow. Thank you, Jibin. Thank you for your kind words. You're all very interactive, so even I am enjoying a lot. Ayushi, just finish this thing and let me know, then I'll hang up. Okay, thank you so much. Good night, bacha log. Bye. Okay, Zayed has. For those examples, are other causes where scoline can cause sudden cardiac. Yes, these are all the places where you have chronic denervation injury. So in all these places, there will be sudden massive hyperkalemia that can cause sudden cardiac arrest. These are all the examples of chronic denervation injury. Zayed. All right. Sure. Good night. See you guys tomorrow.